Qureshi. He is actively running and conducting various courses of family medicine. I would like to give a round of applause for our chief guests and panelists today. I would now like to invite our respected speakers to commence the scholarly talks. I request worthy Professor Dr. Zaman Sheikh, as he will be speaking on the topic, is type 2 diabetes mellitus reversible without bariatric surgery? Sir, I request you to kindly come on stage for your talk. Thank you.
Okay. Dear chairpersons, ladies and gentlemen, Assalamu alaikum. Let us begin with the name of Allah. This is my topic today, is type 2 diabetes reversible without bariatric surgery? So let us talk very important topic. There are some terms used in the management of diabetes. Number one, prevention. Other one is delay. Third one is reverse or remit. Fourth one is the cure. And last but never least is control of the blood sugar. Now they are different things. Prevention means prevent, bachao. This is divided into three types of prevention. Number one, primary prevention. Number two, secondary prevention. Number three, tertiary prevention. Primary prevention, don't let diabetes to occur. 40 साल का मर्द है, family history positive, central obesity is there, sedentary lifestyle है, no exercise, fast food, he is prone to diabetes. He is not diabetic. So with lifestyle or some medication like metformin, you stop diabetes from occurring. This is primary. Secondary, diabetes is there. Patient knows that he is diabetic, but still no complication. Prevent complication. This is secondary. Tertiary, complications are there. Retinopathy is there, but still no blind. This kidney failure is there. GFR 30 कम हो गया, but no renal failure. अभी तक dialysis पे नहीं गया. To prevent further complication, tertiary complication. अच्छा, delay है, delay the onset of type 1 and type 2 diabetes. अब delay जो है वो type 2 में possible था. DPP study ले लें, diabetes prevention program, it was possible. आप lifestyle intensify करो, some tablets like carbos, stop NITTM study, DPP4 में metformin, so you can delay the onset with two means, lifestyle and drugs. So delay was possible in type 2 only. अब एक मैजिक ड्रग आई है, जादुई ड्रग आई है और बड़ा हल्ला गुला है उस पर कि टाइप 1 डायबिटीज के लिए भी डिले पॉसिबल है. उस पर थोड़ी बात करेंगे बिकॉज देयर आर सो मेनी मिसकॉन्सेप्शन अबाउट दिस ड्रग. बहुत सारे पेशेंट पूछते हैं, फैमिली फिजिशियन पूछते हैं कि भाई अब तो डायबिटीज जड़ से ख़त्म हो गई. जड़ से ख़त्म नहीं हुई. दिस इज स्टिल अ स्वीट ड्रीम, मीठा ख्वाब है हमारे लिए अभी तक. अच्छा, रिवर्स और रिमिट द डायबिटीज़, ये अलग टर्म है. इसका मतलब है डायबिटिक पेशेंट है 5 साल 10 साल पक्का डायबिटिक, ही इज़ ऑन टेबलेट्स, ही हैज़ डेवलप्ड माइट हैव सम कॉम्प्लिकेशन, इन्वेस्टिगेशन पे भी पक्का डायबिटिक है. उसको इतना रिवर्स करना कि विदाउट एनी टेबलेट शुगर कंट्रोल हो जाए कपल ऑफ ईयर्स, उसको कहते हैं रिवर्सल. तो आज हम उसकी बात करेंगे. देन क्यूर मीन्स जड़ से ख़त्म कर देना, पेनक्रियाटिक ट्रांसप्लांट, स्टेम सेल थेरापी एंड सो ऑन. बट आई टेल यू, अभी तक ये ड्रीम है और आइंदा 10 साल तक भी ड्रीम रहेगा. कोई पॉसिबिलिटी नहीं है. पेनक्रियाटिक ट्रांसप्लांट होते हैं, क्यों नहीं होते, जिस तरह किडनी ट्रांसप्लांट होता है. बट आफ्टर पेनक्रियाटिक ट्रांसप्लांट यू हैव टू गिव सो मेनी इम्यूनोसप्रेसिव ड्रग्स विच आर वेरी एक्सपेंसिव, वेरी टॉक्सिक. तो जब कहा कि पूरी उम्र दवाएं लेनी है, महंगी है, तो बेहतर है कि फिर शुगर को रहने दो. तो क्योर अभी तक हमारा ख्वाब है. कंट्रोल द डायबिटीज़, ये कंट्रोल हमें करना है, शुगर कंट्रोल करनी है. दिस इज़ पॉसिबल एंड दिस इज़ व्हाट वी आर डूइंग नाउ इट इज़ कंट्रोल. उसमें भी हम फेल हो गए हैं बहरहाल. अच्छा, उस जादुई दवा का नाम है टेप्लीज्यूमेब और ट्रेड नेम है इसका टीजील्ड. दिस इज anti-CD3 मोनोक्लोनल. 2-3 स्लाइड दिखाता हूँ टू रिमूव सम मिसकॉन्सेप्शंस कि भाई अब शुगर का तो इलाज आ गया, जड़ से नहीं आया. इट इज़ अप्रूव्ड रिसेंटली बाय FDA एज अ फर्स्ट डिजीज मॉडिफाइंग एजेंट. रूमेटॉइड आर्थराइटिस में होता है ना कि डिजीज मॉडिफाइंग एजेंट, अब डायबिटीज में भी आ गया है. फॉर 8 year एंड ओल्डर एंड हु आर एट रिस्क ऑफ डेवलपिंग दिस कंडीशन. अब देखें, टाइप 1 डायबिटीज़ के 3 स्टेजेस हैं. स्टेज 1 है कि एंटीबॉडीज़ आर देयर, मोर देन 2 एंटीबॉडीज़ आ गई, होने वाली है, मगर किसको पता कि एंटीबॉडीज़ हैं. स्क्रीनिंग वेरी डिफ़िकल्ट. बहरहाल स्टेज 1 है कि एंटीबॉडीज़. स्टेज 2 है कि एंटीबॉडीज़ तो वही रहेंगी, बढ़ गई, मगर अब डिसलिपिडीमिया भी साथ स्टार्ट हो गया. ब्लड शुगर स्टार्टिंग बिहेविंग एबनॉर्मल, मगर अभी तक क्लिनिकल नहीं हुआ है, उसको सिम्टम पैदा नहीं हुए हैं. और जब तक सिम्टम नहीं होंगे किसको पता कि टाइप 2 डायबिटिक है. आपका बॉर्डर लाइन शुगर है तो ये स्टेज 2 है कि डिसग्लाइसीमिया है, फुल ब्लोन टाइप 2 डायबिटीज अभी नहीं है. एंड दिस इज द टाइम वेयर दिस ड्रग शुड बी गिवन. स्टेज 3 और इसमें है कि रोल ऑफ स्टेज 3 में फुल डायग्नोसिस, टिपिकल जो टाइप 1 के होते हैं, पॉलीयूरिया, नॉक्चूरिया, डिसयूरिया, नॉक्चूरिया एंड पॉलीयूरिया, पॉलीफेजिया एंड सो ऑन. बट वेट, इतना आसान नहीं है. देयर आर 2 प्रॉब्लम्स. नंबर 1, कॉस्ट. कैन यू इमेजिन व्हाट इज द कॉस्ट ऑफ दिस न्यू ड्रग. एक इमेजिन करें کتنے ہزار روپے کی, کتنے ہزار ڈالر کی. کورس آف ٹریٹمنٹ جو 14 دن کا 14 ڈیز کا ہے, ڈیلی آئی وی انجیکشن فار 14 ڈیز, $0.2 ملین, 2 لاکھ روپے 2 ہفتے کی. تو کل میں نے کیلکولیٹر کیا, $2.4 تھا, تو پتہ چلا کہ 4.5 کروڑ روپے ایک کورس ہے. جو نئی دوا ہے ابھی تک زیادہ پتہ نہیں ہے. سو اسٹل اٹس اے ڈریم, یہ خواب ہے, اور خدا کرے یہ دوا سستی ہو, پاکستان میں آئے. ابھی تو امریکہ میں بھی نہیں آئی. فرسٹ جو پارٹ ہے اگلے سال کا جنوری فیبروری میں شاید لانچ ہو جائے. FDA ہیز اپرووڈ. اچھا, دوسرا اسکرین کس کو کریں گے آپ؟ اب GTM میں تو اسکرین کرنا آسان ہے نا, جو پریگننٹ ہے اس کو اسکرین کر دو. ایک سب گروپ ہے نا, اس میں کس کو اسکرین کریں گے؟ اتنے لاکھوں کروڑوں بچے ہیں دنیا میں. تو ابھی تک یہ کریں کہ جس کی فرسٹ ریلیٹیو ڈگری جو ہے نا, جن کو ٹائپ 1 ڈائبٹیس ہے, اس کو اسکرین کریں, کیونکہ وہ زیادہ چانسز ہوتے ہیں اس کی. مگر 90% کو ٹائپ 1 ڈائبٹیس کے ریلیٹیو کو ڈائبٹیس نہیں ہوتی. فیملی ہسٹری پازیٹیو اگر اسٹرانگ ہے تو ٹائپ 1 ہے یا ٹائپ 2؟ ٹائپ 2 ہے. یہ فیملی ہسٹری اسٹرانگ ہو تو ٹائپ 1 کی فیور میں نہیں جاتی پوائنٹ. تو مسئلہ یہ ہے کہ 90% کا تو پتہ ہی نہیں ہے فیملی ہسٹری کا. تو یہ ابھی کوشچن ہے کہ کس کو آپ اسکرین کریں گے بیفور ڈیولپنگ کلینکل ٹائپ 1 ڈائبٹیس. چلیں اپنے ٹاپک پہ آتے ہیں. از ریورسیبل آف ٹائپ 2 ڈائبٹیس پاسبل؟ اب کرنٹلی 488 ڈرگس استعمال ہو رہی ہیں دنیا میں فار دا مینجمنٹ آف 228, اور مور دین 24 آر ویٹنگ فار دا لائسنس. آ گئی ہیں لائسنس, FDA اپروو کرے. اور مچ مور پائپ لائن میں تو بے شمار ہیں دوائیں. اس کے باوجود وی آر فیلنگ. کہاں ڈائبٹیس کو کنٹرول کر سکے ہیں؟ 4 سال پہلے پاکستان 11ویں نمبر پہ تھا. ہم سوچ رہے تھے کہ بھئی 30 سال کے بعد 11ویں سے 4تھے نمبر پہ آئے گا. اب پتہ چلا کہ 4 سال میں 11ویں نمبر سے 3rd پوزیشن پہ آ گیا پاکستان. کہاں گئی اسٹیٹسٹک؟ اے سچ اے ریپڈلی ڈیولپنگ ڈیزیز, ناٹ اونلی ان پاکستان, آل اوور دا ورلڈ. تو اس پہ ہمیں سوچنا پڑے گا ریورسل پہ. اچھا, یہ ٹاپ 10 وہ ہیں گوگل پہ سرچ کرتے ہیں نا, تو گوگل ریکارڈ کرتی جاتی ہے. یہ 10 وہ ہیں جس پہ لوگوں نے کلک کیے گوگل پہ. ٹاپ موسٹ کس پہ کلک کیے کہ ریورسل پاسبل ہے یا نہیں ہے, کیور پاسبل یا ہے یا نہیں. تو ٹوڈے وی آر ٹاکنگ اباؤٹ دا موسٹ برننگ ٹاپک آف ڈائبٹیز. اچھا جی, سم پیپل وتھ ٹائپ 2 ڈائبٹیز کین بیکم نان ڈائبیٹک اگین, ایٹ لیسٹ فار اے پیریڈ آف ایئرس. دیٹ از کالڈ ریمیشن, ریورسل. اٹ از ناٹ اے کیور. گرین پہ جائیں. ریمیشن allows a patient to stop all the medication, oral, insulin, ساری بند, کوئی ہے نہیں. بیکاز دیز ڈرگس آر ایکسپینسو, ہمیں پتہ ہے, انکنوینئنٹ ہے. کوئی 5 منٹ پہلے کھاؤ, 10 منٹ بعد کھاؤ, بیچ میں کھاؤ. ایکسپینسو, انکنوینئنٹ. سائڈ ایفیکٹ ہر دوا کے ہیں. کوئی دوا شوگر کی مجھے بتا دیں کہ جس کا سائڈ ایفیکٹ نہیں ہے. اچھا, لاسٹ بٹ ناٹ لیسٹ, کمپلیکیشن. جب شوگر ہی نہیں ہوگی تو کمپلیکیشن کہاں ہوگی؟ تو یو کین پریونٹ کمپلیکیشن بائی ریورسل. آکیوپیشن. اب دیکھیں نا, سم آکیوپیشنز آر ویری امپارٹنٹ ان ریلیشن وتھ ڈائبٹیز. پائلٹ کو میٹ فارمن سے آگے کی دوا کی ضرورت پڑے تو اس کو گراؤنڈ کر دیتے ہیں. بھائی یو کی ناٹ فلائی. گراؤنڈ, پوری زندگی کی تجربہ, محنت, امتحان, ایکسپیرینس سب ختم, گراؤنڈ کر دیا پائلٹ کو. اب جب ریورسل ہو گئی تو جاؤ بھائی پھر جہاز سے اڑاؤ. تو کتنی امپارٹنٹ بات ہے. ہیوی مشینری, ڈرائیورس, یہ وہ شوگر جب خراب ہو تو گاڑی نہیں چلا سکتے اصولی طور پہ, تو واپس بیک ٹو دیئر جاب. پھر کاسٹ, نہ صرف دوائیں, انویسٹیگیشن کرانی پڑتی ہیں, کنسلٹیشن ڈاکٹر کی فیس ہے. ڈائبٹیز از ون آف موسٹ ایکسپینسو ڈیزیز. میرا خیال ہے کینسر کے بعد ڈائبٹیز ہے جو سب سے مہنگی ہے علاج اس کا. تو آپ کاسٹ بچا لیں. نو ڈرگ, کوئی دوا کی ضرورت ہی نہیں ہے. اچھا, کوالٹی آف لائف, یہ اتنا بہترین ورڈ ہے. کوالٹی آف لائف کیا ہے بھائی؟ آپ کیسے ہو؟ اللہ کی مہربانی سے خوش ہوں. یہ کوالٹی آف لائف. وہ بھائی پاکستان کی تو کوالٹی آف لائف پتہ ہے کیا ہے ہمیں. تو کوالٹی آف لائف امپروو ہو جاتی ہے اگر شوگر ریورس ہو جائے تو. سوشل اسٹگما, ارے بھائی اس کو تو ڈائبٹیز ہے, شادی میں سلاد کھاتا رہتا ہے, یہ ختم. تو کہنے کا مطلب ہے ریورسل از اے بلیسنگ. اب دیکھیں یہ میل فیمیل جنس کو ڈائبٹیز ہو جائے نا تو میل کو کی لائف ایکسپیکٹنسی 5 سال کم ہو جاتی ہے. ویسے اگر 70 سال جیے گا جینیٹیکلی اب وہ 65 میں اس کا انتقال ہوگا, اسٹیٹسٹک ہے. اور 6 سال عورت کی لائف ایکسپیکٹنسی کم ہو جاتی ہے, تو ریورسل ہو گئی تو بیک ٹو نارمل 5 سال اور جیے گا. اچھا جی, ویٹ گین از دا مین ڈرائیور آف ٹائپ 2 ڈائبٹیز. جتنا آدمی اوبیز ہوگا اتنی ڈائبٹیز بڑھتی جائے گی, اس میں کوئی شک ہی نہیں ہے. اب پہلی دفعہ ریورسل کا پتہ چلا جب بیریاٹک سرجری آئی. پہلے ہم سوچتے تھے کہ بھئی شوگر اگر ایک دفعہ ہو گئی تو زندگی کے آخری دن تک چلے گی, جو صحیح ہے. ہم کہتے تھے کہ بھئی شوہر چھوڑ سکتا ہے بیوی کو, بیوی چھوڑ سکتی ہے شوہر کو, شوگر آپ کو نہیں چھوڑے گی. اب یہ کہاوت غلط ہو گئی, اب چھوڑ سکتی ہے. اچھا, بیریاٹک سرجری نے پہلی دفعہ بتایا کہ بھئی ریورس ہو سکتی ہے. حالانکہ وہ موٹاپے کے لیے تھی, مگر پتہ چلا کہ شوگر جڑ سے ختم ہو گئی فار 5-6 ایئرس. اور یہ تھوڑی سی اسٹڈی ہے ڈیپ میں, آپ بھی نہ جائیں میں بھی نہیں جاتا ہوں, ٹائم نہیں ہے. 75% ریمیشن ہو گئی اس اسٹڈی میں, 78% ریمیشن ہو گئی دوسری اسٹڈی میں, اور یہ تیسری اسٹڈی ہے. اس میں آپ دیکھیں کہ ہو گیا کنٹرول گروپ میں صرف 13%. تو 73 کا یاد رکھیں, 73% ریورسل ہے آفٹر بیریاٹک سرجری, وچ از اے گڈ نیوز. تو فزیشین کو جوش آ گیا کہ بھئی جب سرجن کر رہے ہیں تو وہی چیز اگر ہم کریں تو ریورس ہو جائے گی ڈائبٹیز. کیا کریں؟ موٹاپا کم کریں, ناٹ وتھ اینی ڈرگ, کوئی دوا نہیں دیں, صرف ڈائٹنگ پہ رکھیں. ہم کتنی ڈائٹنگ؟ 500 سے 700 کیلوری پر ڈے. تو دیکھیں کیا ہوتا ہے. اب اس اسٹڈی کا نام تھا ڈائریکٹ اسٹڈی. یہ پہلی اسٹڈی تھی اس ٹاپک پہ کہ موٹاپے کے ساتھ ساتھ ڈائبٹیز ریورس ہو سکتی ہے نہیں ہو سکتی. یہ گلاسکو یونیورسٹی میں مائکلین اور رے ٹیلر, نیو کیسل اپان ٹائم, انگلینڈ میں, ان دونوں نے مل کے یہ اسٹڈی کی, پہلی اسٹڈی. اس کے بعد اور بھی اسٹڈی آ چکی ہیں. اچھا, ایم کیا تھا کہ ٹو اسیس ویدر انٹینسو ویٹ مینجمنٹ وتھ روٹین پرائمری کیئر, فیملی فزیشین کے کیئر میں کلینک میں بیٹھے رہیں. یہ وہ ڈبل بلائنڈ پلیسیبو کنٹرول اسٹڈی نہیں تھی, ریئل لائف اسٹڈی تھی. اور اس میں جی پی نے کی اور انڈر کیئر. اب پتہ چلا کہ جنہوں نے انٹرونشن کی وہ ٹارگٹ اچیو کر لیا 15 kg, اور ساتھ ساتھ کنٹرول میں دیکھیں اب رزلٹ آنا شروع ہو گئے. یہ اس کا ہے پروٹوکال. اچھا دیکھیں, یہ ٹوٹل ڈائٹ ریپلیسمنٹ انہوں نے کیا کیا کہ پہلے 3 مہینے ان کو جوس دیے, جوس, سوپ دیے, سوپس, شیک, کھانا نہیں دیا 3 مہینے, اور اسٹینڈرڈ ہوموجنائز بلینڈر میں ڈال کے اسپیشل سوپ بنائے. کیوں بھئی 500 کیلوری آپ ویسے بھی کہہ سکتے ہو نا کیلکولیٹ کر کے کہ اتنا مٹن کھاؤ, اتنا رائس کھاؤ, اتنا چپاتی کھاؤ, اتنا کر سکتے تھے. کیوں نہیں کیا؟ اس لیے نہیں کیا کہ اگر اس طرح کرتے تو کوئی پروٹین زیادہ کھا لیتا, کوئی کاربوہائیڈریٹ زیادہ کھا لیتا, کوئی کمپلیکس کاربوہائیڈریٹ, کوئی فری کاربوہائیڈریٹ, کوئی مونو انسیچوریٹڈ فیٹ زیادہ کھا لیتا. پتہ نہیں چلتا نا کہ یہ فائدہ لو کیلوری سے ہے یا پروٹین زیادہ کھائیے اسے ہے. تو ہوموجنائز 3 مہینے یہ شیک دیے, اور اس کے بعد 3 مہینے کے بعد گریجولی کھانا کھلانا شروع کیا. 1 سال کی اسٹڈی تھی. یہ اس طرح کے شیک بنائے تاکہ ہر ایک کو ایک جیسی کیلوری, وٹامن, پروٹین ایک جیسی ملے, سب کو بایاس نہ ہو. اچھا دیکھیں, ویٹ سب کا گر گیا, ریٹ لائن, مگر جنہوں نے ڈراپ آؤٹ کیے ان کا ویٹ بڑھنا شروع ہو گیا. تو کنسسٹنسی از امپورٹنٹ. اچھا, اب یہ دیکھیں پرائمری کیئر تھے, پرائمری آؤٹ کم تھے 2. ایک ہمارا کہ ویٹ لاس ہوا یا نہیں ہوا, دوسرا ریمیشن ہوئی یا نہیں ہوئی. اب یہ رزلٹ دیکھیں, پی ویلیو 0.001. جتنے 0.0 بڑھتے جائیں گے پی ویلیو میں اتنا اسٹرانگ ہوتا جائے گا. تو ویری اسٹرانگ رزلٹ. اس کا بھی دیکھیں, ریمیشن کا بھی اسٹرانگ رزلٹ. اچھا, HbA1c 5.6 سے نیچے گر گئی آف آل دی ڈائبٹک اینڈ اینٹی ہائپرٹینسو ٹریٹمنٹ, کو بغیر دوا کے. پہلے 1 سال کا کیا, پھر 2 سال کی بڑھا دی. اچھا, یہ ہے ریمیشن بائی دیکھیں نا 10 کے جی لاس کے بعد بینیفٹ اسٹارٹ ہو گئے، مگر پیک بینیفٹ ملے 15 کے جی کے بعد، اور دونوں کو ملائیں تو 73۔ اب آپ یاد کرو 73 بیریاٹک سرجری میں بھی تھا، بالکل ایگزیکٹ جو میڈیکل فزیشین نے کیا 73% ریمیشن اچیو ہو گئی، وچ از اے گریٹ نیوز۔ پہلے 1 سال کا تھا، اب 2 سال تک بینیفٹ قائم رہا۔ Not only weight loss, not only remission of sugar, مگر HbA1c, oral hypoglycemic agent, anti-hypertensive treatment, triglyceride, quality of life، یہ سب بہتر ہو گئے، پی ویلیو سب کی دیکھیں اسٹرانگ گئے۔ کوالٹی آف لائف کو اگنور نہ کریں آپ۔ کوالٹی آف لائف کا مطلب ہے سر میں ابھی تک ٹھیک نہیں ہوں، مجھے تکلیف ہے، مجھے زندگی میں مزہ نہیں آ رہا ہے، اور دوسرا کہے گا اللہ کی مہربانی سے آپ کی دواؤں سے آپ کی علاج سے میں بہت بہتر ہوں۔ اچھا جی، بی پی آلسو فیل ڈاؤن، بلڈ پریشر پہ بھی فائدہ ہوا، سسٹولک ڈائسٹولک۔ کوالٹی آف لائف کو ایسے نہیں کہا کہ بھئی کیا حال ہے تمہارے، اس طرح نہیں، اسٹیٹسٹیکلی۔ کل تو پورا سائیکاٹرسٹ کا دن تھا، پتہ نہیں آج بھی کوئی سائیکاٹرسٹ شاید بیٹھے ہوں ادھر، باقاعدہ اسکیلنگ کر کے کوالٹی آف لائف کو پروو کیا۔ اچھا، ڈائریکٹ اسٹڈی واز کنڈکٹیڈ ان ریئل لائف پرائمری سیٹنگ۔ ریئل لائف کا مطلب ہے کہ آپ کلینک کرتے رہو، اس کے ساتھ ساتھ اسٹڈی کرو۔ اور دوسرا ہوتا ہے آرٹیفیشیل انوائرمنٹ، وہ مہنگی بھی ہوتی ہیں، ڈبل بلائنڈ پلیسیبو کنٹرول ٹائپ، یہ وہ بالکل یعنی کلینک میں بیٹھ کے فیملی فزیشین نے کی۔ بٹ دس واز لمیٹیڈ ٹو یو کے پاپولیشن، یونائٹیڈ کنگڈم میں تھی صرف۔ تو ایسی اسٹڈی پاکستان میں چاہیے، بیکاز وی پاکستانیز آر مور ولنریبل فار ٹائپ 2 ڈائبٹیز۔ اچھا جی، اب ایک $1 ملین کا کوشچن آ رہا ہے، کتنی پرسینٹ ڈائبٹک پیشنٹ اوبیز ہوتے ہیں ٹائپ 2، بتائیں گیس۔ 90%۔ 90% اوبیز ہوتے ہیں، تو جتنا موٹا اتنا ڈائبٹیز، موٹا رف ورڈ ہے، ٹھیک ہے کہہ لیتے ہیں، ہر ایک کو پتہ ہے موٹے آدمی کو زیادہ ہوتی ہے، مگر 10% موٹے نہیں ہوتے، دبلے پتلے ہوتے ہیں، ان کو ٹائپ 2 ہوتی ہے، اورل پہ وہ ٹھیک ہو جاتے ہیں، ڈرگ پہ انسولین کی ضرورت نہیں پڑتی، کیٹونیوریا نہیں ہوتی، وہ کہاں جائیں، ان کو کیا کریں؟ تو ڈائریکٹ اسٹڈی کے بعد ایک اور اسٹڈی کی گئی، ری ٹیون نے رے ٹیلر کا نام بتایا نا، جو نیو کیسل میں تھا، اس نے اسٹڈی کی۔ اس نے کیا، اس کی ایک پوسٹنگ ہوئی، وہاں کا MRI یونٹ تھا، وہاں پہ وہ ڈائریکٹر بن گیا، ایڈیشنل اس کو چارج دے دی کہ بھئی یہ چلاؤ، جس طرح پاکستان میں کرتے ہیں ڈبل ڈیوٹی۔ تو اس نے ایک نئی مشین اس زمانے میں آ گئی، MRI کی نیو مشین لیٹسٹ، جو پاکستان میں ابھی تک نہیں آئی۔ اس نے پینکریاٹک فیٹ بھی کیلکولیٹ کیا، سچ اے سینسٹیو مشین، پینکریاٹک فیٹ۔ تو اس نے دیکھا کہ بھئی پینکریاس میں بھی فیٹ ہے۔ اب ہم کس کی بات کریں؟ وسرل فیٹ، توند نکلی۔ سیکنڈ، فیٹی لیور، نان الکولک فیٹی لیور۔ پینکریاس فیٹ کی کوئی بات ہی نہیں کرتا، اس نے کہا بھئی یہ تو پینکریاس میں بھی فیٹ ہے، اور جو سلم ٹائپ 2 ڈائبٹک پیشنٹ تھے ان کو پینکریاس میں فیٹ تھا۔ تو اس نے کہا چلو وہی 500-700 کیلوری والی ان دبلو پتلے جو 27 BMI سے کم تھے، ان میں بھی ایک تجربہ کر کے دیکھیں۔ تو اس اسٹڈی کا نام ہے ری ٹیون اسٹڈی، وہ انہوں نے بنائی، اور اس میں دیکھا کہ وہی لو کیلوری ڈائٹ کین ہیلپ نان اوبیز، جو 10% ہے، پیپل وتھ ٹائپ 2 ڈائبٹیز وتھ دس کنڈیشن۔ تو اس میں بھی دیکھیں عجیب بات ہے کہ 75% آف نارمل ویٹ ٹائپ 2 ڈائبٹک پیشنٹ دی اچیو ٹائپ 2 ریمیشن۔ تو اس میں بھی فائدہ ہو گیا بیکاز آف پینکریاٹک فیٹ۔ تو فیوچر میں آپ لیور فیٹ کی جگہ فیٹی لیور کے ساتھ ساتھ پینکریاٹک فیٹ کا بھی ذکر سنیں گے۔ اچھا، یہ سیکنڈری اچیومنٹس ہیں، ڈکریز ان ویٹ، ٹوٹل باڈی فیٹ، فاسٹنگ بلڈ شوگر HbA1c، فاسٹنگ پلازما انسولین، ٹرائیگلائسرائڈ، لیور فیٹ ایز ویل ایز پینکریاٹک فیٹ، سب میں فائدہ ہوا ری ٹیون اسٹڈی میں۔ اچھا، ری ٹیون اسٹڈی ڈائریکٹ اسٹڈی تھی، مور دین 25 BMI، جو یورپین امریکن کٹ آف پوائنٹ ہے، ہمارے یہاں 23 ہے، وہاں 27 ہے۔ تو ری ٹیون میں لیس دین 27، اور لیور اور پینکریاس دونوں کے فیٹ کم ہو گئے۔ اب یہ دیکھیں، یہ 2 سلائڈس ہیں، نیچے ہے پینکریاٹک فیٹ کنٹینٹ کم ہو گیا، اس کے ساتھ ساتھ فرسٹ فیز انسولین ریلیز بہتر ہو گئی۔ فرسٹ فیز ریلیز بہتر ہوئی کا مطلب کیا ہے کہ بیٹا سیل نے فنکشن دوبارہ اسٹارٹ کر دیا, ریمیشن ہو گئی, ویری امپورٹنٹ سلائڈ. ساتھ ساتھ لیور فیٹ کو بھی فائدہ پہنچ گیا. اچھا دیکھیں, یہ اوبیسٹی ہے. اوبیسٹی ہم بدقسمتی سے پاکستان میں جتنا اوبیز آدمی ہو اس کو ہم سمجھتے ہیں کہ یہ ہی از اے رچ پرسن, ہی از اے پاورفل پرسن. دبلے پتلے کو کوئی لفٹ ہی نہیں کراتا. وڈیروں کا یا زمینداروں کا فلموں میں جب بھی کوئی رول دیتے ہیں, ہمیں ہمیشہ آپ نے دیکھا ہوگا سب سے جو اوبیز ہے اس کو دیتے ہیں تاکہ روبدار نظر آئے. تو ہمارے ہاں بچہ جتنا موٹا ہوگا گول مٹول, وہ ماں کہے کہ یہ ہیلتی ہے. ارے بھائی وہ بیمار بچہ ہے, اس کو ڈائبٹیز ہونے کے خطرے ہیں, اس کو بلڈ پریشر ہونے کے خطرے ہیں, کولیسٹرول اس کا خراب ہوگا, جوڑوں کا درد ہو جائے گا, ہی از پرون ٹو سم کینسرز. دبلا پتلا چاہے ایکٹیو ہو, ماں سمجھے کہ یہ بیمار بچہ ہے. تو ہمارے ہاں بدقسمتی سے یہ الٹا ہے کہ موٹے کو ہم ہیلتھی سمجھتے ہیں. اب دیکھیں نا, یہ پرسنالٹی ہے, یہ اور یہ ان سے ملو تو ہم کہتے ہیں کہ یار آپ سے مل کے خوشی ہوئی مگر مجھے ضروری کام سے جانا ہے. ان سے ملو تو کہتے ہیں کہ دنیا کے کام تو ہوتے رہتے ہیں. مطلب یہ پرسنالٹی بہتر ہو جاتی ہے اگر آپ آدمی دبلا پتلا ہو جائے, مگر یہ صرف پرسنالٹی نہیں ہے, دس از ڈیزیز. امریکہ اور یورپ میں اس کو ڈیزیز لیبل کیا گیا ہے. انشورنس کمپنیاں ٹربل میں آ گئی ہیں کہ اگر ڈیزیز ڈکلیئر کر دیا تو پھر ہمیں انشورنس میں اینٹی اوبیسٹی ڈرگس جو بہت مہنگی ہیں وہ بھی فری میں دینی پڑیں گی. تو اٹ از اے ڈیزیز ناٹ اونلی لائف اسٹائل. کیوں کہ صرف 0 to 5% ویٹ لاس کرو تو ہائپر ٹینشن اور ہائپر گلائسیمیا میں فائدہ ہوگا. 5 to 10% لوز کرو تو پریونشن آف ٹائپ 2 فیٹی لیور, پالیسسٹک اوورین سنڈروم اینڈ سو آن. 15% کرو تو کارڈیوواسکولر بینیفٹ, یورینری اسٹریس انکانٹیننس, نیش, آسٹو آرتھرائٹس. مور دین 50 کرو تو ٹائپ 2 ریمیشن اچیو ہو جائے گی. دیکھیں نا, یہ اٹس اے ڈیزیز. اچھا, یہ لائف ایکسپیکٹنسی ہے. میں نے کہا 5 سال مردوں میں, 6 سال عورتوں میں کم ہوتی ہے. اب یہ دیکھیں کہ واپس بیک ٹو نارمل لائف ایکسپیکٹنسی از گڈ از نارمل پیپل. اچھا, یہ میری آخری سلائیڈ ہے. ریمیشن شوڈ ناؤ بی اے پرائمری ایم آف ڈائبٹیز کیئر. اب آپ پریونشن پہ پلیز توجہ دیں. ڈائٹ, لائف اسٹائل, کہنا آسان ہے کرنا مشکل ہے, آئی نو. 6 دن آپ ڈائٹنگ کراؤ, 1 دن ولیمہ کھلاؤ پاکستانی, وہ 6 دن کی ڈائٹنگ اللہ کی مہربانی سے ختم ہو جائے گی. تو پرسسٹنسی چاہیے اس کے لیے. آلموسٹ ہاف کین اچیو ریمیشن, 73% پھر مور دین جو اسٹیٹسٹک بالکل بیریاٹک سرجری جیسا فائدہ لے سکتے ہیں. اوور 15 kg لاس از ناٹ نیسیسری. زیادہ جذباتی نہ بنے. آفر آپٹیمل نان سرجیکل ویٹ مینجمنٹ, نان سرجیکل مینس بیریاٹک سرجری ارلی before prescribing more and more drugs and long before considering bariatric surgery. اب اگین $1 million کوشچن آتا ہے کہ از اٹ پاسبل ٹو اچیو سیم ریزلٹ آفٹر بیریاٹک سرجری؟ یس اور نو؟ اف یس دین واٹ بیریاٹک سرجن ول ڈو ان فیوچر؟ وہ کیا کریں گے؟ یہ کرنا پڑے گا ان کو. تھینک یو. کوشچن آخر میں ہوں گے شاید لاسٹ.
Thank you very much, Professor Dr. Zaman Sheikh, for your valuable addition in our knowledge regarding diabetes mellitus. I want to inform you all that we are coming live from LUMHS FM 96.6 and LUMHS TV. The next speaker, I would like to call him by reciting a poetry that is, دَوائیں دیتا ہوں تشخیص کر کے سب کا مرض. دوائیں دیتا ہوں تشخیص کر کے سب کا مرض. میں رنج و یاس و علم کا طبیب تھوڑی ہوں. اس شعر کے خالق and our next speaker, Professor Dr. Muhammad Iqbal Shah, I would request you to come on stage and give your lecture on approach to joint pain.
Bismillahirrahmanirrahim. My respected teachers, students and faculty members, Assalamu alaikum wa rahmatullah wa barakatuhu. Today, it's a great honor for me to deliver a lecture in family physician session on joint pain. Joint pain is one of the common symptoms, and more than 100 rheumatological diseases are associated with the joint pain. Sometimes it's easy to diagnose the cause of joint pain, and sometimes there is overlapping, so difficult to diagnose the cause of the joint pain. The clinical history and examination make the diagnosis of joint pain possible into the 60 to 70% of the patient, and no doubt then we'll go for the investigation to confirm the diagnosis. So, joint pain could be arthralgia, only pain in the joints, and arthritis pain along with signs of inflammation including redness, warmth, and swelling. This difference is very important. Now, in arthritis, there is joint pain. Arthralgia, there is joint pain. Arthritis is inflammatory, while arthralgia is non-inflammatory. In arthritis, there is limitations in range of movement. In arthralgia, there is pain without swelling. Arthritis is associated with the stiffness, and while arthralgia is associated with the achiness. So, causes of the joint pain could be inflammatory. For example, rheumatoid arthritis could be cartilage degeneration, and one of the classical examples for the cartilage degeneration is osteoarthritis, crystal deposition, for example, gout, infection in case of septic arthritis, and trauma. So these are the few basic mechanisms which can give rise the joint pain. Now there may be a monoarticular, only one joint is involved, oligoarthritis that affects the 2 to 4 joints, and polyarthritis affecting 5 or more joints. This slide is important because peculiar diseases sometimes associated with the monoarthritis, sometimes associated with the oligoarthritis, and some disease classically present with the polyarthritis. So, pattern of the pain, occurrence of the pain, only with the activity suggesting a mechanical problem. For example, the classical example of the pain on movement or activity is osteoarthritis. Pain at the rest suggesting inflammation, septic arthritis, crystal-induced arthritis. There may be and may not be fluid within the joint cavity, effusion. So, pathophysiology of joint pain. Joint pain may arise anatomically from structures within the joint. So, intra-articular structures as well as extra-articular structures can lead to the generation of the pain. So, joint pain could be because of the involvement of the joint capsule, periosteum, ligaments, subchondral bone, and synovium. The structures adjacent or around the joint, periarticular structures, for example, bursa, if the bursa is involved, known as the bursitis, tendon sheath, tenosynovitis, tendon, tendinitis, insertion of tendon, ligaments, enthesitis, and extraarticular articular disorders, for example, fibromyalgia and the polymyalgia rheumatica. So, distant disorders can also present with the joint pain, but the pathophysiological mechanism is different. For example, in case of fibromyalgia, there is decreased threshold to pain that lead to the joint pain. Referred pain from one a more distant site, for example from bone. So synovitis is, this picture shows the synovial membrane is the principal site of formation in persons with rheumatoid arthritis and many other inflammatory conditions. So you can see here in the figure, in the there is ulnar deviation and in cross section, cut section view of the knee joint, femur, synovial fluid, patella. You can see here the synovial membrane, the inflamed membrane is synovial membrane is inflamed. So what is your duty and my duty? Patient should be diagnosed before reaching such a complication. If early diagnosis of the joint pain, cause for the joint pain can lead to the prevention of the disease. So enthesitis, examples are, enthesitis is the transitional zone where collagenous structures such as tendons and ligaments are interwoven into the bone. Examples are overuse, sports injuries, psoriatic arthritis and ankylosing spondylitis. So crystal deposition, another mechanism for joint pain is the crystal deposition. The deposition of crystals in articular structures may lead to the symptomatic joint pain. The responsible crystals are monosodium monourate crystal that lead to the gout, calcium pyrophosphate dihydrate that lead to the pseudo gout, and calcium phosphate that lead to the deposition into the tendons, and they lead to the inflammation and lead to the joint pain. So infectious arthritis, the synovium may become the seat of acute or chronic infections such as bacterial, fungal and the viral. Remember, septic arthritis is a medical emergency. It usually occurs in those who are immunocompromised or those who are receiving corticosteroids, are suffering from the malignancy, or suffering from the infective endocarditis. Because the damage to the joint is very rapid if the septic arthritis remain undiagnosed or the treatment is delayed. So remember, it is a medical emergency and causes are bacterial, fungal and the viral. Most of the causes, 80% causes for the septic arthritis are the bacterial. So structure and the mechanical joint derangement that lead to the arthritis are local factors, for example, previous joint trauma, meniscal tears, congenital and developmental joint alterations, alteration of the subchondral bone, for example, in osteopetrosis, avascular necrosis of the bone, and Paget's disease, alteration of supporting structures, hypermobility, cartilage derangements, onchronosis and the crystal deposition, and the host factors, the genetics, age, obesity and occupation. So obesity not only lead to the metabolic syndrome, it not only lead to the development, early development of the type 2 diabetes, it is not only related with the insulin resistance, it is, obesity is one of the cause for the osteoarthritis as well. Etiology of joint pain, so a monoarticular joint pain, for example, the trauma, fracture, overuse, hemarthrosis, infections are the septic arthritis, bacterial, fungal, viral, mycobacteria and parasitic infections. Reactive arthritis are the aseptic inflammatory arthritis, crystal induced disease, gout or the pseudo gout, periarticular syndromes, for example, bursitis, fasciitis, tendinitis, tenosynovitis. So there are so many causes for the monoarticular involvement of a joint, clinical presentation of a joint. It is your art to diagnose a single disease among various causative diseases. So uncommon causes are avascular necrosis, especially avascular necrosis occurs those who are chronic use of corticosteroids or who are suffering from the sickle cell anemia, neuropathy, Charcot's joint. And remember, the one of the commonest cause of Charcot joint is poorly controlled diabetes mellitus. So, diabetes mellitus not only involve the peripheral, causes the peripheral neuropathy, autonomic neuropathy, it is one of the causes that lead to the Charcot joint, and sometimes you need assistance by the orthopedic surgeon as well. Osteomyelitis, Lyme disease, Paget's disease, and the tumor. So, polyarticular joint pain, acute polyarticular arthritis, most often due to infection, viral failure of the rheumatic disease, chronic polyarticular arthritis in adults, most common rheumatoid arthritis and the osteoarthritis. Chronic polyarticular arthritis in children, most common cause often associated with the juvenile idiopathic arthritis. So, you can see here the the chart which showing the arthritis, inflammatory, non-inflammatory, seropositive, negative, infectious, and the crystal induced. So, in case of inflammatory, seropositive, rheumatoid arthritis, SLE, scleroderma, vasculitis, and Sjogren syndrome. In case of seronegative, ankylosing spondylitis, psoriatic arthritis, reactive arthritis, inflammatory bowel disease, and infections already we discussed in crystal-induced gout and pseudo-gout. And in non-inflammatory causes could be there that lead to the joint pain. So, red flags in case of arthritis. So, what signs are there along with the joint pain? A physician should be very cautious to evaluate the cause as soon as possible. So, whenever there is a signs of warmth, erythema, and swelling of the joint, significantly signify the need of consider infection, rheumatic process, and crystal-induced arthropathy. Other joints involvement, for example, if the spine is involved, one must be careful. Extra articular features, nail pitting, stenosynovitis, ears, nodules, conjunctivitis, mouth ulcers. So, sometimes the connective tissue disorders not only associated with the joint pain. For example, rheumatoid arthritis, it is not only associated with the joint pain, it is associated with the involvement of the other systems as well. It causes episcleritis, scleritis, scleromalacia, it involves the heart, it involves the kidney, it involves the it lead to the pleural effusion. So, now another important part of the diagnosis, to reach at that diagnosis, is the history. Pain, inflammatory joint disease, present both at rest and with motion. It works at the beginning, then at the end of uses. Non-inflammatory joint occurs mainly or only during motion. This is very important. Pain at rest, most likely because of inflammation. Pain on movement, most likely because of the degenerative. And the non-inflammatory improves quickly with rest. Patient with advanced disease of the hip, spine, and knees may also have pain at rest and at the night. So, otherwise, classically, if there is inflammatory joint, there is more stiffness, and it usually lasts more than 1 hour. Classical stiffness is early in the morning in case of rheumatoid arthritis, but if the patient take rest at any time, there is a chance patient may complain of the stiffness, pain, and swelling into the joint. So, stiffness is a sensation of tightness when attempting to move joints after a period of inactivity. It typically subsides over time. Its duration may serve to distinguish inflammatory from non-inflammatory forms. With inflammatory arthritis, the stiffness is present with early morning stiffness that lasts at least for 1 hour. With non-inflammatory arthritis, mechanical arthritis tend to occur after resting, and stiffness lasts only a few minutes on movement. So, when you are dealing with a patient, this stiffness is very important. Its duration is very important to differentiate between the inflammatory and non-inflammatory causes, because treatment options are different in case of inflammatory and non-inflammatory causes. Swelling of the joint with inflammatory arthritis. Joint swelling is related to the synovial hypertrophy, synovial effusion, or inflammation of particular periarticular structures. So in inflammatory, the commonest cause for the swelling of a joint is usually the synovial effusion. With non-inflammatory arthritis, the formation of osteophytes lead to bony swelling, and one of the classical example of this swelling related is osteoarthritis. Limitation of movement. A loss of joint motion may be due to structural damage, inflammation, or contraction of surrounding soft tissues. Weakness. Muscle strength is often diminished around arthritic joint as a result of disuse atrophy. Remember, it is not because of the neuropathy, it is not because of the myopathy, it is because of the disuse atrophy. Because of the severe pain limits the total range of movement, and that lead to the disuse atrophy. And if a patient, for example, develops the disuse atrophy of both hands, you can imagine the life of a such patient. Weakness with pain suggests a musculoskeletal cause, arthritis tendinitis, rather than a pure myopathic or the neuropathic cause. Fatigue is another symptom, usually synonymous with the tiredness and depletion of energy. With inflammatory polyarthritis, the fatigue is usually noted in the afternoon or early morning. With psychogenic disorders, the fatigue is often noted upon arising in the morning and is related to the anxiety, muscle tension, and poor sleep. So historical features important to differentiate the diagnosis are onset of the disease, duration of the disease, and temporal pattern of the arthritis. Remember, the temporal pattern of every disease is very important for diagnosis. For example, temporal pattern of stroke is sudden weakness. Sudden weakness. There is a history of diabetes and hypertension. If a patient present to you with this type of pattern, temporal profile, most likely diagnosis is that of stroke, because it is the rapidity in onset. Patient is suffering from the predisposing factors, diabetes and hypertension. Likewise, the onset, duration, and the temporal pattern of arthritis, number of involved joint, symmetry of joint involvement, distribution of the affected joint, distinctive types of the musculoskeletal involvement, extra articular manifestations. Temporal pattern of arthritis onset can be abrupt or insidious. Abrupt onset develop over minutes, hours. This may occur in trauma, crystalline, and the synovitis. Insidious that develops over weeks or months is typically most form of arthritis, including the rheumatoid arthritis and the osteoarthritis. Duration of symptom is considered either acute if the duration of symptom is less than 6 weeks, and chronic if the symptoms are more than 6 weeks. So temporal pattern, migratory pattern. Migratory pattern means pain spreads from one joint to another joint. The first joint starts to feel better before pain begins in the next. And one of the classical examples for the migratory pattern is in case of rheumatic fever. Additive or the simultaneous pattern inflammatory persists in involved joint as new ones become affected. And intermittent pattern episodic involvement occurs with intervening periods free of joint symptoms. So number of joint involvement same, mono, oligo, polyarthritis. Symmetry of the involvement of the joint. Symmetrical arthritis is characterized by the involvement of the joints on each side of the body. Symmetrical, the symmetry is typical of rheumatoid arthritis and SLE. So if the patient present to you with early morning stiffness, symmetrical involvement, proximal interphalangeal joints are involved, most likely diagnosed in such a patient is that of rheumatoid arthritis. Asymmetric arthritis is characterized by psoriatic, reactive arthritis and the Lyme disease. Distribution of affected joints. This is very important because peculiar diseases involve the different joint specifically. The distal interphalangeal joints or the fingers are involved only in psoriatic arthritis, gout or osteoarthritis, but are usually spared in rheumatoid arthritis. So, if a patient present to you with a distal interphalangeal joint involvement, the cause of the rheumatoid arthritis is less likely, could be the possibility of psoriatic, gout and the osteoarthritis. Joints of the lumbar spines are typically involved in ankylosing spondylitis, but are usually spared in rheumatoid arthritis. Distinctive patterns, types of the musculoskeletal involvement. Spondyloarthropathy involves ethyncensis leading to heel pain, sacroiliitis, vertebral disc insertion pain. Gout usually involves tendon sheaths and the bursa, resulting in superficial inflammation. Extra-articular manifestations. We should ask about the constitutional symptoms: fever, weight loss, malaise, anorexia. Suggest an underlying systemic disease. Not expect a patient with degenerative joint disease. For example, a patient present to you with rheumatoid with the osteoarthritis of the knee. Usually you will not get the constitutional symptoms. If constitutional symptoms are present, patient is most likely suffering from the systemic disease or the disease of the rheumatology that involve the other systems as well. Skin lesions may indicate the specific diagnosis of a number of rheumatic diseases. Examples include the SLE, systemic lupus erythematosus, scleroderma, and the psoriasis. So, must ask regarding the skin, involvement of the skin in a patient with a joint pain. A patient present to you with interphalangeal joint, but apparently there is no any skin lesion. Later on query, he will tell you that he has a patch on the right side of the thigh or buttock or somewhere else that is of psoriasis. So it is very important to remember the skin involvement in different arthritic diseases. Ocular symptoms are the signs: episcleritis, scleritis associated with the rheumatoid arthritis, anterior uveitis with ankylosing spondylitis, iridocyclitis with juvenile rheumatoid arthritis, conjunctivitis may be caused by reactive arthritis. It is right, urethritis, skin involvement, arthritis and the conjunctivitis in case of reactive arthritis. So most common causes of acute monoarthritis are bacterial non-gonococcal staph aureus, streptococcal pneumoniae, gram-negative, gonococcal that lead to the migrated tenosynovitis, crystal-induced gout, pseudo-gout trauma. This is the repetition, but it is very important. You should remember the pattern and cause of the disease. So here are some diseases with the chronic inflammatory involvement and non-inflammatory involvement. Here is the same between the acute oligoarthritis and the chronic oligoarthritis. So the general physical examination is very important. Fever, pulse, blood pressure. Joint examination is very important. Look, feel and move. Is there any swelling? Is there any tenderness? Is there any redness? Is there any apparent deformity? Just like I have showed you already, ulnar deviation case of rheumatoid arthritis. You should assess the inflammation of a joint, swollen, red, tender and hot. Functional impairment, passive and active movement, cryptus during active or passive range of movement. This cryptus is especially present if the involvement of knee is there in osteoarthritis. Instability, joint deformity, flexion, subluxation or the dislocation. So physical examination, for example, there is swelling, ecchymosis, could be okay ji, joint swelling, investigation. Here are some figures regarding this. और आखिर में मैं यही कहूँगा कि थैंक यू सो मच. आ जाओ देख लूं तुम्हें थोड़ा करीब से. आ जाओ देख लूं तुम्हें थोड़ा करीब से. नाराज होना जुर्म है अपने तबीब से. बढ़ने लगी हैं इश्क में रुसवाइयाँ बहुत. बढ़ने लगी हैं इश्क में रुसवाइयाँ बहुत. मिलना पड़ेगा अब मुझे अपने रकीब से. बहुत बहुत शुक्रिया. थैंक यू सो मच.
Thank you, Professor Dr. Muhammad Iqbal Shah, for sharing with us on a topic that we come across in our outpatient department on daily basis. Now I want to call Dr. Fatima Jahangir, will be talking on elderly health care, improving quality of life through palliative care. So kindly come on to stage and proceed, ma'am.
किस नाम से? एवोल्यूशन पे?
एल्डरली केयर. ये
आपको चाहिए स्लाइड?
हाँ. Assalamu alaikum. Thank you for having me here. The topic I want to discuss today is taking care of our elderly individuals. So I'm Dr. Fatima Jahangir. I'm an associate professor in the Department of Family Medicine and heading the Department of Family Medicine at Ziauddin University, Karachi. This topic is very close to my heart, and we family physicians take care of a spectrum of diseases. However, elderly people, as with technology and with advances in medical sciences, we know that good medical treatment is available for all kinds of diseases. So longevity is increasing. Elderly people are increasing. Same as what is happening in the Western world. In Europe, we see that there are more elderly people. And with advances in medical care, we will, at one point in time, we'll be seeing more elderly people. So if we do not have expertise of how to deal with their day-to-day problems, it will be difficult to take care of these treasured souls. So it's not one problem that they come with. Elderly people are there in everybody's house, and you must be seeing sometimes they're complaining of depression, sometimes they're forgetful, incontinence, which is very, which makes the lives of others cumbersome. Because caregiver burden is something which is under-recognized in our community. We do not appreciate that people who are taking care of the elderly are also tired. So if we take good care and we do wellness screens, like we do wellness screens of children, and we do the growth charting and the immunization and so much more, so why not elderly? And with this wellness screens, we can take care of the fall assessment, the fragility fracture risk, the risk of osteoporosis, dementia. You know, there's a stage of dementia when there is disinhibition. You lose control over your feelings, your speech and everything. So that crisis in everybody's home, which is so difficult to take care of such an individual, that, you know, we always respect our elderly, and it is wise to respect. But when they're making trouble for the family, So how do we deal with them in our society in a cost-effective manner? We do not send our elderly to nursing homes. So how do we take care of them in a cost-effective manner? So what is the exact age of elderly or geriatrics? Elderly, what is the cutoff age at which we label somebody as an elderly? It is 65 years actually. After 65 years, we label somebody as an elderly person. So it is just not one thing that we come across. There are so many wide area of diseases, like they will develop cataracts and visual impairments and avascular macular degeneration, cataracts and arthritis, functional disorders, cardiovascular diseases developed over the lifetime, neurological problems, dementia, normal pressure hydrocephalus in which they have dizziness, gait problems, incontinence, respiratory problems, GI problems. One is immobile, and that will lead to more constipation, and it is difficult to, because with immobility, there is chronic constipation that is very troublesome. Then psychiatric issues, being aggressive, violent, not listening to the children. And it is the stage of life when actually the parents become children and the children become parents. The children have to take care of their elderly. And the elderly people do not realize that now the younger generation are busy in their lives and they're going to go about their lives. It is in these high inflation times, nobody can sit at home and take care of the elderly. You have to work to earn your living. So it's very important that you have to develop an environment which is good for the elderly person and which is safe, and the person becomes, and we can prevent a lot of diseases. So my theme of my talk today would be how could be certain tricks and tips we can take care of our elderly and and without wasting cost. Because when this elderly person with missing one meal, you have electrolyte imbalance, hyponatremia. You go to the hospital and hospitalizations and hospital-acquired infections, and this is a vicious cycle that goes on. And then you lose money like water. So that is why it is very important to have preventive screens so that you do not have acute infections as such. Loss of hearing results in falls. Visual impairment results in falls. So this elderly person is more prone to infections. So what happens the most? Pneumonias or UTIs? Prone for injuries, falls, and fall is a big domain, and there are multiple factors for falls. We need to evaluate in order to prevent a fall and prevent a surgery, immobility, and so much more. Need special assistance. How can we, when in these COVID times when we have worked day and night, and we've seen that these nursing staff, they have been working day and night also with the patient, and they were tired also because everybody needs assistance. So how can we make their home environment safe enough? There has to be, no rugs and mats in between. The bathroom floor should not be wet. There has to be grabbing bars and handles in the bathroom. Geriatric commodes are there, higher commodes, so that most falls happen in the bathroom. So bathroom door should never be locked in an elderly person. Cameras can assist. That bells, the cable-less, wireless bells can be very helpful. Then increased risk of morbidity, increased risk of disability. I'm going to talk about what is disability and what is frailty. And increased mortality. So the aims in this geriatric patient is that just not one disease that we are taking care of. It is a bundle of diseases that this person comes to us and we are going to help in this and help them. And then terminal illness, people with terminal illness with various cancers, prostate cancers in men, and ovarian cancers and breast cancer, terminal illness when life expectancy is so short. It's not wise to put this person in a hospital. So how do you take care of this person? So make the home environment safe enough and provide palliative care. Through palliative care, we can manage the end of life, because everybody prefers to spend the last days at home, peacefully, dying peacefully is better than everybody running around in the hospitals and we do not have anything in hand. So it's just not physical, it's not just not medical, psychosocial and functional limitations that we need to shed light to. So it is very difficult to see so many areas in one visit, and we physicians are quite busy and difficult to manage everything in one visit. So you have to prioritize. One domain has to be dealt with in one clinic. So triggers of assessment, a physician has to take care that multimorbidity. There are so many things: diabetes, hypertension, cardiovascular diseases, osteoporosis, whatnot. Cognitive changes, dementia. Elderly person is becoming forgetful. So there comes a point in time when the person forgets to eat, the person forgets to dress up, and that is very difficult to take care for the caregivers. Frailty, risk of falling, medication non-adherence, simply the person refuses to eat. Polypharmacy, this is a big issue, because when these wellness screens are not being done in our community and we are not trained to do these wellness screens, this person is going to go from doctor to doctor. For osteoarthritis knees, if this person goes to an orthopedic surgeon, and for dementia to a neurologist, and for diabetes and chronic diseases and to a diabetologist and cardiologist, and so there's no end to it. That will, every physician is going to add up on the list of medications, and that will further harm the patient. We have to minimize the medicines, and polypharmacy results in interactions, and there are more risk of falling, and you become dizzy. So it's important that in every screen you have to review the medication list and minimize and give the most essential medicines. Unexplained weight loss could be a red flag, but most of the time in an elderly, they become like children, and it is very difficult. The nutrition is very difficult. How to provide nutrition, because there is protein loss that is going on. You know, what is the protein requirement of our in adults? What is the protein in individuals' daily protein requirement? It is around 1 gram per kilogram per day. But in an elderly person, it is because elderly person is losing the muscle mass. That he will lose the muscle mass from the deltoid. Haven't you seen a malnourished elderly person? There will be temporal wasting, there will be masseter wasting, deltoid wasting, the thigh muscles, quadriceps muscles atrophy. That is adding up to that is causing the frailty. So with good protein intake, and when the person is not eating enough, there will be more muscle atrophy and more frailty and more leading to disability and mortality ultimately. So not one doctor, a multidisciplinary team, but it is easy to say a multidisciplinary team. We in our society, I'm an advocate of cost-effective care, so I believe that a family physician has to take the lead and take care of most of the diseases, rather than reduce the referrals. And even I don't keep a staff, I keep a staff for urgent need for a day or two or a week hardly, and a untrained maid or an attendant can learn how to take the sugars, how to take care of the person and the nutrition requirements, NG tubing, everything. And then in a cost-effective manner, this illiterate person can take care of the elderly, rather than keeping nursing staff for a long period of time. So what is frailty? Frailty is when everybody is advancing in age, and disability is when you lose your ADLs and IADLs. If you lose your 4 components of ADLs, then that is disability. But frailty is not disability. Frailty is when you are not like elderly. You may see that it is difficult to open up the lids of the jars. It is difficult to open up the handles of the doors. So just your usual day-to-day work, it is difficult to perform that. That is frailty. And there's slow gait, poor balance, decreased physical activity, that adds to the frailty. So there are many definitions of frailty. Freed's criteria would be there is unintentional weight loss, self-reported exhaustion. Our elderly become exhausted very soon. They hardly do anything and they feel that they're tired. There is weakness, unexplained weakness, slow walking speed, low physical activity. So the more the points are present, the more frail a person. The lesser these points are present, lesser weakness, more robust the individual, lesser frailty. So how do you estimate this? Estimation of frailty is important. When this person is not disabled, this person is probably not requiring a crutch or a walker or does not need assistance. But how do you make sure or how do you label that this person is frail and cannot do his work himself? So very office-based test would be time up and go test. And what is this time up and go test, which all of you can do in your clinics? That you ask this person to rise from the chair and walk 3 meters, turn around, come back and sit. And if it takes more than 13 seconds, that means that the person is to a certain extent becoming frail. So try to estimate. Only when we estimate, we'll be in the follow-up visits, we'll be able to judge whether the frailty has increased, has it worsened, or with your treatment, has it become, it is improving or not. So robustness in early life, you see, I like this slide, that when your physiological reserves are available and you're robust, there is no age limit to it. You're robust, you can do your work yourself, you're less dependent on others. And then this downhill of life in which the last point is mortality, in which you are totally dependent. Before that, you're totally dependent. So there is this spectrum of life journey in which you are robust, and then you become frail, you become more dependent, and then more vulnerable to diseases, and in the end you become more disabled and mortality. So nobody is afraid of death. We all know that we are going to die one day, but we are afraid of disability. We don't want to be dependent on others. Becoming dependent is the worst thing that one can think of. So we hope that we become as robust as possible till the last days of our life. So there's not one component of frailty. It is physical frailty that I've talked about, physical becoming dependent and becoming less dependent. There's more to it. Socioeconomic frailty, we know that with you become difficult in financial crisis, and we very well understand that. But what is cognitive frailty? Cognitive frailty is when even young people can be cognitively frail. All of you try to assess how cognitively frail you are. How? By looking at whether are you able to make good decisions at right point in time, if you're able to make your decisiveness and your judgment and your alertness, this causes the cognition that you have. So the more we forget, the more we become, and even when we forget, we become dependent on others. So this is you become cognitively frail. So try to be cognitively robust as well, so that you know that you're managing your finances well, you're managing your day-to-day life well, and you are less dependent on others. And then psychological frailty. Psychological frailty kya hoti hai? That is when you have low interest in day-to-day life, you're more, it's not major depression, it's not a generalized anxiety disorder, but you are you're not giving your 100% to your life. You're not enjoying your life. Haven't we lost the joy in our lives? Probably post-COVID, or probably the crux of life stresses, we have lost the joy. We hardly enjoy our family gatherings. We hardly enjoy eateries. We are just running like a robot. So that is what is psychological frailty, that we are again becoming dependent on others. We have lost the meaningful life, the fulfilling life. And that does not mean that you live abroad and you're having all the luxuries. It is all wherever you live, and you are so much happy that you think that you've achieved everything in life. That is psychological robustness. We hope that we achieve psychological robustness till the last day of our lives also. So frailty is not equivalent to disability. Frailty is we are doing our work, we are not disabled, but it is we are becoming more weak and not enjoying our life 100%. Okay. So what do we lose first? We lose let me go to this. So do we lose IADLs first or do we lose ADLs first? Activities of daily living or instrumental activities of daily living? So instrumental activities of daily living are lost first. Instruments se yu yaad karen ke like running a washing machine. So when you're doing your laundry, you're not just doing it for yourself, you're doing for your family also. Cooking, not just for yourself, for your family also. Making finances, transportation, all such things which involves the care of others apart from yours only. That is activities of daily living. That is instrumental activities of daily living. That you're not functional enough to help the others. So first you lose that, and then at the end of the day you cannot do your own work even. Dressing, eating is lost as well. That is when you lose the activities of daily living, and when you lose your 4 components of activities of daily living. That means you cannot do your own work yourself, you become disabled. So make sure that the distinguishing points between frailty when you can do everything but you are low than your normal 100% physiological reserves, and disability when you're dependent and you're not able to do your work yourself. So in IADLs come driving, using telephone, performing housework, doing home repair, preparing meals, laundry, taking medications, handling finances, smartphone usage, ability to use the internet, and this is all IADLs that we lose first. After that, there comes a point in time when we lose activities of daily living, including bathing, dressing, toileting, maintaining continence, grooming, feeding, and transferring also. So let's come to this number one problem that patients present to us in primary care, falls evaluation. This is a big umbrella term in which there are multiple etiological factors. And what we need, we family physicians have to prevent a fall. Rather than when there is a fall, you lose, there is actually osteoporotic fracture first, the fragility fracture of the neck of femur, and then one falls. It's not the other way around that we think most of the time that in the bathroom floor, the person falls first and then that leads to trauma. That is lesser time the incidence. Mostly what happens, you have a fracture first and then you fall. So preventing a fall, you can do very well in your clinic. Preventing osteoporosis, preventing polypharmacy. Why do we give painkillers when we give muscle relaxants? We give like toffees to an elderly person who is always complaining, moaning and groaning of pain. But don't you do anything that when the harm outweighs the benefits, try to avoid that. Painkillers, muscle relaxants will lead to dizziness. There are more chances of falls. Try to have a judicious use in an elderly person. So you have to think of the first thing is the orthostasis. Orthostatic hypotension that we see in diabetes or autonomic neuropathy also. Elderly person, everybody has to be screened for blood pressure both in sitting position and standing position. If there's a fall in 20 millimeters of mercury in systolic and 10 millimeters of mercury in diastolic, that is considered hypotension, orthostasis. So that is the number one cause of falls, because when this elderly person rises and has a dizzy episode and falls. So again, visual problem, the person is not able to see well. Cataract screening should be done. Gait problem, the person is functional disabilities. Balance testing, medications review, as I said, muscle relaxants, benzodiazepine. Benzodiazepine should not be given in an elderly person. And most of our elderly are all dependent on benzodiazepines, alprazolam and clonazepam. Everybody takes. So we have to put this person in an SSRI rather Not even in TCA. Why? Because with the TCA, there are more chances of arrhythmias. So rather keep this person on an SSRI so that there's lesser dependency on a benzodiazepine group. You may give non-sedative benzodiazepines, so there are lesser risk of falls. And investigation of the environmental hazards at home. So falls could be due to impairment in balance, gait, cognition, visual impairment, muscle strength. You're weak, you cannot walk, and you fall. More than 4 prescription drugs increases the incidence of falls. Depressed, postural hypotension, arthritis, stairs and obstacles. Ideally, what should be done? Elderly people should be given the ground floor room, not the first floor room. Then, what medications can increase the risk of falls? Antiarrhythmics, beta blockers, benzodiazepines, antidepressants, haloperidol, TCAs, zolpidem, CCBs. Many a times I've seen prescription errors. A beta blocker combined with a rate-limiting calcium channel blocker, leading to first-degree heart block. So why is that? Review the medications again and again, try to minimize as much as possible. How do you manage? You have to identify and correct the cause. Early identification of functional decline. So all elderly now stepping up into your clinic, try to identify with this walk up and go test. Try to document and see how frail this person is, how disabled, risk of disability is there. Reduce the psychoactive medications, reviewing and reducing medications, using home or facility-based physical occupational therapy. It is very difficult to send this person to a physiotherapist every day for physiotherapy sessions and occupational therapy sessions. What can you do very easily at home? What we do for occupational therapy at home, ask this person to open up the bottles or jars and open up the lids, the caps of the bottles, and ask this person, you have to spend 10 minutes in capping the bottles, capping and uncapping. This is occupational therapy. Why would you go to a facility and lose money? So with certain things, we can make our elderly people more functional. Polypharmacy, I've already talked a lot on it. Try to make pill boxes, because this person, if this person opens the medicine from the blister and is visually impaired, this one pill falls. You are not taking one medicine, one antihypertensive one day, and there is elevating blood pressure, subarachnoid hemorrhage, or so much more. So it is very difficult. You need to identify the root cause of all these problems. Depression. There is a separate geriatric depression score. This person who is not ready to see that the younger lot in the house is just busy in their own work. This person is not mentally ready to adapt to this change in times. So we have to give them pharmacotherapy, as well as try to spend quality time with them. So with this PHQ-2 and PHQ-9 questionnaire geriatric assessment tool, in which we talk about the anhedonia and low mood and their crying spells, and our elderly people start yelling, isn't it? It's so difficult and they are termed as they are bullying the other people. Actually, it's the disease that is causing them to yell and scream. Then weight loss and malnutrition, very important. Oral diet, these people, if they have one TIA and stroke, and then you haven't checked the vagal nerve, and there are more chances of aspiration pneumonias. How do they die? The most common reason of dying, mortality, even in the hospital, is aspiration pneumonia. Because this person lying alone in the room is just one vomit, or just eating, not chewing well, and there are chances of pneumonias. Aspiration pneumonia is deadly. So what can we do? Preferred will be enteral, but if not, check the vagus nerve, check the gag reflex. If compromised, try to put an NG tube. Through an NG, if the patient is reluctant, because these elderly people are also reluctant, they have poor appetite, they do not want to take food. You know, the clinical presentation of a UTI in an elderly is not the classic presentation of burning, micturition, dysuria. Nothing like that. Then what is how do they present in the ER with acute kidney injury and they end up with raised high creatinine? It's just that they lose their appetite for a week, they become more drowsy, and it is UTI. So do not wait for the classical symptoms to happen. So this person who is drowsy, how will you make him eat? This person who is drowsy, you cannot fulfill the nutritional requirements, the 1.2 grams per kilogram protein intake I'm talking about. How will you give? So it's better, put an NG tube. Replace an NG tube every 3 months. Not possible, not coming back, put a PEG tube. This way it will be easier so that at least the nutritional requirements, the medications are given properly. Presbycusis, hearing loss, sensory neural hearing loss, going in for audiometry and putting a good hearing aid can improve the quality of life. Because this person is hard of hearing and one does not want to, give the answer again and again. Everybody gets tired. So a good piece of hearing aid can improve the quality of life. Presbyopia, visual impairment, macular degeneration. Everybody becomes visually impaired with time. So good glasses, good visit to an ophthalmologist, get the glasses and get this in order. Mini mental examination, dementia. Dementia is something that is so troublesome for the caregiver. Nobody wants, there was a family that came to me, they said, अभी बच्ची का रिश्ता कराया है और वो जो बूढ़ी अम्मा है उन्होंने बात कर दी कोई उल्टी सीधी रिश्ता टूट गया. अब who will know that the problem is dementia and this is a stage of disinhibition. Neither we understand nor the other party. So a doctor needs to sit with the patient and tell them that it is the disinhibition state of dementia which is preventable and which can be cured actually. With your aggressive attitude and with your violence, nobody would like to sit with you. And this will there will be disharmony in the house which nobody likes. So why not understand that this will happen to everybody, all dementic individuals in the house? So why not prevent it? And this is preventable. And studies say that not a lot of medication, although the anti-dementic medicines are too expensive, and they actually do not improve the memory, but they just halt the deterioration. And there are many studies which favor the use of their dementia apps in your iPads and your iPhones. If you can see their dementia apps. And I tell my patients, if you cannot go for those apps, just give your screens and your telephones from your children to your elderly people. Your elderly people must have a phone or a tablet with them. And they may play Candy Crush or simple games. Studies have shown that these simple games give them stimulus and they're able to make good decisions. So when medications are not working, why not help them with these simple advice? Medications, memantine you may give, rivastigmine patches are also available, which we do give, but we've hardly seen much benefit with that. And with dementic, this is a deteriorating disease. Then comes a very problematic issue, incontinence. What happens, which is the most common type of incontinence in elderly? That is urge incontinence. Urge incontinence, in which there is detrusor underactivity. Nobody likes being, clean, being messy, and the caregiver burden again. So again, this problem has to be taken care of. So who would she go? So look at the misery of this person. For every disease that I'm talking about, going from speciality to speciality, waiting at the speciality 2-3 hours for one specialist. Is it feasible? Is it feasible in our society? It's not. So we have to be able to have some geriatric assessment awareness so that we can help our patient. Medicines are available. Then osteoporosis, again, we know that osteoporosis leads to fragility fracture. Where is the fragility fracture happening? The Colles fracture of the wrist, the neck of femur fracture, or the spine fracture, the vertebral fracture. So one loses height with age. One loses height because of the collapsed vertebral fracture. There becomes a hunchback. So then when there is a hunchback, you know that it is a vertebral collapse fracture. This is osteoporotic fracture. Why would you even go for a DEXA scan? You have to start the remedy. Try to prevent a fracture. Save a limb. Because one fracture, you are one surgery, Austin Moore, you are on the bed for 3 months, then DVT and bed sores and so much more that you are welcoming. So a wise person is somebody who foresees the problems before they strike to us. So we physicians have to be wise. Try to correct these causes. Secondary causes of osteoporosis again. So much more to it. And how do you prevent them? You know, more than prevention, exercise. First of all, how do you diagnose it? A T-score of less than -2.5 is considered osteoporosis, and do not go for calcaneal ultrasound, please. It is a DEXA scan that has to be done. So, prevention would be with exercise. Our elderly people who cannot do cardio or aerobic exercises, even isometric exercises have role. That isometric exercises, studies have shown, have good role in reducing systolic blood pressure, 4 millimeters of mercury. It reduces sugars, increases bone strength. So give them 2 dumbbells, 1 kg dumbbells in each hand and do that at home. Give them a static bicycle. Sit at home and run the cycle. With this, you can gain your muscle strength. Calcium, vitamin D has to be given. Try to avoid muscle relaxants and lesser use of NSAIDs, because with NSAIDs, more chances of peptic ulcer and so much more. So exercises are very important. It does not mean younger generation even doesn't exercise, leave alone the elderly. So you have to tell them how make the environment friendly enough for them to exercise. Then prevention with bisphosphonates, easily available orals and IVs, and we have multiple pharmacotherapy available to help them preventing an osteoporotic fracture. Almost last slide, immunization. This is something that we forget. Immunization, when we are very thoughtful of giving our children the regular routine childhood vaccines, why not about the elderly? Elderly when I said that most people die of pneumonias, then why don't you give a pneumococcal shot? A pneumococcal vaccine, zoster. Herpes zoster is so debilitating, it is miserable, it is painful. Elderly people have more chances of developing it. So why not give a zoster shot, which is available in Pakistan? Yes, I'm finishing. So pneumonia, Tdap has to be given every 10 years for life. Pneumonia shot, flu shot yearly, and zoster vaccine. So the take-home message of my talk is that these people, these are not patients, they are our family members in our houses, and we have to prevent their disability and frailty. I hope that you have enough concept of what is frailty, how to distinguish it from disability, how to prevent a fracture, help them in preventing cognitive decline, which is going to happen with time. So longevity with improved quality of life only works. Thank you.
Thank you, Dr. Fatma Jhangi. I would like to welcome to one of our chief guests, the District Health Officer of Hyderabad and President of Pakistan Academy of Family Physicians of Sindh Chapter, Dr. Lala Jafar, to join us. We are proceeding our seminar today by calling our next speaker, Dr. Sadaf Badiuzzaman, to come on stage and give a lecture on evaluation and management of backache and neck pain in a family medicine clinic.
I begin with the name of Allah, the most merciful. Assalamu alaikum and a very good morning to all of you. Thank you very much for coming here and sitting for this long. I would try to keep it short. The topic is evaluation and management of neck pain and backache in family medicine clinic. So our learning objectives would be to discuss various causes of low back pain and neck pain, approach to back pain in and neck pain in family practice, areas of referral, and we would try to identify the red flags. So these are a few numbers. The epidemiology, lifetime prevalence of significant episode of neck pain is 40 to 70%. Global point prevalence of neck pain is 4.9%. On an estimate, 33 to 65% people recover from an episode of neck pain within 1 year. But with neck pain, relapses are really very common. Up to 20% of people who are having neck pain, which is acute, will proceed to have a chronic neck pain. And low back pain, as we all know, it causes more disability globally than any other condition. The point prevalence of back pain is 7.5%, and the lifetime prevalence is, exceeds around 80%. We all know low back pain is one of the most common reason of absenteeism from school, colleges, and from workplaces. So these are the common causes of neck pain: cervical spondylosis, fractures, which could be like Dr. Fatma mentioned, that osteoporosis could lead to fracture, trauma could lead to fracture, cervical strain, osteoarthritis, which Dr. Iqbal told us is a degenerative joint, and rheumatoid arthritis can also cause neck pain. So neck pain can be divided into 4 categories. Grade 1 is the neck pain where there is no sign of pathology and there is little interference with daily activity. Grade 2 is when there is no sign of pathology, but this may impact daily life. Grade 3 is when neck pain is associated with neurological signs and symptoms. Grade 4 is the neck pain with major pathology like a fracture, a myelopathy, a neoplasm, or a spinal infection. So here is a scenario. A 24-year-old married lady presents to your clinic with a complaint of pain in her neck for the past 1 week. She cannot look up nor turn to her right, and she has no idea what has happened. So we just evaluate this patient. Like Dr. Iqbal mentioned, that we need to see the circumstances of pain. How did the pain started? Was there any history of trauma? How long has the duration been? We need to see the location of pain. Is it only the neck? Or the neck is involved along with shoulder or arms? And we need to ask about the numbness and tingling. Like Dr. Iqbal mentioned, aggravating and relieving factors are also important when we are evaluating a pain. While examining this patient who has presented to you with 1 week history of pain, we would just do the inspection of neck. We will palpate for any tenderness. We'll see the range of motion, and we will see the neurological examination to assess any objective weakness in arms or leg. We would assess if there is any increase or loss of deep tendon reflexes, if there is any decrease in sensation or strength, and we'll assess the tone and spasticity as well. So this patient is most probably suffering from cervical strain or sprain. The management would be icing, rest. We can give analgesics, and muscle relaxants if needed, as Dr. Fatma mentioned, keeping the age of the patient in our mind, since she's a young patient, so she can be given muscle relaxant. And I would emphasize the importance of exercise. We just can tell simple exercises to the patient that she can flex, she can extend, she can turn and rotate, and these are the simple exercises that the patient can do easily. So, let's come to the findings that would warrant urgent evaluation in a patient with neck pain. So, if the patient is having fever, meningism, night sweats, photophobia, this could be due to infectious causes. Infectious causes could be epidural abscess, herpes zoster, meningitis, osteomyelitis. And in the physical finding, we would find kerning signs, ductal rigidity, and photophobia. As Dr. Iqbal mentioned about inflammatory conditions, while talking about neck pain, inflammatory conditions could be ankylosing spondylitis, polymyalgia rheumatica, and rheumatoid arthritis. These patients would have generalized joint pain, and as Dr. Iqbal mentioned, that they would have morning stiffness that usually improves with exercise. Then there is malignancy in a patient who has presented with METs, multiple myeloma, or spinal cord. We would get anorexia, fever, history of malignancy, intractable night pain, and on examination we would find significant bony tenderness and other signs similar to myelopathy. In myelopathy, a patient would present with ataxia, bowel and bladder dysfunction, deep aching pain, gait changes, tremor, possible radicular symptoms or weaknesses. On examination, we could find Babinski reflex, clonus, fasciculations, hyperreflexia, and there could be increased muscle tone. If the patient is having thoracic outlet syndrome, it could present with intermittent paresthesia. The patient's pain would worse by use, and there would be unilateral symptoms. And on examination, thoracic outlet syndrome patient would have tenderness on palpation over arms and the veins. So these are some other causes of neck pain, nerve root irritation or entrapment. This is secondary to degeneration, vertebral displacements or collapse, disc prolapse or local tumor or abscess. In this we would find neck stiffness, pain in arms and fingers, sensory loss and decreased reflexes and power. We would treat this with analgesia plus minus cervical collar if needed, physiotherapy, and we would refer for investigation if conservative management fails. The other cause of neck pain is a spasmodic torticollis. This is sudden onset of painful stiff neck due to spasm of trapezius and sternocleidomastoid caused by poor posture and carrying heavy and uneven loads. The treatment would be heating or icing, gentle mobilization, muscle relaxant, and analgesia. Cervical rib is another very common cause of neck pain. It is a congenital condition where C7 vertebral costal process enlarges, and this we're going to refer the patient to orthopedic surgeon for further assessment. Last but not the least is the whiplash injury, neck pain resulting from stretching or tearing of cervical muscles and ligament due to sudden extension of the neck. This often occurs due to road traffic accidents, and we would manage this injury ka patient accordingly. Coming to backache. So this is again a scenario, a 36-year-old gentleman presented with a complaint of low back pain for 5 days. Again going through the same, the onset of the pain, whether it is acute, how did it started, what were the circumstances of the pain, whether there is any history of injury, whether it occurred during sports or any activity, how is the character of pain, is it sharp, is it burning, is it a dull ache. We need to ask about the nature and severity of the pain. Is there any stiffness at rest or at night? Is the inflammation getting better? The pain is getting better with the activity. Is there any radiation? Are there any associated symptoms like numbness, weakness, bowel and bladder dysfunction? And also, is the pain affecting the work of the person or the occupation? What is the medical history of the patient? Like Dr. Iqbal mentioned, that we need to see if there is any systemic, is there any evidence of systemic disease, like if there is any weight loss, fever, is there any evidence of neurological compromise, is there any social or psychological distress that may contribute to chronic disabling pain. On physical examination, we would see the patient, how is he walking, we would inspect the back and his posture, we are going to palpate the spine, and the soft tissue, we are going to see the range of motion, and we'll see the strength of the muscles. Very important straight leg raise test. We ask the patient to lie supine, and we ask the patient to lift his or her leg, and the patient feels pain when there is hip flexion. So this is suggestive of lumbar disc herniation. So the red flags are, while talking about this back pain, the red flags are age less than 20 or more than 55, if there is any history of cancer, weight loss, osteoporosis, if there is any penetrating wound near the spine, infection or inflammation, is there any history of trauma, progressive sensory or motor deficit, immune suppression, chronic oral steroid use, failure to improve after 6 weeks of therapy, cauda equina syndrome is one of the red flags. These are the differentials of low back pain. I have taken it from AAFP. Mostly the low back pain is mechanical in nature. As we can see, lumbar strain or sprain is the most common cause of mechanical low back pain. Then is non-mechanical spinal condition, which include neoplasia, inflammatory arthritis and infection. And not to forget, the back pain can also come from other organs like PID, pelvic inflammatory disease, prostatitis, endometritis. These all conditions may cause back pain. So the treatment would be aimed on the cause of the symptoms, and if we talk about the patient that we discussed in the beginning, we need to explain the cause of the symptom to the patient and reassure the patient that it is going to diminish with time. We need to advise the patient that he or she needs to stay active and continue his or her daily life activity. We can prescribe drugs as needed according to the step ladder pattern. And this is again the same thing. If the patient has presented with acute low back pain, we need to educate our patient. We need to reassure the patient that the prognosis is often good, with most cases resolving with intervention. We are going to advise the patient to stay active. We are going to tell the patient to avoid bed rest. We are going to advise the patient to avoid twisting or bending. And we can give the patient non-steroidal anti-inflammatory drug or acetaminophen. We can consider giving the patient a muscle relaxant for pain severity. And we can also consider giving the patient a short course of opioid therapy if the pain is severe. In second visit, if the patient is not improving, we can consider changing it to a different anti-inflammatory drug, or we can refer the patient for psychiatry, for physical therapy. Thank you very much.
Thank you very much, Dr. Sadaf Badiuzzaman, for a valuable lecture. I would now like to invite our last speaker, Dr. Akram Bajwa, onto the stage and give us lecture on the updates in the management of GERD.
Bismillahirrahmanirrahim. My respected teachers, seniors, guest of honors, PG students, and others, Assalamu alaikum. I am grateful to Professor Iqbal Shah Sahab, who invited me to present GERD that continues to be among the most common diseases for which the patients pay visits to the gastroenterologists, physicians, and surgeons. The prevalence that is very high in the Western countries, but also increasing in the Asian. At the end of this presentation, I think we would be able to manage GERD patients with the advanced approaches and the advancement in the endoscopy and the surgical procedures that's seen in the world. Today, I am going to present updates in the management of gastroesophageal reflux disease. What is GERD? GERD, it's a disease that is a consequence of the failure of the normal anti-reflux barrier to protect against frequent and abnormal amounts of gastroesophageal reflux. There is a disruption of the anti-reflux barriers, like the crura of the diaphragm and the transient relaxation of the lower esophageal sphincter. And this is an imbalance between the anti-reflux barriers and the reflux of the aggressive factors because of reflux of the gastric contents into the esophagus. In the pathogenesis, imbalance between the defensive factors protecting the esophagus, that is anti-reflux barriers, esophageal acid clearance, tissue resistance, and aggressive factors refluxing from the stomach like gastric acidity, volume, and the duodenal contents. The refractory gastroesophageal reflux disease, despite treatment with proton pump inhibitors, some patients with gastroesophageal reflux disease continue to have reflux symptoms or endoscopic evidence of esophagitis. Once the patient, they are taking PPIs, but in spite of taking PPIs with OD dose, they are not responding to the treatment. We have to optimize the PPI therapy, and we have to proceed for the advanced procedures. So this is called refractory GERD. Approximately 10 and 40% of the patients with GERD fail to respond symptomatically either partially in 10% of cases or completely 40% of cases to proton pump inhibitors. Most patients with GERD who do not respond to PPI have either non-erosive reflux or functional heartburn. So we have to differentiate GERD from the NERD or the functional heartburn. In NERD, there is no acid reflux, and endoscopy would turn to be a very much normal. Likewise, in functional heartburn, there is no reflux of acid as well. But the treatment, somehow we have to treat such patients with different way. What is the etiology of the refractory GERD? Because of insufficient acid separation and poor compliance with the proton pump inhibitor timing, and adherence. It is an important cause for inadequate acid suppression and refractory GERD. PPIs should be administered 30 to 60 minutes before breakfast for maximal inhibition of the proton pumps. Because the food stimulates the proton pumps, then it would automatically be less effect of the PPIs. And administration of the PPIs before a meal provides a better control to intragastric pH as compared with administration during or after a meal. H2 receptor antagonists in patients with persistent acid reflux symptoms despite PPI therapy with or without alginates, we add a bedtime H2 receptor antagonist. In those patients who are taking PPI therapy in the morning, but not, they appreciating, the nocturnal acid symptoms, we have to add H2 receptor blockers at night in order to suppress the acid suppression. Furthermore, in a carefully selected group of patients with symptoms refractory to PPI therapy, baclofen significantly reduced the bile reflux, exposure, and heartburn. That is the study published in Neurogastroenterology 2008. The baclofen is a GABA agonist, which helps in reducing the acid suppression. So it can be attempted in many studies and proved very effective in those cases where simple PPIs are not functioning. We use baclofen as adjunctive treatment in patients with persistent symptoms despite a PPI with H2 blockers. We initiate baclofen at low dose, 5 to 10 milligram twice a day before meals. Prokinetics. Prokinetics have a role where there is delayed gastric emptying. Like metoclopramide, they are reserved for the patients with refractory GERD and objective evidence of the delayed gastric emptying on diagnostic testing. How would you initially assess such patients? Compliance, very important with the proton pump inhibitors. Number 2, timing is very important in relation to meals, should be sought. Patients with continued symptoms should be carefully reassessed, paying specific attention to the type of ongoing symptoms and the degree to which symptoms have improved or worsened. Thus, endoscopy healing and the symptom relief are achieved with 8 weeks in the majority of the patients. The patients who are presented with typical symptoms of GERD, they must respond to PPIs for 8 weeks. If they are not responding to 8 weeks PPI therapy, then we have to optimize the PPI therapy. However, patients with severe esophagitis may take longer to heal. Patient may present with alarm features like new onset dyspepsia if the patient is more than 60 years, GI bleed, iron deficiency anemia, unexplained weight loss, dysphagia, odynophagia, persistent vomiting. So if the patient presents with these alarm features, then the answer is upper GI endoscopy. Upper GI endoscopy is very important, and don't wait to advise upper GI endoscopy if patients present with any one of them alarm features. And those who present without alarm features, only general measures like lifestyle modification, dietary modification, and compliance with the PPI therapy is sufficient to treat such patients. In lifestyle modification, taking small foods with the intervals walk after taking meals, a gap of 2 to 3 hours before going to bed, dinner and going to bed, at this gap of 2 to 3 hours, and had a rise during night sleep, 4 to 6 inches. So these all are lifestyle. But in dietary modifications, so we have to quit, acidic foods. Acidic foods, we should avoid to take acidic foods, chocolate, coffee, and tomatoes. So they all are, the aggravating factors in, in appreciating such symptoms. And compliance with the PPI therapy is very, important. The timing and before taking meal, 30 minutes before meal is very important in such cases. And once those patients who are not giving a response to PPI once daily dose, we have to optimize the PPI therapy. Options include splitting the dose, omeprazole 20 milligram twice daily, doubling the PPI dose, 40 milligram twice daily, or switching to another PPI agent like lansoprazole once daily. We usually double the PPI dose for 8 weeks before considering an alternative PPI. Diagnostic testing. Diagnostic testing in patients with GERD usually consists of an upper GI endoscopy and esophageal impedance pH testing. And it is only recommended once nobody is responding to the PPI therapy. We have to re-evaluate for other than GERD, like achalasia, functional heartburn, rumination syndrome, so may be considered by investigation. So before going anti-reflex or reflex endoscopic procedures, we have to go for first for upper GI endoscopy. If something is found there, then it's okay. Otherwise, we have to go for reflex monitoring in order to confirm the GERD or other than GERD. Additional evaluation should be pursued based on the type of ongoing symptoms like esophageal manometry in patients with regurgitation, gastric emptying studies in patients with vomiting. So again, esophageal manometry is very important to go before any surgical procedure or endoscopy procedure. Esophageal impedance pH testing is very important. For patients who fail twice daily PPI therapy should also undergo esophageal pH monitoring. Esophageal pH monitoring with impedance is preferred to wireless pH capsule and the traditional pH probe, as it has advantage of detection of non-acid in addition to acid reflux. Impedance pH testing can be performed while off PPI therapy in patients without typical GERD symptoms to determine if GERD reflux is the cause of their symptom. Esophageal manometry, that is again, as I told you, is very important before going any surgical procedure. We perform esophageal manometry in patients with dysphagia and regurgitation and prior to invasive anti-reflex therapies to exclude an esophageal motility disorder like achalasia. GERD can be distinguished from the rumination syndrome by impedance pH manometry by detecting gastric staining preceding or during a reflux event that extend to the proximal esophagus. And rumination, this is effortless reflux of the gastric contents into the mouth, which does not taste bitter or sour. The endoscopic procedures see advancement in the treatment of GERD in terms of endoscopy procedure is very important. Those who don't want to go for nascent fundoplication or partial fundoplication, so endoscopy procedure is the answer. The most common endoscopic procedures which are very popular and very effective, because with nascent fundoplications, 26% of the patients, they can present with dysphagia later on, but there is very less chance of developing dysphagia in cases of endoscopic procedures. Application of the controlled frequency energy to the lower esophageal sphincter region, this is called Strata procedure. And number 2, transoral incisionless fundoplication TIF with the application of the fasteners. So this is tightening of the the gastroesophageal junction, we can achieve the goal of anti-reflux. And number 3, by the endoscopic procedure, mucosal resection and the ablation is another method to prevent acid reflux. So 3 procedures of the endoscopy-based surgery, that is radiofrequency therapy, that is called Strata, transoral fundoplication, transoral incisionless, without cutting and without giving incision. So we have to tighten the gastroesophageal junction. And number 3, by achieving mucosal resection and the ablation. So in Strata procedure, it's a balloon inflated with the electrode, radiofrequency applied in such cases, and the tightening the junction prevent the reflux. So this is a Strata procedure. And this is transoral incisionless fundoplication. So this is done with the help of the device the scope is inserted from the mouth into the esophagus, and finally creating a tight 3 centimeter length valve enveloping the distal esophagus below the diaphragm. And it would help in prevention of the acid reflux from the stomach. So this is very popular
The
procedure.
esophagus technology is designed to rebuild the valve from inside the stomach using a transoral approach with the goal of creating a partial fundoplication that measures 270 degrees in circumference and 3 centimeters in length. An endoscope is inserted into the center channel of the esophagus device and provides direct visualization for the TIF procedure. While under general anesthesia, the device and endoscope are gently glided through the patient's mouth and into the stomach. The stomach is inflated and the endoscope is advanced and retroflexed so that it is looking up at the gastroesophageal junction. The valve reconstruction starts with the engagement of the helical retractor at the gastroesophageal junction. Then, tissue is retracted into the tissue mold as the esophagus device is rotated, wrapping the fundus toward the lesser curvature of the stomach. A small hiatal hernia can be reduced and the intra-abdominal length of the esophagus can be restored using suction built into the device. The trigger handle deploys a pair of non-absorbable polypropylene H fasteners above the GEJ to oppose the fundus to the esophagus. This retract, wrap, oppose process is repeated in specific locations to ultimately create an omega-shaped valve. Approximately 20 Serosa fuse fasteners are placed during the procedure to recreate physiological anatomy and help prevent refluxate from entering the esophagus. Studies show that in the weeks following, serosal fusion occurs by creating a layer of fibrous and fibroelastic tissue that secures the full thickness plication. Clinical efficacy and durability of the valve have been confirmed in randomized long-term and sham-controlled studies. Well-selected TIF patients report consistent, durable symptom control, and physician.
So this is tightening of the gastroesophageal junction with the help of the endoscopy. Inshallah ta'ala, we will make every effort to start this procedure in endoscopy suite, LUMHS, inshallah, in future. So this is another endoscopy procedure, that is anti-reflux mucosal ablation. And through ablation, so you can see here, this is anti-reflex mucosal ablation. So there is ablation of the mucosa, and finally, in the third figure, we have a very tightening of the gastroesophageal junction, and by tightening of this gastroesophageal junction, now we can prevent the acid reflux from the stomach into the esophagus. Another one, anti-reflux mucosectomy. So this is achieved with the dissection of the mucosa at the level of the gastroesophageal junction, and by achieving this, so we have to tight the gastroesophageal junction and prevention of the acid reflux. So these are 3 endoscopic procedures. So they are being commonly applied in the Western countries, but hopefully they will be started in Pakistan as well. So inshallah ta'ala, so LUMHS, the Department of Gastroenterology Endoscopy Suite LUMHS would start soon with the help of the experts. So such procedure inshallah ta'ala. Now anti-reflux procedures, the surgery is another final option for those who are not responding to the PPI therapy, have large hiatus hernias, so they are very reluctant to take PPIs because PPI, they have their own side effects like, constipation, diarrhea, fractures, pneumonias, so some of the vitamin deficiencies in the body. So the patient can't tolerate PPIs for the long time with 40 milligram BD dose or 40 milligram OD dose. So that's why we have to stop PPIs after 8 weeks. If not responding to the PPI, then we have to re-evaluate by upper GI endoscopy and reflux monitoring, and then decide for any surgical procedure. So those who are not willing to go for surgery, so endoscopic procedures is the option, and those who want, so it's very good to go for Nissen fundoplication. Again, fundoplication, they are of 2 types: full rep fundoplication and partial fundoplication. In full rep fundoplication, there is a chance of dysphagia. 26% of the patients, they appreciate dysphagia after surgery, but in partial fundoplication, there is less chance of developing dysphagia in partial fundoplication procedures. So, Nissen fundoplication, stomach wraps fully around the esophagus. There is chance of dysphagia later on. 26% of the patients, they can appreciate this system. And another one is door fundoplication and the two-pit fundoplication. In door fundoplication, stomach wraps around front of the esophagus. In case of two-pit fundoplication, the stomach wraps around the back of the esophagus. So these are the 2 different surgical procedures. So can be applied to those who have refractory GERD. After optimization of the PPI therapy, they are not responding to well, and plus those who have an large hiatus hernia and they have severe LA classification, L, C, and D, so not responding to the medicines. So alternative, the next option is fundoplication. So summary, lifestyle modification and the dietary modification is very important. Weight loss in overweight and obese patients, avoiding meals within 2 to 3 hours of bedtime, avoidance of tobacco products and smoking in patients with the GERD symptoms, avoidance of trigger foods, and elevating head or bed at the time of sleep. Treatment with PPIs over treatment with the histamine H2 receptor antagonist for healing erosive esophagitis is very important, and PPI discontinuation, PPI administration 30 to 60 minutes before a meal is very important. Maintenance PPI therapy indefinitely or anti-reflux surgery for patients with a LA grade C or D esophagitis is very important. You can put patients on maintenance therapy with the classification of Los Angeles classification is C and D. But those who have large hiatus hernia and the Barrett's esophagus, so you have to keep, such patients on lifelong maintenance therapy. Do not recommend baclofen in the absence of the objective evidence of GERD. So never prescribe without getting investigation like esophageal pH impedance monitoring, and once you have confirmed the case, then you can start baclofen. Recommended treatment with the prokinetic agent is very important. Recommended sucralfate for GERD therapy during pregnancy is very safe. Suggest on-demand or intermittent PPI therapy for heartburn symptoms control in patients with a NERD is very important. Anti-reflux surgery is recommended for those who have severe reflux esophagitis, CRD, large hiatus hernia, persistent or troublesome GERD symptoms. MSA, magnetic sphincter augmentation, is recommended as an alternative to laparoscopic fundoplication in patients with regurgitation who fail medical management. Roux-en-Y gastric bypass for obese patients suffering from GERD is very important, and transoral incisionless fundoplication for patients with troublesome regurgitation or heartburn who do not wish to undergo anti-reflux surgery and who do not have a severe reflux esophagitis is recommended, and high-resolution manometry is recommended before anti-reflux surgery or endoscopic therapy to rule out eclasia and absent contractility. Thank you very much.
Thank you very much, sir, for your healthy talk. Now we conclude our session by shield distribution. I would like to call upon on stage Professor Muin Ansari, the Dean of Medicine and Chairman of International Academics and Research Summit LUMHS, the Dean of Basic Sciences, Professor Munawar Alam Ansari, Professor Dr. Iqbal Shah, and today's organizers, Dr. Khalid Sheikh, Professor Muzaffar Sheikh, Professor Shoaib Ansari, Dr. Santosh Kumar. I would like to call on stage Professor Dr. Zaman Sheikh to receive your shield and certificate. I would like to call Professor Dr. Muhammad Iqbal Shah to receive his shield and certificate. I request Dr. Fatma Jhangi to come on stage and receive her certificate and shield. I request Dr. Sadaf Badiuzzaman to come on stage to receive her certificate and shield. Now I would like to request Dr. Akram Bajwa to come on stage to receive his shield and certificate. Now I'd like to request our panelists of today's session, Professor Dr. Muhammad Rafiq Ghori, to come on stage and receive his certificate and shield. I request our next panelist, Professor Dr. Kasim Rahupoto, to come on stage and receive his certificate and shield. I request Professor Dr. Anwar Jamali to come on stage and receive his certificate and shield. Now I'd like to request our special guest, Mr. Dr. Lala Jafar Khan, the DHO Hyderabad, to come on stage and receive his shield. I request to Dr. Salahuddin Qureshi to come on stage and receive his shield. I request Dr. Anwar Qureshi to come on stage and receive his shield. Thank you very much.
Ladies and gentlemen, please give a big round of applause for Dr. Krutna to moderating this session.
अस्सलाम वालेकुम। इंतहाई शुक्रगुजार ऑर्गेनाइजिंग कमेटी का कि उसने हमें बुलाया, मदू किया, और मेरे सीनियर टीचर्स उन सबको इंतहाई शुक्रगुजार कि उन लोगों ने मुझे मौका दिया। मैं आज फैमिली कॉन दूसरी इंटरनेशनल कॉन्फ्रेंस जो हैदराबाद में होने जा रही है 17, 18, 19 मार्च 2023 इंडस होटल में इंशाल्लाह ये हम ऑर्गेनाइज कर रहे हैं पाकिस्तान अकेडमी ऑफ फैमिली फिजिशियन की जानिब से। तो आप सबको मैं इस फोरम की जानिब से दावत देता हूँ कि आप तमाम पार्टिसिपेट करें और इंटरनेशनल कॉन्फ्रेंस है इंशाल्लाह। इसमें साथ हमारी वर्कशॉप से पीट्स गायनी ऑफ डर्मेटोलॉजी, डेंटिस्ट्री, पहली मरतबा हम डेंटिस्ट्री को भी इन कर रहे हैं और अल्ट्रासाउंड एंड रेडियोलॉजी को भी इंशाल्लाह हम इसमें एंट्री कर रहे हैं। तो एक साइंटिफिक सेशन है इंशाल्लाह, आप सबको इनवाइट किया जाता है। इंडस होटल 17, 18, 19 मार्च। थैंक यू। अस्सलाम वालेकुम।
Thank you, ladies and gentlemen. Due to shortage of time, we are starting our next session, that is plenary session second of International Academics and Research Summit, LUMHS 2022. On the behalf of organizing committee, I extend my heartfelt gratitude and thanks to all the dignitaries, delegates, guest speakers, and the organizers who have spared their time on this weekend and are today are here with us in the International Academics and Research Summit 2022. The theme of this summit is integrating healthcare delivery with sustainable development goals. Ladies and gentlemen, proceeding towards our session, I would like to introduce the panelists for today's session. And the first panelist is Professor Dr. Hassan Kulachi Sahab. He is Professor of Community Medicine and Public Health, currently serving as HOD, Head of the Department of Community Medicine at ISRA University Hospital, Hyderabad. It's Professor Dr. Hussain Bakhsh Kulachi. My mistake, apologies, sir. The next panelist is Professor Dr. Zaman Sheikh. Professor Zaman is Professor of Diabetes and Endocrinology. Please, sir, take your seat as a panelist. The next panelist we have is Professor Dr. Munawar Alam Ansari, the Dean of Basic Medical Sciences and Public Health. Sir, please take your seat. The first talk we have is titled as Need of Research Ecosystem in Pakistan, the Need of the Hour. And the speaker is none other than Dr. Bashir Hanif. Dr. Bashir Hanif is Executive and Medical Director of Tawa Heart Institute. He is Diplomat, American Board of Internal Medicine, American Board of Cardiovascular Diseases, American Board of Interventional Cardiology, Board of Nuclear Cardiology, National Board of Endocardiography. He is diplomat and certified from the Certified Board of Cardiovascular CT, Fellow American College of Cardiology, and Fellow Society of Cardiovascular Angiography and Interventions. Dr. Bashir, please take over. Thank you, sir.
Good afternoon, everyone. I think I would like to start with congratulating the organizers for holding such a great meeting, and thank the organizers, especially Professor Moin Ansari and Dr. Kashif Sheikh for inviting me and giving me this opportunity to talk over here. So basically, when Dr. Kashif asked me to give a talk on cardiology, and I looked at the title of the meeting, it was academics and research. So I thought we always talk about academics, and there will be so many other talks about academics. So let's talk about a little bit about research. And obviously, I'm a cardiologist, so I thought I'll be talking about cardiology. I think nobody really would say that there's not a need for research or a research ecosystem in Pakistan, but the question is what we are doing really to fulfill that need. And that's what I'm going to try to highlight today, that at individual level, we all can contribute and do something. I think there is a famous quote from one of the presidents, US President Kennedy, that don't ask what your country can do for you, but ask what you can do for your country. So I think all of us as individuals need to do something, and I'm sure everyone is doing it as much as they can, but we need to have definitely in research, we need to make our efforts much more than what we are doing in other clinical areas and other things. So I'll be introducing two projects which I've been working on for the last few years, and alhamdulillah they have matured and are making a huge difference. So we'll talk about that. So in terms of atherosclerotic cardiovascular disease remains the leading cause of death all over the world, and almost causing around 18 million lives a year. And we used to think it's a disease of the Western culture or Western population, but it is actually the #1 cause of death in low to middle income countries as well, and that includes Pakistan too. And these numbers are gradually getting worse and worse. In Western countries, they are actually coming down, but in our countries or low to middle income countries, they are increasing. And almost 30% of annual mortality worldwide, and around 85% basically is a cardiovascular mortality if you look at overall mortality. And again, the risk unfortunately is almost fourfold in South Asians, and that includes Pakistan, as compared to rest of the world. So that is really the most alarming part for which we need to worry. And not only that, on top of that, this cardiovascular disease fourfold risk is more so in younger population as compared to older population. This is one of the recent UK Biobank study from 2021, and that clearly showed, if you look at the numbers up here, that South Asians had a much higher atherosclerotic cardiovascular disease. The top graph is that of, do I have a pointer? I don't know. So on the top, on the right side, upper paragraph, you can see the top one is South Asians are at a much higher risk as compared to Europeans. And again, the risk factors like hypertension, diabetes, and central adiposity is also much higher as compared to rest of the world. And despite adjusting these risk factors, which are higher in our part of the world, there are other factors like lifestyle and genetics also play a significant role. And a lack of, unfortunately, again, most of these research and data on cardiovascular disease is coming from the Western world, and there's a significant lack of literature or data in our part of the world in cardiovascular disease. And that's where we really need to worry. This was a survey from Global Burden of Disease estimates, and if you look at Pakistan actually is on the top, and it's not working. So it's have the highest mortality rates in Asia, and globally it ranks 18th in terms of cardiovascular mortality, again, which is very, very alarming. And if you look at the risk factors, almost 60% of the deaths are premature cardiovascular deaths, suggesting the trend of premature cardiovascular disease is much higher. We see younger people like 20s and 30s even with ST elevation myocardial infarction. And there are a lot of risk factors, and one of the major and common risk factors, hypertension, has almost kind of a prevalence of 30%, which is like means that every third person has high blood pressure in Pakistan. And unfortunately, despite all these alarming numbers, if we look at the health financing, Pakistan, unfortunately, in all South Asian countries, remains the lowest. If we talk about total expenditure on health, general government expenditure on health, and per capita total expenditure on health is significantly lower as compared to all South Asian countries, including even Nepal and other countries too. So non-communicable diseases currently account for almost 60% of total disease burden in Pakistan, and younger people are affected more. But the worst part is, unfortunately, this is a long-term, lifelong disease, and it could be very harsh and poor. It's not only affects that particular individual, but the whole family in terms of economic and financial burdens. And in terms of dealing with these non-communicable diseases, if you look at the capacity, what different countries has, and unfortunately, the Pakistan, if you look, I won't be going into the details, but most of these numbers are no. That means we don't have that kind of capacities to deal with all these non-communicable diseases. And on one hand, this is the problem, and on the other hand, if we look at the socio-economic polarization, there's a one extreme to other, and we see this all the time. On one extreme, there's no middle class is very small, and both extremes are there, and that is true in healthcare as well. This polarization of extreme to the other side remains like this also. On one hand, we have very high institutes, and on the other hand, people are not able to get even the basic health care. Economic impact is significant. Even in 2005, it was supposed to be $1 billion, which was supposed to increase to $30 billion in 2020, and it's going to keep growing up and up. One of the study, most of the data, as I said, is from Western countries, but Interheart study was the one which they included the Asians as well, and they found 9 major risk factors which were contributing for more than 90% of cardiovascular disease. And if we are able to implement preventive strategies to just deal with these risk factors, we can significantly reduce the burden of cardiovascular disease. Unfortunately, they also found that in our part of the world, protective risk factors were markedly lower, while harmful risk factors like blood pressure, diabetes, and cholesterol issues were much higher in South Asian countries as compared to the rest of the world. Similarly, acute myocardial infarction in South Asians were at a much younger age as compared to the rest of the world. Lifestyle changes were also not as good. So what is the way forward? We need to eliminate these major risk factors. If we are able to eliminate the risk factors, we may be able to eliminate most of these non-communicable diseases. If we can prevent 80% of the heart disease and stroke and type 2 diabetes, if we are able to work on these major risk factors. So what is the prevalence of risk factors in Pakistan? Again, unfortunately, we have mostly estimates. We don't have the actual numbers just like we have in the rest of the world. And for that, what happens most of the time, whose responsibility is, when we say it's the government responsibility, is it private institutions' responsibility or a private sector's responsibility? We keep blaming each other, but there are problems at all levels, whether it is a private sector or private universities. There's a lack of commitment, lack of expertise, and also there is a financial concerns as well. And when it comes to government again, unfortunately, there are not that many professionals. There is a lack of awareness. There are lack of resources and lack of political will as well. And that's why our budget towards health is much lower as compared to other things. So I think with this background, we really need to have our own data to really see what is going on, and then only we can plan what over next 10 or 15 years what we need to do in order to be able to do something about these issues. And believe me, the cardiovascular disease is really growing at an epidemic rate and at a much younger age in I was in the US for 15 years. I never saw a 30-year-old or even 40-year-old. Was very rare to see an MI or ACS. Or over here, it's quite common. We see every day or every other day patients so young, even 20s and 30s with acute coronary syndromes. So that's where I always, when I started seeing these patients many years ago, when I came back, younger population, so rampant, so bad, so diffuse disease in the coronary arteries, I wanted to do something about it, but it's unfortunately not that easy to get the funding and to do the research, especially when you are based in a private sector. It is very difficult, but I always wanted to do it, and I had really been working on this for many years on these two projects. One is called Pak Sehat, which is a Pakistan study of premature coronary atherosclerosis in young adults, and eventually I was able to get a funding from one of the pharma companies, Gets Pharma, unrestricted educational grant. This study is going to be the first study in South Asia, a longitudinal study of young people who are not diseased right now over 10 years. We will follow them regularly, and this is going to be a $5 million project, and we have just started this study, and I'll quickly show you what we are going to do in this study. And the second one, which I started again, is the Cardiac Registry of Pakistan. We don't have really the registries, and it is very important. When I talk about the registry, I'll show you why it is important, but we need to see what we are actually doing. And I've been able to work on this for almost like 10 years now, and luckily now, at present, all cath labs in Pakistan have to put a data in this online registry, and we will have enough data to see what is going on and what we can do basically to prevent or plan strategies to counteract these issues. When we started Pak Sehat study, we had international collaborators. We formed a steering committee from all over the world. We had this from Spain, USA, and from AKU. This is the steering committee which had been running. Again, we formed a core team for in different areas. We made sure that we have all the basic requirements for running such a study on long-term basis. We selected certain centers from all over Pakistan to make sure it represents all those centers and have a population which is really representing the whole Pakistan. So objective of the study basically was we really needed to determine, as I said, we don't even know the prevalence of the disease or what is the incidence. So we decided that we will, with this, we are going, with the help of biostatisticians, we decided that we'll be selecting 2,000 patients and following them over long term. And in order to find out, they will be healthy usually, have no problems right now, we'll get some baseline labs and CT, angio and other things which I'll show you quickly. And then we will follow them over next 10 years and see what happens to them and determine the prevalence, incidence, and the rates of atherosclerotic cardiovascular disease. We will be also looking at the risk factors these young or relatively healthy people may have. We will be also looking at the plaque burden in the coronary arteries and carotid arteries to find out how that progresses in these and why we have this kind of a disease in younger people. We'll be looking at socio-cultural factors and also health outcomes. Ethnic and cultural background will be closely looking at their habits, their socio-demographic factors, their past medical history, hereditary and genetic risk factors, and obviously looking at cardiovascular health and mental health as well. So basically this, we will have a baseline, midline and end line in these patients. We'll be doing a screening and lab test and also getting a CT angiography in all these patients and also looking at the carotid intima media thickness, which again is a surrogate or a marker for atherosclerotic vascular disease. So we'll be looking at baseline, and then at midline we will follow the lab test and do the CT scan, do the lab test and the screening. And at the end line, at the end of 5 or 10 years, we'll be looking at lab tests, CT angio and screening again. So this is how we basically, again, with the help of the biostatistician, we decided that 2,000 individuals will be good enough to follow them from different provinces of Pakistan. Again, the numbers were proportionally divided as per the population. So at first point of contact, we'll take the consent, we'll screen them, have an interview, and also get a body composition. We have a special device which is going to tell us how much body fat content they have and their baseline weight, height, and all those things. And at second point of contact, we'll get the labs from their homes. So we have hired lab people who will do it from home labs. And then eventually we'll have CT angiography and carotid intima media thickness. So we'll be doing all these labs and everything at baseline. We'll do the screening, data collection tool. We have inclusion and exclusion criteria. We'll get all the data which is going to help us, medical history, socio-economic factors, passive active smoking and all those things, risk factors. We have devised an app to collect all this data. There are all socio-demographic factors and all the screening tool in there. We'll get the CT angio, as I said, we'll get the ultrasound of carotids in all these patients as baseline at the end line. And we made sure that we follow all the international standards to run such a kind of longitudinal study. We have hired the Chugthai lab that will be taking these samples from home in all these patients. And one of the major risk factors, which may be one of the common factors that has been found it's high in South Asian, is lipoprotein little a will be following in all these patients also. We have again acquired insurance for these patients. If there is any problem, we are going to give some incentives to the volunteers for this study. Recruitment and data quality, we have hired a very well-reputed PHC global firm who is going to help us to collect all this data. And then we have baseline completion times based on how much we are going to collect. So lastly, the cardiac registry of Pakistan, I think science really tells you what you are doing, and the guidelines tell you what you should do, but actually the registries tell you what you are doing. So we read and we see the science, but what we are actually practicing, that is only comes from the registries, and that's why it is very important to have this registry. We need a centralized, comprehensive database, quality patient care, to improve the quality patient care, that's going to be important. So it will be a central database, online database, which will be entered in the computer. It was initiated of Tabba Heart Institute. We developed this software similar to American College of Cardiology's central database, which is NCDR, and Pakistan Society of Interventional Cardiology and Health Research Advisory Board is part of it. And we are running several registries. Right now we have a cath PCI registry. We have also started a heart failure registry. We are working on acute coronary syndrome registry. We are working on device, ST elevation MI, and registry of heart disease in pregnancy. And it's going to be, as I said, online. We can really check all the parameters, appropriate use criteria, door to balloon time, overall mortality. This is eventually going to help us to improve the outcomes, reduce our errors, improve the systems. We have been able to improve our own system so well after we started this that it is unbelievable how this helps you overall. And then for research and publication, it has a huge database which can be very good. We have very detailed TORs and MOU, and again, it's free of cost to everyone, although NCDR charge you $50,000 a year to enter the database and get this. We are providing everyone free of cost. And this basically, recently we presented the data to in Pakistan Society of Interventional Cardiology meeting Park Live 5-year trends, and now we have a database of almost 600 variables for almost 100,000 patients. So you can imagine how much database we have and what we can, and we are working on how we can use this data to help us overall. There's a software available, and it's, as I said, it's online. Everything is a drop-down menu, very easily. We can fill that. As I said, we have started the heart failure registry as well, which can be easily done. So I think we all need to work together, and that's the only way we can succeed. I think single individually, if I keep working somewhere, that's not going to help me. So if you really want to go fast, go alone, but if you want to go far, we need to work together. And I'm sure meetings like this and the initiatives by institutions or universities like this and working together, bringing everyone together is going to help us a lot to further progress, inshallah, and Pakistan will be able to achieve its improved health outcomes and research outcomes and establish a research ecosystem as well. With that, I would say thank you very much for inviting me once again.
Thank you very much, sir, for your wonderful talk. The next speaker that we have is Professor Dr. Anila Ataur Rahman. Professor Dr. Anila Ataur Rahman is serving as Professor of Community Medicine and Public Health Sciences Department at LUMHS. She has served as a former Vice Chancellor of Shaheed Mohtarma Benazir Bhutto Medical University, Larkana. She has the unique honor of not only to be the first ever lady Vice Chancellor of any medical universities of Pakistan. She also has the honor to be selected as the first ever PhD scholar from any medical university of Pakistan and become the first ever public health professional to achieve the doctorate degree in dual subjects of epidemiology and public health, in addition to double masters from UK and Pakistan as well. Dr. Anila is a renowned researcher, epidemiologist, biostatistician, and has more than 44 research papers published in international and national journals of repute with a total impact factor of 81.221. Her title of talk is very relevant to the theme of this summit, and that is on Goal 13, take urgent action to combat climate change and its effect.
Smile and learn.
Hello, friends.
May I start with the permission of Chair? Is everything? Okay. Thank you very much. So today my topic is goal number 13 for the climate change. And it has several sub-themes. But before, I'm very much uncomfortable here. So it's better to speak from... Hello. Ji, so these are 17 sustainable goals. برازیل کا ایک بڑا خوبصورت شہر ہے ریو. وہاں پہ 2012 میں کانفرنس ہوئی اور وہاں پہ یہ ڈیسائیڈ کیا گیا, یو این کانفرنس تھی, کہ جو 8 ملینیم ڈیولپمنٹ گولز ہیں وہ کسی کام کے نہیں ہیں. دوز آر ویری امپریکٹیکل گولز. اور ہم لوگ, میں اپنے آپ کو تالاب میں بہت چھوٹی سی مچھلی سمجھتی ہوں, لیکن میں جہاں بھی گئی, دنیا کے کسی خطے میں بھی گئی, ملینیم ڈیولپمنٹ گولز پہ جب مجھے بات کرنے کے لیے کہا تو میں اس کے سخت اگینسٹ بولی تھی, کیونکہ دوز گولز ور ویری امپریکٹیکل. وہ اچیویبل نہیں تھے, اتنے براڈ تھے کہ سمجھ میں نہیں آتا تھا کہ ہاؤ از اٹ پاسبل کہ ایون دا ڈیولپ کنٹریز کے لیے جو یہ ٹاسک ہے وہ امپاسبل ٹاسک تھا. اس کے بعد جب انہوں نے دیکھا کہ انڈر ڈیولپڈ اور ڈیولپنگ کنٹریز تو چھوڑ دیں, لیکن ڈیولپ کنٹریز بھی اچیو کرنے کے پوزیشن میں نہیں رہیں, دین دے شفٹیڈ ٹو دیز 17 goals. And every goal is interrelated. Actually, these goals are the commitment. Commitment that seeks to address the most urgent and crucial public health problems. جتنے بھی ہمارے ہاں جو بھی پرابلمس ہیں, وہ میڈیکل پرابلمس, سوشل پرابلمس, جو بھی پرابلمس ہیں, نیچرل کلیمٹیز ہیں. ابھی ہمارے پاس اتنا بڑا ڈیزاسٹر ہوا فلڈ کا, دین اس سے پہلے ہمارے پاس اتنا بڑا کووڈ پورے دنیا کو کھا گیا, نگل گیا. تو دیز آر ویری مچ انٹر ریلیٹڈ. میرا جو ٹاپک ہے وہ دیٹ از کلائمیٹ ایکشن, اینڈ دیٹ از دا موسٹ امپورٹنٹ ٹاپک ناؤ اے ڈیز آف یونائٹیڈ نیشن, آف ہول یونیورس. اور ہمارا جو ایٹماسفیئر ہے, ہمارا جو یہ خطۂ ارض ہے جس میں ہم رہتے ہیں, وہ ایک کال دے رہا ہے, ایمرجنسی کال دے رہا ہے, جو ہم میڈے 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 سن رہے ہیں کہ بچاؤ مجھے, I need your help to save me. Why they need help from human being? Because جتنی بھی پرابلمس ہیں جو ایٹماسفیئر کو خراب کر رہے ہیں وہ مین میڈ ہیں. تو جنہوں نے یہ پرابلمس بنائی ہیں, سولوشن بھی وہ لوگ ہی نکالیں گے. یہ قدرت کی طرف سے کوئی چیز نہیں آئے گی کہ ہمارے دماغوں میں چلی جائے گی اور ہم کہیں گے کہ ہم یہ چیز اللہ میاں نے کر لی ہمارے لیے. ہمیں اللہ نے بنائے اس وجہ سے وی آر اشرف المخلوقات, کہ ہم نے جو پرابلمس بنائے ہیں, اور میں آپ کو بتا دوں کہ وی ہیو 200 ملین پرابلمس, وی ہیو 200 ملین سولوشنس آلسو. سو مائی ٹاپک از کلائمیٹ ایکشن. بٹ اگر آپ دیکھیں اس میں میجورٹی ٹاپکس ایسے ہیں, ایون نو پاورٹی, یہاں سے نو پاورٹی ہے. اس کے بعد سیکنڈ جو ہے وہ ہے یور زیرو ہنگر, دین گڈ ہیلتھ اینڈ ویل بینگ, کوالٹی ایجوکیشن, جینڈر ایکولیٹی, جتنے بھی آپ کریں, سیف واٹر ہے, بہت ساری چیزیں ہیں. جب تک یور کلائمیٹ از ناٹ سیف, جب تک آپ کے پاس نیچرل ڈیزاسٹر کم ہونا نہیں شروع ہو جائیں گے. آپ اندازہ لگائیں کہ سیلاب آیا, सब कुछ बहा कर ले गया। 6 महीने पहले पानी से डूबने वाले लोग 6 महीने के बाद पानी की बूंद के लिए तरस रहे हैं। सारे इंफ्रास्ट्रक्चर तबाह हो गया। आप एजुकेशन कहाँ से देंगे? ये गोल कहाँ से अचीव करेंगे? आपके पास साफ पानी नहीं, आपके पास स्कूल नहीं, आपके सारे जो BHUs थे वो बर्बाद हो गए, आपकी हॉस्पिटल्स बर्बाद हो गई। आई वॉज दैट टाइम वाइस चांसलर ऑफ शहीद मोहतरमा बेनज़ीर भुट्टो मेडिकल यूनिवर्सिटी। पूरी यूनिवर्सिटी डूब गई। हमारी टीचिंग हॉस्पिटल के दूसरी मंजिल तक पानी आ गया था। तो हम पागलों की तरह फिर रहे थे कि हम लोग क्या करें। इस सूरत हाल में जब तक हम क्लाइमेट को कंट्रोल नहीं करेंगे, क्लाइमेट चेंजेस को कंट्रोल नहीं करेंगे, और पाकिस्तान की अगर मैं बात करूं तो हम तो वैसे ही बहुत ज़्यादा बदनाम हैं बहुत सारी चीज़ों में। जो बुरी बात आती है ग्राफ में हम सबसे ऊपर होते हैं। गुज़िश्ता 20 साल से वी आर अमंग द लिस्ट ऑफ 10 वर्स्ट कंट्रीज जिसमें इतनी क्लाइमेट ने तबाहियां लाई हैं। और गुज़िश्ता 20 साल में 173 नेचुरल डिजास्टर्स हुए हैं, जिसमें मोर देन $4 मिलियन का लॉस हुआ है पाकिस्तान जैसे गरीब मुल्क का, जो कि अब बैंकरप्सी के वर्ष में हम लोग आ गए हैं। सो this is my topic. The skeleton of my presentation is goal number 13, the climate change, causes of climate change, effects of climate change, remedial actions, and individualistic approach. Key features of goal number 13 is improve education, awareness raising, then human and institutional capacity on climate change, जिसमें हम मिटिगेशन करेंगे और उसके बाद हम एडाप्टेशन करेंगे, इम्पैक्ट रिडक्शन करेंगे, एंड अर्ली वार्निंग। दीज आर द की कंपोनेंट्स ऑफ गोल 13. Now this is the picture of different things. We have glaciers, we have roads, we have ozone, and we have so many things, but we all confused with so many things. We have climate, we have weather, we have atmosphere. अगर यहाँ पे हाल में बहुत सारे माशाल्लाह पढ़े लिखे लोग बैठे हैं, अगर मैं किसी से पूछूं कि what is difference between climate and weather, कोई नहीं बता सकेगा, या कोई बताएगा भी तो उसके पास बहुत बता सकोगे, चलो अच्छी बात है, लेकिन ऐसे चंद लोग होंगे जो बताएंगे। यहाँ पे एक कोई आए मेरे के लिए इसको वीडियो को चला दे। एक छोटी सी वीडियो है, मैं बहुत ज़्यादा ड्राई सब्जेक्ट था मेरा, तो मैं इसको ड्राई नहीं बनाना चाहता।
Smile and learn.
Hello, friends! Today we're going to learn what climate is. Climate and weather are closely related to one another, but they are different concepts. Do you know the difference? The weather is an atmospheric situation which occurs in a given moment and in a specific place. Look outside the window. What's the weather like now? Is it cold or hot? Is it rainy, cloudy, or windy? Very well. You're observing the weather. In contrast, the climate is the combination of atmospheric conditions that occur in a place for a prolonged period of time. For example, the predominant climate in Central American woods is the tropical climate because these are hot and humid places with heavy rainfall during summer. The factors that affect the climate are latitude, altitude, landscape, nearby seas, or sea currents. Because of these factors, the elements that make up the climate, temperature, precipitation, humidity, pressure, or winds, vary from one place to another. Did you know that there are different types of climates on Earth? There's a big variety, and every one of them has its own characteristics. We can divide them into hot, temperate, and cold climates. Let's learn more about some of them. The equatorial climate, the tropical climate, and the desert climate are hot climates. The countries near the equator have an equatorial climate. This climate is characterized by being hot and humid owing to heavy precipitation. The temperature is mild, an average of 77 degrees Fahrenheit. The tropical climate is a characteristic of the areas near the tropics. It's a hot and humid climate with heavy rainfall during summer. The desert climate is found in places like the Sahara Desert, the Arabian Desert, the southeast parts of the United States, or a large part of Australia. Is characterized by being very hot and dry. Precipitation is very scarce. The Mediterranean climate, the oceanic climate, and the continental climate are temperate climates. The Mediterranean climate is located along the Mediterranean coast and some parts of its interior. Temperatures are high during summer and mild in winter. Precipitation is not heavy. It hardly rains during the summer months. The oceanic climate is a characteristic of the areas near the Atlantic Ocean and Central Europe. Temperatures are mild during summer. Precipitation is heavy and occurs in all seasons. The continental climate is a characteristic of Eastern European areas. Temperatures are high in summer and very low in winter. Precipitation occurs mainly in summer. The polar climate and high mountain climate are cold climates. The polar climate is located in places like Northern Europe, North America, Russia, or the North Pole. It is characterized by being the coldest climate on Earth. Temperatures range from -58 degrees Fahrenheit in winter to 50 degrees Fahrenheit in summer. Precipitation is scarce. The high mountain climate is found in the highest peaks of the mountain.
Now, this picture is showing all the disasters and what is causing the climate change. Why climate change? Shifts in weather pattern may be natural, such as through variations in solar cycle. But since 1800 जो हमारा इंडस्ट्रियल रिवोल्यूशन आया, उसके बाद human activities have been the main driver of climate change. Now the greenhouse gas emission. We have different sources for the greenhouse gas emission. Now here is the question that what is greenhouse? After one or two slides, I will show you what is the significance of greenhouse gases, how greenhouse gases are important for us. But these are the different sources of emission, जिसमें एनर्जी सप्लाई जो हम फॉसिल फ्यूल जलाते हैं, कोल जलता है, ऑयल जलता है, एनर्जी प्रोड्यूसिंग जो भी है, वो 34% कंट्रीब्यूट करती हैं इन द एनवायरमेंट, इन द पॉल्यूशन, एटमॉस्फेरिक पॉल्यूशन. उसके बाद हमारे पास जो सेकंड नंबर पे है दैट इज़ इंडस्ट्री. इंडस्ट्रीज जो हैं वो वन ऑफ द बिगेस्ट कंट्रीब्यूटर्स हैं, 24% हैं. एग्रीकल्चरल, फॉरेस्ट्री एंड लैंड यूज 22% है. अपरेंटली हम ये कहते हैं कि हमारे पास लैंड्स हों, एग्रीकल्चर, अब हमारा कंट्री मेनली है ही एग्रीकल्चर कंट्री, लेकिन आपको आगे चल के पता चलेगा कि हाउ मच इंजूरियस दिस एग्रीकल्चरल एंड फॉरेस्ट्री एंड लैंड यूजेस. देन वी हैव ट्रांसपोर्ट, गाड़ियाँ, हर घर में 10-10 गाड़ियाँ हो गई हैं. किसी ज़माने में ये होता था कि एक शहर में कहते थे बाबा ट्रेन मानन बट मोटर आ, अब एक घर में 10-10 गाड़ियाँ हैं. उसका मतलब इरेशनल यूज़ है हमारे यहाँ हर चीज़ की. देन बिल्डिंग्स हम बनाते जा रहे हैं. वी हैव گیٹوز اینڈ کچی آبادیز اینڈ ایک مشروم گروتھ ہے. آپ ملیر کینٹس پہ جائیں تو پتہ ہی نہیں چلتا. 2 سال پہلے گئے آج گئے تو لگتا ہے کہ 50-60 اور بلڈنگس ہماری کھڑی ہو گئی ہیں. ہر ایک کا انوائرمنٹ پہ بہت نیگیٹو امپیکٹ ہے. دا بگ 3 جو مین 3 کلپریٹس ہیں, دیٹ از کول, آئل اینڈ گیس, covered 85% of our energy demands in 2019. Burning fossil fuels emits 50 billion tons of greenhouse gases annually. Methane contributes 16% and nitrous oxide 6% to greenhouse gas emission. سب سے زیادہ کاربن ڈائی آکسائڈ ہمارے ہاں جا رہی ہے, لیکن اس سے زیادہ کہیں ڈینجرس ہمارے لیے میتھین اینڈ نائٹرس آکسائڈ ہے. دین ڈیفارسٹریشن. ڈیفارسٹریشن اینڈ ایگریکلچر پروڈیوس 1/5 آف ایمیشنس. ڈیفارسٹریشنس کے بہت سارے ریزنس ہیں. ون آف دا مین ریزن از ٹو پروڈیوس پیپر. پیپر بنانے کے لیے اب آپ انگلینڈ امریکہ جائیں گے, آپ کو جیسے وہ سگریٹ زون بنائے ہوئے ہیں کہ سارے ایریاز نان اسموکر ہیں, کونے میں جا کر وہ پھونکتے ہیں. ادھر وہاں پہ اٹس پیپر فری انوائرمنٹ. میں ابھی گئی ہوں اپنی یونیورسٹی میں, ناٹنگھم یونیورسٹی میں, کوئی پیپر کا کہ ہم اب یوز نہیں کرتے, کوئی لیٹر نہیں جاتا, ایوری تھنگ از تھرو ای میل. ٹھیک ہے. تو ڈیفارسٹریشن کے یہ ڈیفارسٹریشن کا ایک مین ریزن اب میرے سامنے جو آیا, ہم کیا کر رہے ہیں, درخت کاٹ رہے ہیں, درخت کاٹ کے ہم فرٹائل لینڈز بنا رہے ہیں, اور فرٹائل لینڈز جو ہے وہ ویری ڈینجرس بیکاز وی آر یوزنگ دیز فرٹیلائزرس. اگر فرٹیلائزرس کے بغیر کریں, آرگینک ہم بنائیں, تو وہ ہمارے انوائرمنٹ کو قدرے بہتر کر دیں گے. اچھا, اس کے بعد nearly 2/3 of nitrous oxide emissions and half of the methane emissions are from agriculture. میں پہلے ہی بتا چکی ہوں. Livestock is another contributor to methane emission. Pakistan is one of the biggest contributor in methane pollution. اور ہم سگنیٹری بھی ہیں, ہمارا یہ پلیج بھی ہے. کلائمیٹ چینج کی جو منسٹری ہے, کلائمیٹ چینج کی جو ٹاسک فورس بنی ہوئی ہے, اس نے یہ جا کر پلیج لیا ہے کہ ہم پاکستان کو میتھین فری بنانے کی کوشش کریں گے 2030 تک. اللہ کرے کہ ایسا ہو جائے. سو دس از گرین ہاؤس افیکٹ. یہ جو آپ کو نظر آ رہی ہے ایک blue line, this is your atmosphere, and in the atmosphere you have greenhouse gases. Carbon dioxide hoti hai mainly, then you have also this nitrous oxide and methane there. Lekin carbon dioxide itni hoti hai jitni کہ آپ کے پاس سورج سے شعائیں آتی ہیں, ہٹ کرتی ہیں ارتھ سرفیس کو. کاربن ڈائی آکسائڈ کا کام کرنا کیا ہوتا ہے کہ وہ ریٹین رکھتا ہے اتنی ریڈیشنز, اتنی انرجی, اتنی گرمی جتنی اس ارتھ کو چاہیے, جتنی وارمتھ ہمیں چاہیے. اب اگر آپ ٹنوں کے حساب سے کاربن ڈائی آکسائڈ چھوڑ رہے ہیں, نائٹرس آکسائڈ آسمان میں بھیج رہے ہیں, ایٹماسفیئر میں جا رہی ہے, میتھین جا رہی ہے, تو لیئر تھک ہوتا جا رہا ہے. جتنا کاربن ڈائی آکسائڈ کا لیئر تھک ہوتا جائے گا اتنی وارمتھ زیادہ کیچ کرے گا, اور اسی وجہ سے کہتے ہیں کہ دس از گلوبل وارمنگ. اٹس ویری سمپل تھیوری. ہوتا کیا ہے کہ جب نارمل لیئر ہوتی ہے کاربن ڈائی آکسائڈ کی, تو وہ جب جتنی اس کو ضرورت پڑتی ہے باقی وہ واپس ایٹماسفیئر میں بھیج دیتا ہے. تو ہماری جو ضرورت ہے زندگی, اگر یہ ایٹماسفیئر ہٹ جائے تو ہم -18 سے -56 کے ٹیمپریچر میں چلے جائیں اور یہ دنیا ختم ہو جائے. ایٹماسفیئر از سو امپورٹنٹ. اب دیکھیں جی, یہ نیچرل ہے گرین ہاؤس افیکٹ. ہیٹ آئی, سولر ریڈیشنس آئیں, اپنے وارمتھ کے لیے کاربن ڈائی آکسائڈ نے رکھا, اور باقی جو ہے واپس انوائرمنٹ میں بھیج دیا. یہاں پہ آپ کو ایٹماسفیئر بلو کہیں نظر نہیں آ رہا, یہاں پہ آپ کو سارا ریڈ نظر آ رہا ہے, اور سن بھیج رہا ہے سولر ریڈیشن, اور بہت کم جو ہے ہیٹ ہماری اومیٹڈ ہو رہی ہے. تو یہی وجہ ہے کہ ہمارے ہاں گرمی اور ٹیمپریچر رائز ہو رہا ہے. اب واٹ از ایٹماسفیئر؟ The thin envelope of gases forming a protective covering around the earth, and it is retained by the earth's gravity, and it is highly compressible. میں آپ کو پہلے ہی بتا چکی ہوں کہ یہ جو ایٹماسفیئر ہے ہم بہت گھچڑی بنا دیتے ہیں, وی ہیو کلائمیٹ, وی ہیو ویدر, وی ہیو ایٹماسفیئر, لیکن ایکچوئل پتہ نہیں ہے کہ واٹ از ایٹماسفیئر. اینڈ دیز آر دا ڈفرنٹ لیئرس آف ایٹماسفیئر. پہلا جو ہے ٹروپوسفیئر, جو ہمیں نظر آتا ہے, جو ہم باہر نکلتے ہیں تو جو باہر ہے دیٹ از ٹروپوسفیئر. دین اسٹریٹوسفیئر, میں اوپر نہیں جاؤں گی. اسٹریٹوسفیئر از دا موسٹ امپورٹنٹ لیئر آف دا ایٹماسفیئر. جو ہم کہتے ہیں کہ اوزون لیئر ختم ہو رہی ہے, ایک ہول بن رہا ہے, وہ آپ کے سیکنڈ لیئر میں اسٹریٹوسفیئر لیئر میں ایٹماسفیئر کے بن رہا ہے. وہ کیوں بن رہا ہے؟ وہ اٹس ناٹ ریلیٹڈ ود کاربن ڈائی آکسائڈ, اٹ از ناٹ ریلیٹڈ ود میتھین, اٹ از ناٹ ریلیٹڈ ود نائٹرس آکسائڈ, کسی سے نہیں ہے. یہ پھر جو ہمارے ریفریجریٹرس اور ہماری جو ماشاءاللہ اے سیز ہیں جو ہم چلاتے ہیں, اس میں سے کلورو فلورو کاربانس نکلتی ہیں جو اوزون لیئر کو ختم کر رہی ہیں. ناؤ کوشچن ہیئر از کہ ہم کہہ رہے ہیں کہ بھئی گلوبل وارمنگ ہو رہی ہے, اس وجہ سے اسپیلس آئیں گے ہاٹ ویدر کے, کولڈ ویدر کے. ٹیمپریچر تو بڑھ رہا ہے تو کولڈ کیوں ہمارے پاس ویدر ہوگی؟ کولڈ تو نہیں ہونی چاہیے. ہوتا کیا ہے کہ جب یہاں پہ یہ آپ کا جو فرسٹ لیئر ہے ٹروپوسفیئر, جو ہمیں اوپر سے نظر آتا ہے جب ہم باہر نکلتے ہیں, جب اس میں گرمی بڑھ جاتی ہے تو اسٹریٹوسفیئر جو ہے اس میں ویسٹرلی ونڈس ہوتی ہیں, بہت ٹھنڈا ہے. آپ جہاز میں چڑھتے ہیں, تھوڑا اوپر جاتے ہیں تو آپ کو بتایا جاتا ہے -18 میں آ گئے, وہ اوپر جاتے ہیں -46 میں آتے ہیں. یہ کیا ہے؟ آپ اس اسفیئر میں چلتے ہیں اس وقت. اب اس میں کیا ہوتا ہے, نیچے ہیٹ ہے, اوپر ٹھنڈ ہے, اس میں کھلبلی مچا دیتے ہیں. اور جب کھلبلی مچا دیتے ہیں تو وہ علاقے جو اسپیشلی نارتھ پول پہ جن کا ہائی الٹیٹیوڈ ہے یا جن کا لیٹیٹیوڈ اوپر ہے, وہاں پہ ایکسٹریم کولڈ ویدر کے اسپیلس آتے ہیں ڈیو ٹو ڈسٹرپشن ان دا سیکنڈ لیئر آف دس ایٹماسفیئر. یہ میں نے آپ کو پہلے بھی بتایا, لیکن اگر بہت سائنٹیفک وے میں آپ کو بتانا شروع کر دوں گی, وائی اٹ از کولڈر اف دیر از اے گلوبل وارمنگ. Global warming can cause winters to be colder and more severe. In a study published in Science in 2021, researchers found that the warming in the Arctic causes a disruption in stratospheric polar vortex. جو ہوا ونڈ چلتی ہے ٹھنڈی, اس میں ڈسٹرپشن ہوتی ہے, اور پھر اس کے بعد جو ہے وہ ایکسٹریم ویدر ٹھنڈی بھی آ جاتی ہے along with the extreme hot weathers. Now this is the graph of greenhouse gas emission by countries. The main culprit is always United States. ہمارے لیے تو بہت ہی بڑا کلپریٹ ہے. سیاسی بات نہیں کروں گی, لیکن جو سچی بات ہے وہ ضرور کروں گی. اور اس کے بعد اگین چائنا. جتنے ورلڈ پاور ہیں جو دنیا پہ آج کل راج کر رہے ہیں, وہ مین کنٹریبیوٹر ہیں کاربن ڈائی آکسائڈ ایمیٹنگ کنٹریز میں. اور سفرر ورس کون ہیں؟ وی پیپل. ہم ایشینس, ساؤتھ ایشینس, افریقن, میڈیٹیرینس, ہم لوگ جو ہیں ورسٹ افیکٹی ہیں. تو دس از اے گراف. US emits 25% of world carbon dioxide. China is second. 28 European countries have 22% to global emissions. Lower income countries have played less. The entire Africa's contribution of carbon dioxide emissions is only 3%. اور آپ بتائیں کہ وہاں کا کیا حال ہے. لوگ بھوک کے مارے مر رہے ہیں, لوگ ڈراؤٹ کے مارے مر رہے ہیں, فیمائن کے مارے مر رہے ہیں, کچھ نہیں ہے ان کے پاس. The richest half of the world emits 85% of global carbon emission annually. Greenhouse gases, پڑھ لیں, carbon dioxide levels are reaching 2 million years high. Earth is 1.1 degree centigrade warmer than 18. یہ ہمیں نظر آ رہا ہے کہ 1.1 ڈگری سینٹی گریڈ, اور 1800 سے اب تک جو اتنا ہوا ہے کچھ نہیں. یہ اٹس ویری الارمنگ. اگر یہ 1.1 کو آپ اس میں نہ دیکھیں کہ یہ ایک ہے, نہیں, اس طرح سے نہیں ہے. اس کو یوں سمجھے کہ ملینز میں بڑا ہے, اس کا امپیکٹ اتنا ہے. 2011 سے 20 تک واز دا وارمیسٹ ڈیکیڈ ایور. اور اس دفعہ ہمارے ہاں پاکستان میں اپریل جو تھا 60 سال کا ریکارڈ توڑا تھا, اتنا وارمیسٹ تھا وہ ہمارے ہاں. تو یہ دیکھیں کہ بڑی 1.1 ڈگری سینٹی گریڈ ہے, لیکن اس کا امپیکٹ ہمارے پاس کتنا آیا ہے. اور سیلاب نے جو ہمارے ہاں تباہی مچائی ہے اس کا تو آپ نے خود دیکھا ہے اپنی آنکھوں سے. Since 1850, humans have emitted 2400 gigatons of carbon dioxide. Climate change, جنگلوں میں آگ, famine, drought, melting glaciers, اور بہت ساری چیزیں. Serious concern for humanity. Glaciers shrink ہو رہے ہیں. Warming has melted Greenland and Antarctica's ice sheets. میں خود گئی ہوں الاسکا, ہمیں لے گئے کروز پہ, نارتھ پول یوں میلٹ ہو رہا تھا. مطلب تکلیف ہو رہی تھی, جو جانتے تھے ان کو بہت تکلیف ہو رہی تھی کہ یہ ہمارا, کیونکہ یہ ہماری پروٹیکشن ہے. یہ گراف ہے کہ 1953 میں ہمارے گلیشیئرز پہ اس طرح سے برف تھی, وہی گلیشیئر ہے 2019 میں. آپ دیکھیں کہ آلموسٹ جو ہے وہ سنو آئس فری ہو چکے ہیں. یہ رائزنگ سی لیولز, سونامیز آ رہی ہیں, ریئرلی کبھی سنا تھا بچپن میں. اب آپ دیکھیں کہ کتنی کنٹریز ہیں. کچھ سال پہلے انڈونیشیا میں آئی, تباہی مچا دی, جاپان میں آئی, بہت سارے اور کنٹریز میں آ رہی ہے. تو رائزنگ سی لیولز, اوشین ایسیڈیفیکیشن, میرین لائف تباہ ہو رہی ہے. ٹھیک ہے. اس کے بعد آپ کے پاس فوڈ شارٹیجز اینڈ فیمائن ہے. ہیٹ اینڈ ڈراؤٹ مائٹ کاز famines in the worst hit regions. If emissions keep rising at the current rate, a third of global food supply might be at risk by the end of the century. The IPCC predicts climate change would cause 183 million more people to go hungry. Food shortage and famine, then wildlife migration and extinction. یا تو وہ جہاں کے اسپیشیز تھے وارم ہونے کی وجہ سے وہاں کو چھوڑ کے آ رہے ہیں, یا پھر مر رہے ہیں. Animals are migrating to avoid rising temperature and wildfires. Especially آسٹریلیا میں یہ بہت بڑا پرابلم ہے, امریکہ میں بہت بڑا پرابلم ہے. The loss of species is frightening. An estimated 1 million species are risk of extinction, many potentially within decades. ہمیں جانوروں کا خیال نہیں ہے, ہمیں صرف بھینسیں, گائیں, گدھے, بکریاں اچھی لگتی ہیں. لیکن ویسٹرن ورلڈ میں اس کے بالکل الٹ ہے. ہمیں وہ چیزیں اچھی لگتی ہیں جو صرف ہمیں کام دیتی ہیں. اپرنٹلی ہمیں لگتا ہے کہ ہمیں گھوڑا چاہیے, ہمیں گدھا چاہیے. خیر اس پہ تو میں بات نہیں کرتی ہوں کہ گدھا چاہیے پہ. اچھا گدھا چاہیے, اس کے بعد پھر ہمیں بھینسیں چاہیے دودھ کے لیے, گائے چاہیے بھینس کے لیے, بکری چاہیے بھینس کے لیے. لیکن ویسٹرن ورلڈ از ٹوٹلی ڈفرینٹ. وہ چھوٹے سے چھوٹے اسپیشی کا خیال رکھنے والے لوگ ہیں, تو ان کے لیے یہ ایک بہت بڑا پرابلم ہے. مائٹ بی ناٹ فار وی پیپل. Then extreme weather events, جو ہم نے اپنے آنکھوں سے اب دیکھا, کسی اور جگہ کی مثال ہم کیا دیں, ہمارے پاس جو سیلاب نے تباہی مچائی اور ابھی تک وہ ہے, وہ میرے خیال میں ہماری زندگی میں تو اس کو ہم اوورکم نہیں کر سکیں گے. ہو سکتا ہے کہ ہمارے جب بچے اتنے بڑے ہو جائیں تو پھر وہ دیکھیں کوئی prosperity. Heat waves are 5 times more frequent and persist longer than before. The chance of 1 in 50 year heat wave will increase 9-fold under 1.5 degrees centigrade. Once a decade rainstorms are now 1.3 times more probable and 6.7% wetter. Once a decade droughts now occur 70% more frequent in even 5 or 6 years. Most important for me at least, worsen inequalities. Already ہم لوگ inequalities کا شکار ہیں. کلائمیٹ ہو, کلائمیٹ کا تھریٹ ہو یا نہ ہو, سب آپ پڑھے لکھے ہیں, سب آپ جانتے ہیں کہ اس کی کیا امپورٹنس ہے اور کیا ہو رہا ہے ہمارے ہاں. Low lying coastal areas will flood and become uninhabitable. Then drought cause hunger and burning. Despite releasing the least carbon, the Pacific area suffers the most from the climate change. Climate change will force mass migration, increase climate refugees. By 2050, over 1 billion people could be displaced, causing political and social upheavals. Remedial actions for climate change. Carbon production must halt immediately and to reach net zero. ہمارے ہاں US نے اور European countries جو they are main emitters of these carbon dioxide gas, تو انہوں نے پلیج لیا ہے کہ by 2030 جہاں پہ ہماری سسٹینیبل گولز کی اینڈ ہو رہی ہے, جہاں پہ ہم نے کہا تھا کہ 2000 started from 2015 and at 2013 ہمیں 15 years ملے ہوئے ہیں, 7 سال ہم لوگ اس میں سے نکال چکے ہیں. Now we have 8 years. ہم نے پلیج لیا ہے کہ we will bring net zero of methane. پاکستان نے جو پلیج لیا ہے it is for the methane, اور US اور European countries نے net zero کیا ہے for carbon. Let's hope for good. Several countries including UK, China have pledged net zero by, لیکن net zero by کب کا ہے, by 2050, not by 2030 اور 2060 تک بھی لے گئے ہیں. Urgent need to switch to renewable energy such as solar windmill. اب وابڈا والوں کو ہم برا بھلا کرنا چھوڑ دیں, اچھا ہے بجلی بند رکھتے ہیں کیونکہ اس سے نقصان ہوتا ہے, تو بہتر ہے کہ سارے سولر پینل پہ شفٹ ہو جائیں اور یا ونڈ مل لگا لے اپنے اپنے گھروں میں. ویسے بھی لگی ہوئی ہے تقریباً سب کے پاس, تو اس وجہ سے ہمارے وائس چانسلر صاحب آ گئے ہیں, اکرام صاحب, یونیورسٹی کو رینیویبل انرجی پر لے کر آئیں, اس کو سولرائز کر دیں تو ہم بڑے اچھے کنٹریبیوٹر ہوں گے ٹو ریڈیوس دا ایمیشن آف filthy gases and save our environment. Fixing energy infrastructure leaks, improving agricultural livestock, land management, fertilizer use نہ کریں. اب تو انگلینڈ اور امریکہ میں کپڑے بھی آرگینک مل رہے ہیں. حیران کن بات ہے کہ پوچھ رہی تھی کہ بھائی آرگینک سبزی تو ہو گئی, آرگینک اور بہت ساری کپڑے کہاں سے آرگینک ہو گئے. سو آتر مجھے وارن کر رہا ہے, تو اس وجہ سے this would also reduce nitrous oxide emission from overusing fertilizer and agriculture. Find a way to carbon removal, negative emissions, اور بہت ساری چیزیں ہیں. Natural methods of carbon capture, planting کریں, more trees, restoring coastal ecosystem. Hope exists. یہ سب سے اہم بات ہے کہ ہم سب امید پر زندہ ہیں, امید پر چلتے ہیں, اور جو گمان کرتے ہیں وہ پا بھی لیتے ہیں. تو اچھا گمان رکھیں, اچھا پائیں گے. If we reach net zero and remove emissions, warming could be reduced to 1.4 degrees centigrade by the end of the century, according to IPCC. What can you do with this goal number 13? ये चंद चीजें हैं. Recycle, reduce, reuse, conserve, and restore. ये चंद चीजें हैं जो हम पहले वाली स्लाइड में मैंने कहा था कि बैंक स्टेटमेंट्स नहीं बल्कि ऑल द यूनिवर्सिटीज, कॉलेजेस, ऑल द इंस्टीट्यूशंस शुड बी पेपर फ्री. इंडिविजुअलिस्टिक अप्रोच, हर एक की जिम्मेदारी क्या है? वी हैव टू रिमूव दिस कार्बन फुटप्रिंट जो हम अपने साथ लेकर हर कदम के साथ चल रहे हैं. ये सारी चीजें हैं जिससे हम अगर परहेज करना शुरू कर दें तो हम आसानी से इस चीज को काबू पा सकते हैं. लोअरिंग योर मीट, गोश्त कम खाएं, and dairy intake and going vegan can reduce the tons of carbon a year. एक simple step and healthy step है. Another albeit controversial method is simple but effective, have fewer children. तो जो contraception है, मैंने कहा था बहुत सारी चीजें interrelated हैं, सारे SDGs are interrelated. Fewer child save 58.6 tons of carbon emissions a year. Insulating your home can save 0.895 tons of carbon. Small steps, big difference. This is a quote. Thank you very much. I also welcome Professor Hakim Abdo. Welcome to Liaquat Medical University. Thank you very much. Ekram साहब तहाँ lead वठजो environmental free तहाँ हुआ भी LUMHS कोडन में lead आहे त environment friendly जो भी असां के ये honor मिले तो बेहतर आहे. Thank you.
Thank you, ma'am, for the wonderful talk. The next speaker we have is Dr. Shahid Qureshi. Dr. Shahid Qureshi is Pakistan originated citizen of United Kingdom. He's a consultant psychiatrist currently working at Pennine Care NHS Foundation Trust, Manchester, United Kingdom. He's a certified, thank you, okay.
Assalamu alaikum, and thank you, Professor Ansari and LUMHS for inviting me to take part in this wonderful conference. Over the last 2 days, I have enlightened myself with integrating healthcare with sustainable care development. I would start with the last speaker who started with globalization to individual solutions. And I'm going to talk about individual problems and its resolutions within the work that we do as trainers. It's not only about trainers, it's about other employees and subordinates. And I am really privileged to be speaking in front of LUMHS leaders. Vice Chancellor, I think the previous speaker was a ex-Vice Chancellor, and there are 2 deans that I know personally, both Ansaris, Moin, who I know personally through my profession, and Munawar as a baby brother of my best buddy from school days. I'm going to talk to you about trainees and difficulties. Now, this talk I normally do as a workshop. It takes a considerable time, but I'll try my best to concise it It's not going to be a lecture, and it's not a scientific talk. It's a practical talk. Neither it is an academic talk. It's a talk definitely has to be used by trainers, academics, professors, deans, vice chancellors like yourself to ensure that your students, your trainees are productive and contribute positively into this society. Like first speaker, I think it was cardiologist, Dr. Hanif, who spoke about some social deprivations and social injustice in the society and the two-tier level of healthcare system. Obviously, it is not something we can beat, but what we can do, what is within our power, that we help our trainees to be becoming a productive and excellent doctors. Now, it's not going to be possible that I run this as a workshop. You can see the agenda, but I'll try my best to finish it in 20 minutes that I don't overrun. Just think for a second in your own heads. I'm not going to ask you to answer me. I'm not going to ask you to reply. Just think in your heads. What do you think about a doctor in difficulty, a trainee in a difficulty, or an employee in a difficulty, or your subordinate in a difficulty? I'm sure you all leaders must come across your subordinates, your juniors, your trainees, your students who are not doing as well as you would like them to do. I'm sure most of you would have come with a similar concept that you as senior person, can I move around? Chatama thoro gumi saga to je point speaker gumi pe. Chojo natama kari pavandus ma kafi je ko hai so agitated restless insan hai ya tamane kalaye chha so ye mathe sandalan I'm sorry mic kane ka khair tahan je ko hai so ditho that one of your trainee or employee is not performing as well. Thank you. Hello, can you hear me? Now, that person has required unusual need of what you call attention, that you make sure that problems that person is displaying do not occur repeatedly. And this means that you are going to out of your box and going to do something extraordinary to help that person. I think this is the one. How do you use this? Hinaketa? Hiyan? Tika ma hita correct this tika. Warning signs shahin unan manun me jeke who are not performing well. Usually you'll find that these people do not come to work, often report sickness. They disappear. They are disappearing when you need them and when you're wanting them to come and attend. There's low work performance. They are not productive. They are not meeting the targets that you're asking them to achieve. Ward rage. Most often you'll hear the complaints from their juniors or nursing staff that this doctor is very rude, very angry. He does not listen. And they are very rigid in their work. There's a bypass syndrome. People who are junior to them or who are subordinate to them, they will not talk to them. They will just avoid them. ऐसा कोई वाइस चांसलर हो जिससे प्रोफेसर्स दूर भागते हों, ऐसा कोई प्रोफेसर हो जिससे क्या कहते हैं उसके असिस्टेंट प्रोफेसर, एसोसिएट प्रोफेसर्स भागते हों, ऐसा कोई डीन हो जिससे उसके प्रोफेसर्स भागते हों, या ऐसा कोई यानी कि लेक्चरर हो जिससे उसके स्टूडेंट्स भागते हों. This is something I'm talking about. I'm sure you would know. And career problem, these people are not progressing as well as you would expect them. Assistant professor, you expect them to become an associate professor, but they have not become associate professor on time because they may not have produced enough papers. Associate professor is not becoming a professor, or professor is not becoming dean. Insight failure, they do not have a personal, insight is a scientific term, but I'm sure most of us know. Insight means that self-awareness about personal limitations. And I'm sure leaders like Professor Anita, Anila, Atar Rahman, I know your husband, and the current Vice Chancellor and the deans, they would know the term called emotional intelligence. The emotional intelligence means people are aware of their own limitations and what they do, how it impacts other people. So these people often have, limited insight into their problems. And this can be a personal problem. This can be a professional problem. And this can be an educational problem. Personal problems often are health related, either a personal health or health of a family member, or their relationship problems. Zale murse je vich mein masalo aa, baran jo ko masalo aa, girlfriend jo ko masalo aa. Ya cultural change, gothama manu ayo aa, shahar mein jekin se manu hikre khas qism ja kapda pain tha, ya ma jare dadu ma Karachi was Sidh Medical College mein to khod side mein chokri hu, unlike in Chanka Medical College. Hikro cultural shock to the how people fit into that kind of a culture. And domestic pressures. Sometimes people have some domestic pressures to achieve certain things which are very difficult to achieve, balancing work and your home life. There may be interpersonal issues, drugs, alcohol, or personality problems, which I'm sure you know asani society mein kafi aam accident kesi acknowledge na kanda hai. Professional problems, I think I've touched upon it, that people are not performing well. Here conference hai, in conference mein Professor Moin Ansari tamam ghano kam kahna te tamam ghano pressure hundo. Tama he sab je can say meetings time te halan and smoothly halan and sab je can say on speakers they can we waqt te chen very coordination is zarurat hundi. And he is not somebody who can deliver this alone without his team who has been working with him. And unfamiliarity with inexperience or area of work. I mean, this work, I refer back to Professor Ansari, that this conference, he has provided opportunity of learning to a lot of his team people who have been working with him, that they are gaining some, what you call, leadership skills. Educational, again, they are not passing exams. FCPS जो इम्तिहान के पास कौन का वक्त थे उन्हें करे हो गया कौन तो वधी सके या माँ psychiatrist है मार्सी साइक के काना पास किया American diplomat हो अगे सिवरेट हो तो उन्हें मुख्तलिफ exams से था उन्हें achieve किया not having enough time to revise or prepare जो on calls तमाम घड़ियों या जेकन से seniors या जेकन pressures तमाम घड़ान तो ताहाँ ही targets meet कयो. Failure to achieving appropriate milestones and career progressions. Now, I'm going to talk about the system where I come from. So please don't feel that this cannot be implied, and I'm sure there would be systems. If you speak with Dean Ansari here, or your Vice Chancellor, they will be able to tell you and guide you. There will be some policies which are existing. All you have to do is find and learn. I've used these terms CS and ES. CS means clinical supervisor and educational supervisor. Clinical supervisor is the person who you work under. Educational supervisor is somebody who is overseeing your progress. Now this man, Stanwyck in 2012 said, it is a responsibility of educational supervisors to make sure that their trainees are progressing well and they are adequately supported to ensure development in their careers. And if we do not do that, which means that we will be failing ourselves as professors, deans, and vice chancellors. Department of Health also says it is important that you take care of your employees' health and well-being. Listen and respond to their concern. This thing that I'm talking to you is not only applicable in health. This can be applicable in any industry or in any organization where they have large number of what you call employees. Seek advice from human resource. I'm sure there would be a department of human resource in this university as well, who would be able to advise you and guide you about the policies these exist here. And now for counseling. I'm sure I will refer back to Professor Ansari, Moin Ansari here. He's a psychiatrist and he's a head of chairman of Department of Psychiatry as well, so I'm sure he will have some counselors and maybe some occupational health. And I don't know whether this is something you offer to your employees, but this is something should be offered. General Medical Council, like here PMC or PMDC, whatever you call it, they would have some procedures as well. If doctor is not performing well, they are not achieving what they should achieve, then if you're not supported them, it means their names might be erased or eradicated from register. So here we shall not be talking about punishment. I'm talking about supporting, helping your trainees that they can progress. NHS में because again NHS National Health Service Pakistan जी जेका Department of Health या पाकिस्तान जी हुंदी या Secretary of Health या जेको बि हिते या Secretary Health हुंदो उन जे मथां Minister of Health हुंदो सूबे जे लेवल ते उन्हनि जा पंहिंजा जेके सिस्टम्स हूंदा उन्हनि में बि जेके आई एम श्योर के न के पॉलिसी हूंदियूं त रिस्क खे मिनिमाइज़ कयो वञे त जेके प्राइमरी केयर में या सिविल हॉस्पिटल्स में डॉक्टर्स कम कनि था उहे परफॉर्म कनि त जेको हिसो हेल्थ जेका आहे सा माण्हुनि जे दरनि ते पहुचे ensure safe return of the doctor to the work. If you support them, they'll get back to work. कल literally ॻाल्हि पे थी, I think हिते अॻु में शॉर्टेज आहे साइकाइट्रिस्ट जी सॼी दुनिया में शॉर्टेज आहे पर डॉक्टर्स जी ओवरऑल सॼी शॉर्टेज आहे हिते सवेरे जेको आहे सो हिकिड़ो पोएं सेशन में I think Dr. Bajwa, I think he was talking about bringing endoscopy here, and I was really surprised that endoscopy procedures are not available in LUMHS, whereas these are available at district level in many developed countries. Ensure return of the doctor to work. Avoid more formal punishments. The more you punish them, the more you be boisterous with them, their performance will go low. So what you need to do, invest the things that I made clear earlier, personal, professional, or educational, you need to learn. Like मरीज़ असां वटि अचे थो, असां खां उन खां पुछूं था तो कहिड़ी तकलीफ़ आहे, किथे सूर आहे, कॾहिं खां सूर शुरू थियो, हीउ सूर हेॾा खां हेॾा वञे थो या नथो वञे, इहो सूर निंड में बि आहे या सिर्फ़ु जागण ते थो थिए. Earlier somebody was talking about pain, whether pain in joint is while mobilizing or pain in joints when resting. So we are doctors, we take the history of that person and improve working between doctors and human resource, because human resource aim and objective might be to punish and get rid of that doctor because they are paying them. Who can help? Hitte zahara magal ke trust guidelines hitte. I'm in a university guidelines hundiyu. School of Psychiatry guidelines hitte jeko hai so individual jeke specialties and unan ju guidelines psychiatrists the Pakistan Psychiatric Society ju ke guidelines hundiyu. College guidelines means hitte maite university bitwa in a university ju ke guidelines hundiyu. Deanery guidelines hitte deans betan hindi panji faculty ju ke guidelines hundiyu. National guidelines, mulki level te ya सूबे जे level te के guidelines हुंदियूं त इन्हनि माण्हुनि खे कीअं support कजे, कीअं help कजे. I'm sorry, if there are people who cannot understand Sindhi, please raise your hands that I make sure that I can switch to Urdu as well, because I can speak Urdu very well as well. What support is available? There will be different terminologies used. DM is the Director of Medical Education. College tutors and individual tutors. Foundation leads means that now educational system in medicine has changed in UK. Word SHO has become obsolete. We do not use the word SHO. We use the word foundation year doctors. People work in as a foundation year doctors first 2 years, so they are foundation leads. Then TPDs. TPDs means a training program director. These are for the specialty trainees. Specialty trainees bin kisman core trainee and specialty training. Specialty training means equivalent to senior registrar. Core training means equivalent to SHO or a registrar. I'm thinking in older terms. I'm sure most of you would be familiar with those terms. Occupational health. Again, I think I did talk about occupational health and counseling. Human resource and MD means medical director. Here in this case, in this university, I don't think there's a medical director. There's a vice chancellor. So I'm sorry, I'm just referring to you. It's medical director by say a medical director. I don't know what I did. Right, I'm sorry. Again, support comes from a basic level. When there is a SHO or trainee, they would be they can get support from registrar to senior registrar to assistant professors to associate, then professors. Then if the problem is not resolved, then deans can solve the problem. If deans cannot solve the problem, then maybe a vice chancellor or a medical director. Time is needed to support you guys as well. There's a time, I think you need to discuss that you guys have enough time whilst you are offering a medical practice, you are teaching, then you have enough time to train your trainees as well and support them. And this is something I'm sure you can negotiate with your vice chancellor or medical director or deans. Modify training post. If that person is not performing well, their training post may be modified, that they are not expected to come to work 5 days a week. They might be expected to come to work 3 days a week, or maybe hours that suits that individual until that person is fit enough to assume the full responsibilities. Sometimes, people can take time out of training as well, out of program for 6 months and then come back to the program. And maybe you can devise less than full-time training. People who are full-time trainees, so their training is completed 3 years, and less than full-time trainees means they will not be working full-time, they'll be working half the time, so it means that their training time will be extended to 6 years, depending on the specialty. These people might need mentoring or pastoral care. Pastoral care is when people become unwell, they may not be able to talk to their bosses, they might not be able to talk to their professors, they might talk to somebody who is out of their department, provide pastoral care, means supporting them and linking with their professors and linking with other people in organizing. ARCP basically this is the annual review of clinical progression. It's an annual report of a trainee to see how that trainee is performing and progressing. HR is again human resource. Guidelines, there are, again, I'm just repeating myself, guidelines of the university or whatever the guidelines exist. And I'm not sure whether you are able to see the slide. The problem has been identified, problem has been discussed with the education supervisor, has identified it's a health problem. They have given some time out of work and they can come back. If the problem is a personality problem, person is coming drunk to the work, and obviously that's a bigger problem, that may need involving deans. Deans need to be involved and then decide whether this person needs some treatment for their drug addiction or alcohol addiction. If the problem is a personality, again, senior people may need to be involved to see how to support them, to understand what is this person behaving this way. But there may be times when the people are so bad that they may need punishment, but that is something has to be the end point rather than beginning point. Again, it's the same thing. There's a trigger event, simple thing, I'll be finishing, sir. There's a problem that you have identified, you investigate. If serious, what is the problem? Define it, decide if this is an organization problem or individual problem. If, does it matter? Can they normally do this? Or who can support them and why now? Identify the problem, validate the resources that we have discussed, and the risk assessment by the education supervisor. Risk is to the patient, because I'm talking about doctors. If the doctor is not well, the treatment he'll provide that might have an impact on the patients. Or that impact might be on that doctor as well. After risk assessment, if it is minor, moderate, or major, use NCAST. It's a National Academy of Clinical Training. You use their guidelines and what they guide to how to support a training. Diagnose the problem. I've already touched upon it. Diagnose like you're diagnosing any patient when you see. And look whether it's a clinical performance or a health problem or a personality behavioral problem or an environmental problem. What can you do? Identify the problem early, take a history, obtain information from others, like you get a collateral history, maitran ka puchbo, hite maitran je baja dostan ka, nurse ka, jake bekam unan ka puchbo how this person is doing, why he is doing it. Explore, work out underlying problem, diagnosis again, work out appropriate help and interventions, what help and interventions you can provide as an organization, or signpost them. WPBS, I'm not sure what is the equivalent of that here, means work-based program assessments. These are done yearly to see how trainees are performing. Review, monitor, and document. Get help from others. Important thing is document, document, document. If you don't document anything, it means it hasn't happened. So tomorrow, if it goes to the Vice Chancellor, a trainee complains, Baba Mukhe, Professor Busai, you are not going to be able to defend yourself in front of a Vice Chancellor, because it's going to be your word against your trainee, a trainee's word against a professor. So you make sure that you document everything, that is going to be your evidence. You, Vice Chancellor, our deans can see, this is what we did, and this is what we tried to achieve, but this has not helped. Again, email, trainee, copy, and relevant others. Savera Budosi, Dr. Anila, Professor Anila Kabudosi, the Nottingham Mathia, Uttahano email Nutakan, Yasai Nai, Kaga Nyaban, but so Gatan. Emails, they can say, basically, again, that is going to be your evidence as well. Types of interventions, health problem of the GP, yeah, local specialist services, local problem of in-house occupational health and support trainer. Tutor has a key role, then training program director if it goes longer than 6 months. Modification of the post, I think I have already covered that. National counseling services, and most doctors find very difficult to acknowledge they need help. I'm sure your common problem, Asame, we as doctors do not acknowledge that we have some problem. Clinical performance issue, training. There is specific targeted training on device use workplace-based assessments as a means of giving and documenting feedback. Review progress is the ARCP again. ESR, Education Supervisor Report, every year they give a report that how training has progressed and performed. Personality and behavioral problems and the supervision methods are discussed. Tell them the implications. Use again work-based assessment and 360 degree. 360 degree means a doctor, nurse, gate te jako so manu etwa ho safai waro manu etwa receptionist, they will all give feedback about Dr. Qureshi. Dr. Qureshi is a good guy or a bad guy. Means that behaviorally they will be able to tell, and you can see 360 degree. Mentoring with the education supervisor and beyond. Trust, again, trust means here you see trust as a university. Organizational issues, they can say. Human resource, maybe the stress due to problems at workplace. Dr. Moin Ansari is a very tough doctor. He's giving hard time to his juniors and trainees. I'm just using it as an example. I mean, you're an excellent doctor. I know you personally. And bullying by colleagues. Dr. Shahryar, Rajesh ke bully pe kayo because a senior PG in a imtihan pass kare chuko who on training on imtihan puru pass na kya. Lead consultant or a medical director. These issues can go to the lead consultant or medical director. Again, tutors, training, each individual has a role and responsibility at their level of responsibility. DME, again, director of medical education. Referral pathways, I think I've touched upon these things. Again, say vignettes, and I'm not going to do that because we don't have enough time to do the workshop kind of a thing. Conclusion is, never judge what you see until carefully investigated. So, ये मानो कि जब तक न चलो ये खराब डॉक्टर है या खराब डॉक्टरियानियाँ, तहाँ investigate क्यों उन्हें मसले के इन मालूम क्यों अच्छा problem है. उन्हें कहा do not harm, do not harm. ये तो सारे medics डॉक्टरी जब ये सुना ना, जब when we treat patients, our motto is do not harm. But sometimes we can cause harm in the best interest of patient because patient did not respond to that treatment, or that treatment may have had some side effects. This is best achieved through a careful and supportive conversation, albeit firm, and ensure do not lose the plot. We shall not get the plot, we do not get personal. Treat each case with dignity and respect, and be flexible. As Maslow's self-actualization concept, again I'm referring to psychiatry and psychology, that it is important to consider basic human needs. Basic human needs come first: family, health, and emotional state. So why I'm behaving this way? Maybe different reason. I may not be a bad guy. I may have a problem at home. These are some references, and thank you so much for listening to me.
Thank you very much, sir. The next speaker we have is a proud Liakatian who is a graduate of Liaquat University of Medical and Health Sciences, Dr. Abdul Manan Beg. Dr. Abdul Manan Beg is assistant professor, a researcher, group lead of emerging infectious diseases at Department of Biology and Biomedical Sciences at Aga Khan University, Karachi. His title of talk is Integrating Acute and Long-Term COVID-19 Awareness and Healthcare Delivery During Pandemic of COVID-19. Sir, please.
Assalamu alaikum and a very good afternoon. And it was very difficult when I was sitting there to not have a look at your faces, okay, which I can see very clearly now. Many of you, okay, know me by the name of Dr. Manan. You know, I have been teaching in this institute for more than something like 22 years, if I'm not wrong, okay, for my graduation since 1990. Dr. Moin Ansari, who appears to be my classmate, I first would like to start with thanking him and the worthy Vice Chancellor to actually invite me to have this talk. And with the permission of the chair and the panelists, okay, if you allow me, please, can I start? Thank you very much. Now, this presentation actually, and I also realize that I'm the only barrier between you and the lunch, you know, so I would just like make it short if you want to just like let me start and begin with this. Now, awareness, integration, and encompassing the healthcare delivery during pandemic was a total failure, okay, when we met it in 2020. First of all, it was very difficult to even realize that there is something like as disastrous as this condition. And then, you know, we all went from virtual in real mode teaching to online teaching, the use of Zoom and everything, you know, better than me. It was, and it still is, a very tedious period that we are going through. Now, I'll talk about two things, the awareness and the healthcare delivery during this pandemic. You know, because of loss of virtual contact with people, wearing masks, having distance, it was not easy to spread awareness. The tool that I used, okay, to do that was via publication and via book chapters and stuff. So most of the things that you will see would be related to that. So let me begin with my first slide. Okay, you see this pandemic is affecting, and these are the figures from yesterday's online records. Okay, you can see the figures are like in 7 digits for US nowadays, and these are, I'm talking about active cases, and the ones which are diseased are visible. Pakistan, again, is not, I mean, like that worse when you see it go globally, but then the conditions are not very, very optimistic when you see that. One thing that you must have realized, and we all are witnessing it as at present, is that we think that the pandemic is over because it's coming from the mouth of the horse, you know. The US state secretaries, the presidents, okay, just want to keep the financial years running. So they know very well that it would be a disaster if we keep on calling it pandemic. The disease is still present. The virus is mutating. And today I'm going to talk about those aspects that we don't frequently do witness, so we think they don't exist. So let me show you that how it all began and what we know. We commonly think it's a flu. It causes pulmonary congestion. Physicians witnesses as crepitations in the chest, converts into lobar pneumonia, and makes a person sick. The person gets hospitalized here, and then it becomes a very serious situation on a ventilator, and then you saw everything which is on the right side of the list. Okay, we saw it burning. India was affected in a way that we saw on our channels, you know, burials were difficult, not only difficult, eventually they had to throw the bodies into Ganga rivers, you know. So this all started because of we didn't have any awareness or any preparedness to tackle COVID-19. What came in the next few, what you call as period of time is that we came to now know that it causes immune dysregulation, it causes thrombosis activation, which is evident by many players, okay, world-class players, sporty individuals dying on the field. It also is now known to cause a condition known as long COVID syndrome, which very few people know what it is. You will see that it is implicated in the causation of one condition of neuro-COVID, in which is primarily affecting the brain, as evident by more than 600 publications now. So the question is, and also not to forget that it is inducing Alzheimer's-like changes. Now my question is, did we know this, that this simple flu is going to cause sudden cardiac death, lymphopenias, protracted cases, okay, of guys going over 2.7 years now into long COVID syndrome, paralyzing individuals, okay, by causing neurological symptoms. These are the things which they don't talk about. We don't know about this, that it is a neuroinvasive virus. We don't know about the neurological complications it is causing. My question is, was the pandemic and is the pandemic as simple as a flu? No way. If you check PubMed alone, there are over 1,600 publications on neurological symptoms caused by COVID-19 alone. Leave alone the ones on pulmonary complications and myocardial infarction, and you name it. It's a multi-organ disease. So if you allow me, okay, and ask me that what is our state at present with this disease, I'll tell you, we are in a state of denial. You see the flights which are going on. China had a recent, again, a rebreak of the disease, and flights are still on from China to Pakistan, China to US. I mean, who's wearing mask? I mean, like, mask is not the only way that you address this disease. Now, these conditions are like in every person who is affected. If he goes for a neuro-COVID complication, you would not believe. If you just, I want all of you individuals to just go today and Google it, long COVID caused disability. 10 million, how does that figure sound? 10 million in UK alone, okay? 25 million of people going disabled, chartered accountants, bank managers, doctors, consultant physicians, okay, bedridden now, bedridden. Cannot move from the bed to the washroom or the restroom. So are they pretending? Do they want allowance from the government, okay, to just feed them? No, these are carrier 1 type A personalities who are now paralyzed. So my question is, did we know this about this disease? No, it actually just is emerging, and we are still trying to understand the disease. So my purpose here to talk before you is that I said in the beginning of the talk that during the pandemic, because there were constraints, okay, I used publication and book chapters as a major route of communication with the world, with guys like you who are professionally trained, okay, who want to know the disease more than just like sit and say it's a flu. So it causes brain damage, yes, and if I can take you to the next slide, sorry, I pressed too many buttons, I think. It's causing Alzheimer's-like changes. It's causing loss of memory, and also over 6 papers on loss of brain mass have been reported. And you tell me, at what age do we get commonly a plaque, brain plaque, or amyloid fibril? Commonly, we develop Alzheimer's at the age of 60 plus, so it's not very common in 30, 35-year-old individuals. Now, nowadays, you know what you see is that a person who suffered COVID, admitted to the hospital, had an MRI, and those guys are having memory loss. They are having deposit of amyloid. Autopsy findings are showing it. How a disease so fast that it in 2.5 years can induce amyloid-like changes, I just leave it to you to understand. The disease is cruel. The disease is merciless. Okay, so we'll take you to other complications that it causes, and which include thrombotic occlusion of blood vessels. You would imagine, yesterday I had a chance to talk to the patient, okay, lying on the bed, the blood pressure is 110 by 90 mmHg. The person only stands up. You know what happens to the heartbeat? Ranging right from 82 to 173. POTS, postural induced tachycardia syndrome. Did this person have this condition in 2019? No. All developed after what? After COVID. So if you notice these type of cases, okay, they are the ones who need our attention. These are the ones who need our referrals to specialists so that the disease could be understood in its best context. Okay, I'll just keep it short, and I don't want to interfere between you and the lunch, and I will just talk one more slide on how to take care of this and see that how did it spread. Now, this situation, as we talk, as we sit here and listen to it, has got congestion in NHS or UK hospitals. They are overbooked. If you receive an emergency call, okay, in NHS as a doctor, you will see that the 14 hours is the minimum stay time to respond to it. Hospitals, no seats, no beds for acute coronary attacks or even strokes. My question is, what is filling these hospitals? If the disease is no more there, if COVID is over, okay, why NHS hospitals are filled? Ambulance cannot respond for 11 hours, okay? If you make a call from 9 blocks away, okay, this straight away say, we can't give you an ambulance for an entire 24 hours. What's happening? I mean, like, if everything is good and we should be sitting in flight, flying from one continent to other, why the hospitals in the US and the UK are filled? Only because we are in a state of denial. The disease is truly there, and it still is actually threatening us. The burials you saw. Now the thing is, were we prepared for it? Are we also prepared for the next pandemic? If it happens in Pakistan, in Sindh, in our continent, okay, are we prepared to tackle it? No, we are not, okay? And I would like to say that the excuse is underfunding, we don't have money. If we even give the funds and the money, okay, we don't know how to tackle it. So I made these 5 circles, okay, you educate and organize, you spend and invest very wisely, you remain up to date, investigate, you collaborate with national and at international levels, and with special care to the green A circle that you can see is the one which is the most neglected component of our healthcare system. Who bothers to go to a rural area to serve a patient with COVID? We managed it in Jamshoro. I know feedback coming from the Vice Chancellor and other doctors that they actually served in the rural areas so very good. The thing was missing in Karachi. I mean, like the thing was missing in even Punjab, you know. They didn't have any reasonable access to those rural areas to actually address the COVID problem. So next we show you that how it could be done. If you advertise good, if you take it to the walls, paste it, you raise awareness, you use innovative methods of delivery. Okay, if you are afraid of getting infected by these type of what you call as the flies, okay, that we know nowadays, okay, that can deliver even food, medicine and stuff. Raise awareness and let the public know that how it gets communicated. Don't even think that if you wear a mask, okay, you can communicate a message that it's airborne. No, you have to train them, you have to educate them that what the disease is all about. So I'll keep it short by telling you that Pakistan's contribution to COVID-19 as a nation, we contributed our 2 cents to the research in COVID in past 3 years. Okay, me being a graduate of an alumnus of Liaquat University, Okay, I'm very proud that we could make it possible to spread that awareness to the entire world. We published this paper, okay, which you can see in 2.7 years, okay, actually was the first paper which could alert the individual community throughout the world that the virus is neuroinvasive. It's going through the nose, causing damage to the brain. It would cause amyloid. We predicted in 2020. It actually got confirmed in 2022. We also actually were first to name this disease as long COVID syndrome. And mostly my colleagues here are physicians, you know, they started calling this condition as long COVID only. That was a layman term. I said, but it has got signs and symptoms, why not call it syndrome? Because if few publications get deposited in PubMed with the name of long COVID alone, then we will be rewriting the history by calling it syndrome. So in 2020, okay, very early, late December, I think I managed to actually alert the community that name it well and call it a long COVID syndrome, okay, and then after that, it was endorsed by Dr. Fauci and stuff, okay, so we kept on contributing, we didn't stop, and we didn't only say that we have lack of resources, we don't have money. So if you want to raise a voice, raise it good, you know, so that you can actually make it go to the other corner of the world. So we heralded and alerted the healthcare, what you call as bodies. We published on how it is causing neural damages, okay, by affecting central nervous system and also respiratory regulatory centers. My colleagues, okay, who belong to pulmonology here, they know that in COVID, the breathing pattern is very vivid. You know, you don't know why this hyperventilation is there when the oximeter is showing 97 and 98% of oxygen saturation, because the virus is affecting the respiratory centers. Nobody knew it. We managed to alert it. Last slide that we recently published in Nature, okay, and alerted the community because the readership of this journal is good. And then after this, okay, many people, okay, who never knew that it's causing the brain damage, okay, became aware to it, okay. Thank you very much. It was a pleasure coming to my mother university. Being an alumnus, I would end this talk by saying one thing. Every other place I go, okay, when I go to the podium, okay, I've got a glass of bottle, and it gives me a few extra heartbeats. But when you come to your mother institute, you know, those heartbeats are normal, and you don't need a bottle of water. Thank you very much.
Thank you. Thank you, Dr. Manan. The next speaker we have is Professor Dr. Mohammad Irfan. Professor Irfan is a consultant psychiatrist, a medical educationist, and a PhD doctorate in mental health policy and services. Professor Irfan is professor and head of Department of Mental Health, Psychiatry and Behavioral Sciences at Peshawar Medical College. He is also looking after the Office of Director Research, Prime Foundation, Pakistan, President-elect of World Association of Cultural Psychiatry, Director, Research and Innovation, Asian Cognitive Behavioral Therapists Association, and current President of Pakistan Association of Medical Editors. I welcome Dr. Irfan to please come up on the stage to deliver his plenary talk on research mentoring.
Thank you very much. First of all, I take the opportunity to congratulate the organizers for organizing this wonderful event. I thoroughly enjoyed being here. Today, when I talk in this august house about research, which is very close to my heart, I would think that there is I would think that there is Right. My apologies for the inconvenience. So I wanted to talk about this topic because this is something that is close to my heart, and when I talk in front of you, an audience that is gathered here in a summit which is all about research and innovation, I thought it is important that we should cover research in a different way, in a way where we just not only look in doing research, but look into the process of doing the research. And that process is not a one-way traffic. In this process, there is something coming in and something going out. But this first side of coming in is sometimes accompanied by people that are associated in many ways. And in those many ways, we have selected one way. And that way is something that we call research mentorship. So let's start general with knowing about what is a mentor. And I looked into the possibilities of definitions and thesaurus about what mentor is in the context that we are talking about. और आप इस mentor की definition अपने तौर पर करना चाहें तो बेशुमार तरीक़ों से कर सकते हैं. आप इस mentor को एक रहनुमा कह सकते हैं, आप इस mentor को एक गुरु कह सकते हैं, आप इस mentor को एक ऐसी शख्सियत के तौर पर जान सकते हैं जो आपको किसी रास्ते की तरफ लेके उंगली पकड़ के चलता है. लेकिन अगर comprehensive definition जिसकी ज़ाहिर है इधर ज़रूरत होगी उसकी बात की जाए तो वो definition इस जुमले के बाद है और वो है कि the journey of 1,000 miles begins with a single step. और ज़ाहिर है जब हम इस जर्नी पे चलेंगे, इस सफ़र को लेंगे तो हमें ये स्टेप्स लेने होंगे, लेकिन जो हमें लेके जाएगा, जिसको हमने मेंटोर के तौर पर कहा है, वो एक ऐसा शख्स है who has achieved career success and counsels and guides another for the purpose of helping to achieve success. किसी ने वो सक्सेस हासिल कर ली और फिर वो किसी को लेके बढ़ता है एक सक्सेस के सफ़र पे और उसको वहीं पहुंचाना चाहता है जहां तक वो पहुंचा और उसके बाद उससे आगे. अच्छा, ये तो बड़ी जिम्मेदारी की बात है. ये एक ऐसी जिम्मेदारी है कि आप किसी को न सिर्फ वहां तक लेके जाना चाहते हैं जहां तक खुद पहुंचे, बल्कि उससे आगे भी ले जाना चाहते हैं. और जैसा कि हम में से बेशुमार लोग जो इस सफ़र पे मुख्तलिफ तरीक़ों से गामज़न हैं, वो ये जानते हैं कि जो लोग इस सफ़र पे जाते हैं उनका रिश्ता उसी तरह जो हम जैसे कहते हैं कि रूहानी उस्ताद का होता है, क्योंकि वालिदैन के बाद असातिज़ा ही वो शख्सियत होते हैं जो अपने शागिर्द को, जैसे वालिदैन अपनी औलाद को चाहते हैं कि वो उनसे आगे बढ़ जाए, सिर्फ यही वो रिश्ता रह जाता है. आप देखिए कि हम ऐसी शख्सियत, ऐसे रिश्ते, ऐसी कैफियत की बात करने आज जा रहे हैं. ये है वो डिपिक्शन जो मेरे जहन में है जो किसी मेंटोर की होनी चाहिए. और जब मैं इस डिपिक्शन की बात करता हूं तो मैं ये सवाल अपने आप से करता हूं कि किसे मेंटोर की जरूरत है. क्या सिर्फ किसी रिसर्च के सफर पे जाने वाले को मेंटोर की जरूरत है? क्या किसी सिर्फ इल्मी सफर पे जाने वाले को मेंटोर की जरूरत है? या मेरा जवाब ये होगा कि हर किसी को जरूरत है. अब वो उसकी हैत मुख्तलिफ होगी, उसकी शक्ल डिफरेंट होगी, मगर ज़रूरत तो हर किसी को है. हाँ, ये ज़रूरी है कि हमें ये समझ आ जाए कि मेंटोर का मकसद सिर्फ रिसर्च के कॉन्टेक्स्ट में हमने ऐसे कहा कि जिसने एक सक्सेस हासिल कर ली और उसके बाद आगे ले गया, वरना ये मेंटोर किसी भी शक्ल में हो सकता है. ये वालिदैन हो सकते हैं, कोई ऐसी शख्सियत हो सकती है जिसको आप देख के आगे बढ़ रहे हो, चाहे वो आपके रिसर्च के, चाहे वो आपके इल्मी सफ़र में तो साथ ना हो, लेकिन किसी ना किसी तरीके से आगे लेके आपको बढ़ रही हो. ये बहुत ज़रूरी है कि हमें पता हो. लेकिन इसकी ज़रूरत हमारी इस फील्ड में इन जनरल क्यों है? क्यों है कि हम इसको इम्पॉर्टेंट समझते हैं और हम ये समझते हैं कि अगर मेंटोरशिप होगी तो चीज़ें ज़्यादा आगे बढ़ेंगी? उसकी वजह यह है कि जो मेंटोर है उसने आपकी ज़िंदगी पर एक ऐसा अनमिट और गहरा नक्श छोड़ना है जो आपको आगे ले जाने का बाइस बनेगा. So a mentor has a very profound and long-lasting impact on the life of a mentee in every aspect, be it personal growth, professional achievement or anything else. अब जब हम इसकी बात करते हैं तो हम ये कहते हैं कि एक जुमला हम बहुत कॉमनली सुनते हैं जिसे कहते हैं प्रैक्टिस मेक्स परफेक्ट. ये जुमला बहुत कॉमन है, लेकिन سائیکاٹری اور مینٹل ہیلتھ کے ایک ادنا سے طالب علم ہونے کی حیثیت سے مجھے ایک اور بات بھی معلوم ہے, اور وہ میں آگے کی 2 لائنیں دکھانے کے بعد بتاتا ہوں. اور وہ یہ ہے کہ اگر میں یہ مان لوں کہ پریکٹس میکس پرماننٹ پرفیکٹ, تو مجھے تو لگتا ہے اور مجھے یہ بتایا گیا ہے کہ پریکٹس کرنے سے چیزیں پرماننٹ ہو جاتی ہیں, اور اگر پرماننٹ کچھ غلط ہو جائے تو اس کی ان لرننگ بہت مشکل ہے. جو آپ نے غلط چیز سیکھ لی اس کو ان لرن کرنا بہت مشکل ہوگا. سو آپ کو کسی ایسی شخصیت کی ضرورت ہے کہ وہ آپ کو ٹھیک سکھا کے اس کو پرفیکٹ لیول تک پہنچائے. So you need someone, and that's someone that we are talking about, a mentor, to make it a perfect combination. So that is something very important. اب mentorship کی بہت ساری ٹائپس ہیں, میں اس کی ڈیٹیل میں نہیں جا رہا, صرف آپ کو جسٹ فوڈ فار تھاٹ کے لیے صرف یہ سلائڈ دکھانا چاہتا ہوں کہ آپ کے علم میں ہو کہ کن کن طریقوں سے mentorship کو دیکھا جاتا ہے. اور یہ وہ بہت ساری ٹائپس ہیں جن کے حوالے سے بات ہوتی ہے, اور میں وقت کی قلت کی وجہ سے میں بہت زیادہ اس ڈیٹیل میں نہیں جاؤں گا. اب میں نے اس کو بہت طوالت سے پڑھا, بہت طریقوں سے دیکھا, تو میرے خیال میں مینٹورنگ کی رسپانسبلٹیز کو اگر بہت بریف کیا جائے, ہے تو بہت زیادہ لیکن بہت زیادہ بریف کیا جائے تو ان کو آپ 3 حوالوں سے دیکھ سکتے ہیں: شیئرنگ نالج اینڈ اسکل, اوور سیئنگ دا ورک, اینڈ ہیلپنگ ٹو اسسٹ ان ڈیولپنگ اے کیریئر. اگر ہم اپنے کانٹیکس میں دیکھیں گے تو اگر یہ 3 کام کوئی کرنے کو تیار ہے اور اس کام کرنے میں مہارت رکھتا ہے تو وہ ایک اچھا مینٹور کہلائے گا. رائٹ جی. تو پھر جب ہم یہ سمجھ لیتے ہیں تو ہمیں یہ پتہ لگتا ہے کہ یہ وہ تمام چیزیں ہیں جو ایک مینٹورنگ کے رول کو اچھا بنانے میں, اور وہ 3 باتیں جن کی میں نے ابھی آپ سے تعریف کی, ان کے حوالے سے بہت امپورٹنٹ ہوں گی. کیا کیا ہوگا؟ ٹریننگ ہوگی, موٹیویشن ہوگی, ایڈوائس ہوگی, سکسیس ہوگی, ڈائریکشن گیونگ ہوگی, کوچنگ ہوگی, سپورٹ ہوگی, اور یہ تمام چیزیں کسی گول کی طرف لے کے جائیں گی. یہ تمام چیزیں ہیں جو ایک مینٹورشپ میں ہمیں چاہیے. اب تھوڑا سا آگے بڑھتے ہیں اور ہم اپنے ٹاپک سے نزدیک ہوتے جاتے ہیں, اور وہ ریسرچ مینٹورشپ کا ہے, اور اس کو ہم نے دیکھا ہے ان جنرل اور پھر 1-to-1, اور میں یہ دیکھ کے آپ کو بتاتا ہوں کہ اٹ از اباؤٹ بلڈنگ این انٹیمیٹ ورکنگ ریلیشن شپ بٹوین اے اسٹوڈنٹ اینڈ مینٹور. آپ اسٹوڈنٹ کی جگہ مینٹی بھی کہہ سکتے ہیں. Commit to maintaining the highest academic standards by carefully selecting faculty members with both research expertise and teaching experience. And a one-on-one mentorship is a fully tailored experience which is based on the schedules, syllabus, course structure, course length, and components that may be optimized to give us the best result. And the students' own ideas and academic passions are where to begin with. This is all what research mentorship is understood in many ways. اچھا, جب ہم یہ دیکھ لیتے ہیں تو ہم یہ جاننا چاہتے ہیں کہ وہ کیا کیا کوالٹیز ہونی چاہیے جو آپ کو ایک اچھا ریسرچ کا مینٹور بنا سکیں گی. سو میں ایک ایک سلائیڈ پہ 10 کوالٹیز کے ساتھ آپ کو آگے لے کے چلوں گا. سو پہلی کوالٹی جو میں سمجھتا ہوں وہ ہے کہ میک شیور یو پریکٹس واٹ یو پریچ, بی اٹ مورلز اور ایتھکس. اگر آپ یہ کرنے میں کامیاب ہو جائیں گے تو شاید یہ سفر شروع ہو, ورنہ اگر آپ کا خیال یہ ہے کہ آپ کی تقریر سے جو کچھ وہ سیکھیں تو ایسا نہیں ہوگا, وہ آپ کے عمل سے سیکھیں گے. سو یہ بہت ضروری ہے. سو ہمیشہ لیڈنگ بائی ایگزامپل از سم تھنگ دیٹ اے مینٹور شوڈ بی ڈوئنگ. اس کے بعد جو دوسری بات آتی ہے وہ ہے بی اٹینٹو اینڈ ریئلسٹک اینڈ نوئنگ دی امپورٹنس گڈ کمیونیکیشن. بہت زیادہ ضروری ہے, صرف اس حوالے سے نہیں, ہر حوالے سے بہت زیادہ ضروری ہے, اور ہمیشہ ایک اچھا لسنر ایک اچھا مینٹور بننے کی تعریف میں آتا ہے. پھر اس کے بعد ایڈوائس اینڈ ناٹ ڈکٹیٹ اینڈ بی ٹالرنٹ. پیشنس از اے ورچو. آپ کو اچھا مینٹور بننے کے لیے بہت ضروری ہے کہ آپ کے اندر پیشنس ہو. Provide constructive criticism in a way that both challenges and encourages the mentee to do better. So what do? You guide. You actually take them through. So that is very important. Then you need to show a willingness to organize and structure the mentoring relationship instead of relying entirely on the mentee to take initiative. اگر سارے initiative اسی کی طرف سے آنے ہیں تو پھر آپ کیا اس رشتے میں کیا رول رہ جائے گا. So you need to be an initiator. If I have to go further to know about a good researcher, I would say this is something very important. بیکاز کبھی کبھی رشتے میں دراڑ کی وجہ یہی بنتی ہے, اور وہ یہ ہے
Okay, you have to agree upon early in the collaboration regarding the ownership of data or the project or whatever you are doing, so as to maintain a healthy working environment. So you have to have the capacity to be a boundary setter. That is very important. Then I go further and talk about being highly competent and innovative to be able to provide assistance wherever necessary for skill development in a befitting way, and you need to be innovative. Last few points: connect your mentee with different opportunities, no space for gatekeeping. You need to be a source to connect and not a boundary or a barrier between them and the opportunities. That is very important. And provide independence for freedom of thought, making the mentee feel comfortable enough to express an opposing view of, or express their disagreement. And most important, seeing the mentee's professional development goals and aspirations as valid and legitimate. You should be an acceptor. And last but not the least, create a sense and a feeling of team with the mentee. It's not you or me, it's we. Both mutually want what is best for each other, and you need to be an ideal team person to become a good research mentor. So that is what I think about mentorship. So if I consider these qualities, the first question that some people would ask, at what level we need a mentor in our educational setup, in a research setup? So the answer is simple. We need it at every level. All these levels we need. Even if someone say, I'm a faculty myself, do I need a mentor? Yes, you would also need it. So I'm not going into the details of this slide that I've taken from a very important presentation, but this is how what undergrad, grad, and faculty level supervisors becoming mentors would need. But I'll skip that, and let's focus on what I thought I would discuss, and that is undergrad, and that is close to my heart because I've been thinking, I've been working around undergrads because I thought if we make the right call at this level, हमें आगे बहुत आसानी होने वाली है. लेकिन अगर हम बहुत आगे जाके इस दरख्त को सीधा करना चाहेंगे, इस इमारत को एरेक्ट खड़ा करना चाहेंगे, बहुत मुश्किल होगी. फारसी का एक शेर है कि अगर पहली ईंट टेढ़ी लगा दी जाए तो वो इमारत अगर आसमान तक भी पहुंच जाए तो वो इमारत टेढ़ी ही रहेगी. सो मैं ये समझता हूं कि अगर इस सफ़र में जो हमने मेडिकल स्टूडेंट के हवाले से जाना है, अगर उसको अंडरग्रेड में ही कर दिया जाए या किसी भी और डिसिप्लिन में अगर चीज़ें अंडरग्रेड से ही ठीक करने की कोशिश की जाएगी तो शायद ज़्यादा बेहतरी होगी. सो क्या क्या करने की ज़रूरत है? उससे पहले ये जानना कि अंडरग्रेड रिसर्च करे ही क्यों. ये भी एक कॉमन सा सवाल है. हमारे बहुत से लोग ये सोचते और समझते हैं कि कॉलेज में, यूनिवर्सिटी में, अंडरग्रेड लेवल में तो हम बच्चों को पढ़ने के लिए भेजते हैं, ये रिसर्च को क्यों आप शामिल करना चाहते हैं? सो बुनियादी तौर पर जिस कॉम्पिटिटिव वर्ल्ड में हम रह रहे हैं उसके अंदर कैरियर की जो मुख्तलिफ डायरेक्शंस हैं उनको एक्सप्लोर करना बहुत ज़्यादा ज़रूरी है. और अब तो ये जान लें कि रिसर्च एज अ करियर बहुत सारे लोग लेते हैं, लेकिन अगर मैं ये ना भी कहूँ और मैं कहूँ कि लोग अपने डिफरेंट वेरीड करियर्स में जाएंगे, तब भी तो उनको अपनी ट्रांसफरेबल स्किल्स और एनहांसिंग सीवी के लिए उनको रिसर्च की ज़रूरत है. उनको लर्निंग टू पब्लिकली एडवोकेट एंड डिफेंडिंग देयर वर्क में रिसर्च की ज़रूरत है. गेटिंग नोटिस्ड एंड स्टेइंग अहेड इन कॉलेज में रिसर्च की ज़रूरत है. और कंट्रीब्यूटिंग नॉलेज एंड इम्पैक्टिंग द वर्ल्ड में उनको रिसर्च की ज़रूरत है. इसलिए उनको चाहिए कि वो रिसर्च में जाएं. 3 सवाल हैं जो मेरे नज़दीक क्वेश्चंस हैं जब रिसर्च मेंटरशिप प्रोग्राम हम बनाते हैं, जो हर इदारे को अपने आप से पूछने चाहिए. वो 3 सवाल क्या हैं? What is the ideal place and level in curriculum to introduce these programs? Second, should mentors be research expert models or should they just be good advisors? Or a combination of both? Or how to assess the impact of research mentorship program? ये 3 सवाल हैं. अगर हमें ये 3 सवाल हमारे जहन में हैं तो हम एक अच्छे रिसर्च मेंटरशिप प्रोग्राम को रन कर सकते हैं. मैं अंडरग्रेड रिसर्च को मुख्तलिफ और अप्रेंटिसेस की तरह इसको भी एक अप्रेंटिसशिप समझता हूँ कि अगर हमें इसको आगे लेके बढ़ना है तो उसको एक अप्रेंटिसशिप की तरह ही लेके बढ़ना होगा. और मेंटोर को एग्जाम्पल के ज़रिए کوچنگ کرنے کی ضرورت ہوگی, اسٹوڈنٹس کو لرننگ بائی ڈوئنگ کرنا ہوگا, اور کریٹیکل تھنکنگ اور انالیٹیکل سکلز کی ڈیولپمنٹ کرنا ہوگی. اگر آپ نے کسی پروگرام میں کسی کو انٹر کیا ہے, جیسے آپ اور میں اپنی مختلف اوقات میں روٹیشنز میں گئے ہیں, مختلف وارڈز میں ہم نے روٹیشنز کی ہیں, اپنی ٹریننگز کی ہیں, تو ہم جہاں جاتے تھے وہاں ہم سے کہتے تھے کہ آپ آئے ہیں اس روٹیشن پہ, یہ 6 ماہ کی ہے, 1 سال کی ہے, جتنے عرصے کی بھی ہے, جب آپ یہاں سے جائیں گے تو یہ سیکھ کے جائیں گے. اب ریسرچ کے حوالے سے اگر ہم کہیں گے کہ اس نے کہیں جانا ہے, تو جنرلی بھی یہ سکلز امپورٹنٹ ہیں, لیکن کریٹیکل تھنکنگ کی اور انالیٹیکل ایبلٹیز کی جو سکل ہیں وہ انتہائی امپورٹنٹ ہو جائیں گی یہاں پر. سو وہ بہت زیادہ ضروری ہیں کہ ہمارے پاس ہوں. As they take intellectual ownership of a project, they often develop the ability to make research decisions, learn the questions to ask, and gain the confidence to ask questions. یہ بہت زیادہ ضروری ہیں, اور یہ شاید آگے بڑھنے کے لیے ایک ایوریج اسٹوڈنٹ اور ایک اسٹوڈنٹ جس کی یہ اسکلز ڈیولپڈ ہیں ان کے درمیان ایک بیریئر ہوگا. جو لوگ ان اسکلز کو حاصل کر لیں گے وہ ایک ایوریج اسٹوڈنٹ سے آگے بڑھیں گے. تو میرے لیے جو اسٹوڈنٹس ہیں جو پیچھے بیٹھے ہیں ان کے لیے میسیج یہی ہے کہ اس بات کو سمجھیں, کیونکہ یہ وہ صلاحیت ہے جو آپ نے اپنے اندر پیدا کرنی ہے تاکہ آپ ایک ایوریج سے ابو ایوریج بن جائیں. سو دیٹ از ویری امپورٹنٹ. اچھا, ایک ہوتی ہے تھیوریٹیکل بات, اور تھیوریٹیکل بات کرنا آسان بھی ہے, گوگل سے بہت زیادہ ریفرنسز بھی مل جائیں گے, بہت ساری چیزیں بھی ہو جائیں گی, بہت سارے واقعات بھی کوٹ کر لیے جائیں گے. لیکن ایک ہے کیس ایگزامپلز ہوں کہ ہم نے خود کچھ ایسا کر کے دکھایا ہے, خود کچھ ایسا کیا ہے جس کے بعد ہم یہ بات کرنے کے قابل ہوئے ہیں یا نہیں. سو میں, جیسے کہ ڈاکٹر عاطر نے میرا تعارف میں کہا, میں پشاور میڈیکل کالج سے وابستہ ہوں بہت سالوں سے, اور وہاں پر ہم نے اس کا آغاز کیا آج سے کئی سال پہلے. اور کیا کہ ہم نے اپنے آئیڈیالوجیکل جو سلوگنز تھے اس کے اندر اپنا مین مقصد میں جب ہم نے کہا کہ ایک ڈاکٹر پروڈیوس کر رہا ہے تو ہم نے کہا کہ وہ کیا کیا کوالٹیز رکھے گا. ایک تو جنرل کوالٹیز ہیں, لیکن ظاہر ہے ہر ادارے کی اپنی اپنی اسپیسیفک پہچان بھی ہوتی ہے. تو ہم نے کہا باقی تو سب چیزیں میڈیکل ڈاکٹر کے حوالے سے سب لوگ کہہ رہے ہیں, ہم 2 باتیں اضافی کہیں گے. ایک کہیں گے کہ کیسا ڈاکٹر پروڈیوس کریں جس کا فوکس جو ہے وہ ایتھکس پہ ہو, اور دوسرا ایسا ڈاکٹر پروڈیوس کریں جس کا فوکس ریسرچ پہ ہو. اچھا, کہنا تو آسان ہے, آپ نے کہہ دیا, لیکن پھر اس کے لیے کرنا کیا ہے؟ تو پھر ہم نے کہا کہ ہم میڈیکل ایجوکیشن کو استعمال کریں گے اور اس کے اندر اس کو ایز اے پلر ایسوسیٹ کریں گے. جب تک ہم اس لیول پہ نہیں جائیں گے, جب تک ہم میڈیکل ایجوکیشن کے ساتھ کمیونیکیٹ نہیں کریں گے اور اس کو ایز اے پلر نہیں لے کے جائیں گے, معاملات ٹھیک نہیں چلیں گے. سو یہ بہت امپورٹنٹ ہوگا. پھر اگر اولڈ اسکول پہ چلا جائے اور لوگوں کو زبردستی کام کرائے جائیں اور ہر چیز کو کہا جائے آپ کی اسائنمنٹ ہے, آپ نے یہ کرنا ہے, کام نہیں بنے گا. اس لیے کہ لوگ نئے طریقے سے, نئے حوالوں سے چلنے کے لیے ماڈرنسٹک اپروچ چاہتے ہیں. وہ کیسے ہوگی میں آگے چلتا ہوں. اور آخر میں کوئی بھی چیز اس وقت تک کامیاب نہیں ہوگی. کل سے بار بار جو لوگ یہاں پر آ کے بات کرتے ہیں ان میں ایک بات سب سے زیادہ ہوتی ہے, اور اس کا ذکر میڈیکل ایجوکیشن والے بھی کرتے ہیں, سارے لوگ, وائس چانسلر صاحب نے بھی اس وقت بات کی, ہمارے سیشن میں آئے تھے, کہ انٹیگریشن ہونی چاہیے. اپروچ جو ہے وہ ہولسٹک ہونی چاہیے. جب تک ہولسٹک اپروچ نہیں ہوگی, آپ یونی ڈائمینشنل چلتے رہیں گے, کام آگے نہیں بڑھے گا, بات بنے گی نہیں. سو دیٹ از ویری امپورٹنٹ. تو ہم نے کیا کہ ہم نے ایک کانسیپٹ ڈیولپ کیا, اور وہ کانسیپٹ کیا تھا کہ جب کور کمپوننٹ کسی چیز کو بنایا ہے تو ہم یہ کہیں گے کہ ہم نے ایمفسائز کرنا ہے ایئرلی ڈیولپمنٹ آف ریسرچ پروپوزلس پہ, پروجیکٹس پہ. اور وہ کیسے کرنا ہے وہ میں آگے آتا ہوں. اور پھر ظاہر ہے جب آپ نے ان کو ایمفسائز کیا, ان کو سپورٹ کرنا ہے اور ان کو انکریج کرنا ہے آخری دم تک, یعنی پبلیکیشن تک لے کے جانا ہے. صرف یہ نہیں کہ آپ کچھ کر لیں, وہ سبمٹ ہو جائے, اس کے کچھ مارکس لگ جائیں اور بس بات ختم. اس کو پھر آگے تک لے کے جانا ہے اور اس کو پبلیکیشن تک لے کے جانا ہے. بات یہ ہے کہ جب آپ کسی سفر پہ کسی کو لے کے چلتے ہیں تو جب تک منزل تک نہیں پہنچاتے ان کو اس سفر کا مزہ نہیں آتا, اور جب آپ ایک دفعہ وہ مزہ ان کو دے دیتے ہیں پھر وہ خود سفر پہ چلنا شروع کر دیتے ہیں. سو یہ بہت ضروری تھا کہ ہم اس عمل کو ایسے ہی رکھتے. سو ہم نے کیا کیا کہ ہم نے یہ میں 2 سلائیڈز آگے لے گیا. تو ہم نے کیا کیا کہ ہم نے یہ کہا کہ ہم ہر سال انڈر گریجویٹ لیول پہ ہم ایک کانفرنس کا انعقاد کریں گے. اور اب اس وقت اس سلسلے کی 15 انڈر گریجویٹ میڈیکل ریسرچ کانفرنسز ہم کر چکے ہیں, اور ہر سال پورے پاکستان سے لوگ آتے ہیں, میڈیکل اسٹوڈنٹس اور الائیڈ ہیلتھ کے بھی اسٹوڈنٹس آتے ہیں جو ان میڈیکل ریسرچ کانفرنسز میں پارٹیسپیٹ کرتے ہیں. یہ ساری کانفرنسز اسٹوڈنٹس ہی آرگنائز کرتے ہیں. یہ کچھ ضدی ہو گئی ہے, سلائیڈ آگے پیچھے ہو رہی ہے, لیکن بہرحال اس کے اندر ڈیٹیلز ہیں کہ کس سال میں کتنے پیپرز بچوں نے پروڈیوس کیے یہاں پر, اور پھر وہ کتنے حوالوں سے کتنے اینگل سے دیکھے گئے. اچھا 15 سال کانفرنسیں کر لیں, 15 سال ایونٹس کر لیے, ایک سوال یہ بھی پیدا ہوتا ہے کیا ایونٹس ونس ان اے ایئر ایک ایونٹ کر لینا کیا چیزوں کو پروموٹ کرنے کے لیے کافی ہوگا؟ اس کا جواب بھی بہت سارے لوگ نفی میں سر ہلا کے دیں گے, اور میڈیکل ایجوکیشن سے متعلق تو جو لوگ بیٹھے ہوں گے وہ تو زیادہ اس بارے میں بات کریں گے. سو اس پہ کیا کرنا ہے؟ تو اس کے لیے سب سے پہلے یہ پروڈیوس کرنے کی ضرورت ہوتی ہے کسی بھی ادارے میں کہ ایک ون ون سچویشن پیدا کی جائے کہ جو لوگ اس چیز سے وابستہ ہیں ان کو بتایا جائے کہ اس میں کیا ہے کہ ان کو بھی اس میں فائدہ نظر آئے. سو میں اس ڈیٹیل میں صرف سلائیڈز آگے لے جا رہا ہوں کہ آپ نے یہ بتانا ہے کہ انڈر گریجویٹ ریسرچ کے فائدے کیا ہیں, اور پھر اس کے بعد آپ نے کہنا ہے کہ اچھا بچوں کو تو یہ فائدہ ہو رہا ہے, فیکلٹی کو بھی فائدہ ہو رہا ہے. جب آپ کہہ رہے ہیں فیکلٹی کو بھی فائدہ ہو رہا ہے, اور میں اس کی ڈیٹیل میں نہیں جا رہا کہ وہاں پر کیا انسینٹیوز دینے کی ضرورت ہے اور کیسے بڑھانے کی ضرورت ہے, لیکن بہرحال آپ نے ون ون سچویشن کریٹ کرنی ہے. اور سب سے زیادہ اگر انسٹیٹیوشن کہے جس نے اس کو اسپانسر کرنا ہے, جس نے اس سارے کیس کو آگے لے کے چلنا ہے, اگر اس کو اس میں کچھ نظر نہ آئے تو وہ کیوں کرے گا؟ تو پھر آپ نے ان کو بھی بتانا ہے کہ کیا کیا انسٹیٹیوشنل بینیفٹس ہیں جس کے تحت ہم آگے چلیں گے. سو یہ وہ تمام چیزیں ہیں جس کے تحت آپ اپنا کیس بلڈ کرتے ہیں. جب بھی آپ نے کہیں جانا ہوتا ہے, کسی سے اپنی بات منوانی ہوتی ہے, تو اپنا کیس بلڈ کر رہے ہوتے ہیں. سو آپ کیس بلڈ کرتے ہیں. سو جب آپ یہ کیس بلڈ کر لیتے ہیں تو آپ یہ سکھاتے ہیں اس پورے پروسیس کو کہ لرننگ اور ٹیچنگ میں اسٹوڈنٹ پارٹنر ہوتا ہے. یہ ون وے ٹریفک نہیں ہوتی, اور جب ون وے ٹریفک نہیں ہوتی تو جو مینٹورشپ کی جو ہم بات کرتے ہیں وہ مینٹورشپ ایک برابری کا رشتہ ہے. کسی نہ کسی طریقے سے جب یہاں سے مجھ سے کوئی اچھا سوال پوچھا جائے گا تو میں اس سے جتنا سیکھوں گا شاید میں وہ سلائیڈز بنانے میں وہ نہ سیکھ پاؤں. سو دیٹ از ویری امپورٹنٹ. تو کیا ہوتا ہے کہ ہم پھر اس میں جاتے ہیں کہ پارٹنرشپ جو لرننگ کی ہے وہ اس ماڈل پہ چلتی ہے, اور یہ جو پارٹنرشپ لرننگ کمیونٹیز کا ماڈل ہے, میں ڈیٹیل میں نہیں جاؤں گا, لیکن یہ سلائیڈ ہے جو ہیلے فلنٹ اینڈ ہیرنگٹن سے میں نے لی ہے, اور یہ بہت امپورٹنٹ سلائیڈ ہے کہ آپ یہ دیکھیں کہ اس ماڈل کے تحت ہمارے سارے پروگرامز رن ہو سکتے ہیں. میں نے اس کو زیادہ فوکس کیا ہے ریسرچ کے حوالے سے. تو آپ یہ دیکھیے گا کہ اس پروگرام کی ڈیولپمنٹ میں اس پارٹنرشپ کی کتنی اہمیت ہے. اچھا اب بات یہاں ختم تو نہیں کرنی چاہیے, بات تو یہ ہے کہ پھر اس کو ایک ایکٹیو کریکلم کے طور پر لینا چاہیے, کیونکہ تمام انڈر گریڈ کے اسٹوڈنٹس جو کسی بھی طرح کی ایجوکیشن میں ہیں وہ ان کو ایکسپیرینس کرنا چاہیے لرننگ تھرو اینڈ اباؤٹ ریسرچ اینڈ انکوائری. سچ کریکولر ایکسپیرینس شوڈ and can be mainstream for all or many students through a research active curriculum. اور engaging students in research بہت important ہے. engaging students in research کے بارے میں بہت بات ہوتی ہے, لیکن کیسے؟ آپ سکھائیں گے نہیں, آپ بتائیں گے نہیں, آپ کرنے کو کہیں گے نہیں, تو کیسے ہوگا؟ So what we did کہ ہم نے کہا یہ ساری چیزیں تو چل رہی ہیں, آپ کلینکل ایئرز میں جیسے میڈیسن, سرجری, گائنی آپس, باقی تمام چیزوں کی روٹیشنز ہوتی ہیں, why not start a rotation in research؟ اور جب آپ ریسرچ کی روٹیشن سٹارٹ کرتے ہیں اور آپ لوگوں کو کہتے ہیں, اور ہم تھرڈ ایئر میں کرتے ہیں یہ, اور اس کو مینڈیٹری کہا جاتا ہے, جس کے بعد اسیسمنٹ ہوتی ہے, جس کے بعد سکورز جو انٹرنل اسیسمنٹ کا حصہ بنتے ہیں, تو آپ یاد رکھیے ہمارے اسٹوڈنٹس بہت زیادہ آبجیکٹو ہو گئے ہیں, اور ان کو پتہ لگتا ہے کہ جس چیز کی بعد میں اسیسمنٹ کے حوالے سے ویلیو ہے وہ اس کو زیادہ اہمیت دیتے ہیں اور وہ اس کو کرنے کی کوشش کرتے ہیں. اور یہ وہ طریقہ ہے جس کو آپ انسینٹیوائز کر کے پروگرام کا حصہ بنا کے اپنے کریکولم میں انگرین کر لیتے ہیں. سو دیٹ از واٹ وی ہیو بین ڈوئنگ. اور پھر ہم نے اس کو اس ماڈل کے تحت اپنے سسٹم میں انگرین کیا ہے, جس کے اندر آپ ریسرچ کانٹینٹ پہ اور ریسرچ پروسیس دونوں پہ فوکس کرتے ہیں, ریسرچ ٹیوٹرنگ کرتے ہیں, ریسرچ بیس طریقے سے چلتے ہیں, پھر ان کو ریسرچ لیڈ کرواتے ہیں, اور ساتھ ہی ریسرچ کی اورینٹیشن دیتے ہیں. سو یہ وہ ماڈل ہے جس کی بنیاد پہ ہم آگے چلتے ہیں, اور اسی کو آپ دونوں طریقوں سے اسٹوڈنٹ لیڈ اور اسٹاف لیڈ کے طریقے سے پرسوئنگ, آتھرنگ, آئیڈینٹیفائنگ اینڈ پروڈیوسنگ کے حوالے سے دیکھتے ہیں. So that is something that we have been doing. اچھا اب وے فارورڈ کیا ہے؟ ہمارے نزدیک وے فارورڈ یہ ہے کہ جتنا زیادہ ایجوکیشن اور ٹریننگ ہوگی اتنا ہی فائدہ ہے, جتنا زیادہ کام پہ توجہ ہوگی اتنا ہی زیادہ اس کو اچھے طریقے سے اور ایتھکس کے اصولوں کے مطابق کرنے پہ توجہ ہونی چاہیے, اور انوالومنٹ آف سپروائزرس کو اتنا ہی اہم رول حاصل ہے کہ اگر وہ انٹرسٹڈ نہیں رہیں گے, اگر وہ انوالو نہیں رہیں گے تو بات آگے نہیں بڑھے گی. اور پھر آخر میں ہمیں صرف پبلیکیشن پہ نہیں بلکہ اس پروسیس پہ فوکس کرنے کی ضرورت ہوگی. سو ہمارے نزدیک اس ساری چیز کا لب لباب اور وے فارورڈ یہی ہوگا. اچھا کچھ ایشوز بھی ہوں گے مینٹورشپ کے, میں بس 2 سلائیڈز میں وہ آپ سے ڈسکس کر لیتا ہوں. 2 ہی بڑے ایشوز کو دیکھا جاتا ہے, بیریئرز ٹو رننگ اے گریٹ مینٹورشپ پروگرام اینڈ چیلنجز فار مینٹورز اینڈ مینٹیز. بیریئرز کیا ہے؟ یہ تمام بیریئرز ہیں, 4 چیزیں میں نے لکھی ہیں. انسٹیٹیوشن سے بائی ان کبھی کبھی نہیں ملتا, اس کی لیڈرشپ آپ کو پیچھے دھکیل رہی ہوتی ہے. سم ون ڈیڈیکیٹڈ ٹو مینیجنگ اے پروگرام نہیں ہوتا. ہمارے ہاں ایک کامن کانسیپٹ ہے, اچھا یہ شخص کر رہا ہے اس کو یہ ذمہ داری بھی دے دو. سو کبھی کبھی وہ بہت ساری ذمہ داریاں لیتے ہوئے کام پیچھے رہ جاتا ہے. ظاہر ہے آپ اس کو 10 کام دیں گے تو اسے کس کس کا پوچھیں گے. سو ڈیڈیکیٹڈ لوگوں کی بہت زیادہ ضرورت ہے جو اس پروگرام کو مینیج کریں, اور فائنڈنگ دا رائٹ بیلنس آف مینٹیز اینڈ مینٹورز اینڈ پیئرنگ مینٹورز اینڈ مینٹیز, دس از امپورٹنٹ. However, on the other hand, the challenges for mentors and mentees include getting a relevant match, knowing what to discuss, understanding where support is needed, and communicating effectively with one another, and committing to the mentorship relationship. This is very important. لیکن جو سب سے important ہے وہ یہ ہے کہ there is still an elephant in the room where we see exploitation in this relationship, and I'm not going into details, but I just thought to mention کہ جہاں یہ کام ہو بھی رہا ہے وہاں احتیاط کی بہت زیادہ ضرورت ہے تاکہ کسی بھی قسم کے ایکسپلائٹیشن سے بچا جا سکے. اور میری لاسٹ مینٹورنگ ٹپس یہ ہوں گی, کلیئر ایکسپیکٹیشن بنانے کی ضرورت ہے, میکنگ دا اسٹیپس آف ریسرچ پروسیس ایکسپلسٹ, ٹیچنگ اسٹوڈنٹس ریزیلینس, incorporating routine checks for understanding, fostering increasing independence, and address professional development to go forward. Because اگر ایسا نہیں کریں گے تو ہو سکتا ہے کسی ایسے طریقے سے بھی وہ آپ کا تھینک یو ادا کریں آپ کے مینٹیز. تو آپ یہ نہیں چاہیں گے کہ ایسے طریقے سے آپ کے مینٹیز آپ کا شکریہ ادا کریں, تو آپ کو بھی ایسے سے بچنے کی ضرورت ہے اور ان کو کیریکٹر بلڈنگ کی طرف لے کے جانے کی ضرورت ہے, بیکاز کیریکٹر از ڈیسٹنی. And food for thought is, can we have continuous mentorship program that do not end with the completion of an education program? Can we have that? This is my food for thought for you. Thank you very much. If there is any question, I'll be happy to answer.
Thank you very much, sir. We shall now proceed to the shield distribution ceremony to honor the meritorious speakers and the panelists for their work and presence here today. To do the honors, I would request Professor Dr. Ikramdeen Ujjan, Vice Chancellor, LUMHS, and the patron of the summit to please come up on the stage. Sir, please. The first speaker that I would like to invite to receive the shield is Dr. Abdul Manan Beg. I would request Professor Dr. Irfan to please come up on the stage to receive his shield. I would request Dr. Shahid Qureshi to please come up on the stage. I would now request Professor Dr. Anila Ataur Rahman. Madam, please come up on the stage. I would now request the worthy Vice Chancellor to please present the shield to the panelist, Professor Zaman Sheikh Saab. I would now request Professor Dr. Hussain Baksh Kulachi to please receive your shield. I would request Professor Dr. Munawar Alam Ansari to please receive his shield from the worthy Vice Chancellor. Thank you, respected sirs. With this, we come to conclusion of the second plenary session of today's summit. We are about to start with the concluding ceremony of International Academics and Research Summit, and I would request all the participants to please be seated. To remain seated, we will start the concluding ceremony within 5 minutes. Thank you.
Dear distinguished guests, honorable invitees, and ladies and gentlemen, Assalamu alaikum and good afternoon to you all. It gives us immense pleasure to welcome you all at the concluding ceremony of the International Academics and Research Summit 2022, organized by the Liaquat University of Medical and Health Sciences, Jamshoro. Ladies and gentlemen, the International Academics and Research Summit 2022 stayed committed to enhancing scientific knowledge and delivering an enriching experience to the delegates. The conference brought together not only national and international experts to discuss ways to achieve the Sustainable Development Goals, but also ways to integrate the goals with special emphasis on good healthcare delivery. We are extremely honored to have with us today an elite panel of guests from across the country and around the world. We also have with us today prominent and notable experts in health, education, and research who have shared their expertise with us over the 3 eventful days of this summit in the form of scholarly, keynote, and thematic lectures. On behalf of the organizers and collaborators, we would like to extend a heartfelt gratitude to all the dignitaries who spent the 3 days with us. To formally start the proceedings of the concluding ceremony, I request the Chairman and Secretary Organizing Committee to escort the patron of the summit, our worthy Vice Chancellor, Liaquat University of Medical and Health Sciences, Professor Dr. Ikramdeen Ujjan, and the esteemed guests of honor and our most celebrated guests to be seated on stage. I would request our guests of honor, Dr. Simi Jamali, Dr. Hakim Ali Abro, and Dr. Muhammad Juman Bahuto to please be seated on stage. I request our worthy deans to please join the guests on stage. I request our worthy deans, Professor Ashok Narsani and Professor Feroz Ali Kulhoro, to please join us on stage. To formally commence this auspicious occasion, I would request the Honorable Professor Dr. Moin Ahmed Ansari, the Dean Faculty of Medicine and Allied, and Chairman Organizing Committee to kindly come and deliver his address.
Bismillah ar-Rahman ar-Rahim. It's a great honor, it's a great pleasure that we have now come to this stage of this conference, this point in the conference where I am welcoming you for this concluding ceremony of the great scientific event that we had. हमने कोशिश तो की यहाँ maximally ऐसे specific topics discuss किए जाएं जो इससे पहले यहाँ शायद ना हुए हों. Particularly आपने खुद ही देखा कि कुछ ऐसे topics थे जो कि बहुत ज़रूरत थी उन गोल्स को अचीव करने के लिए जिसके लिए ये यूनिवर्सिटी मेंट है, जो चिराग यहाँ जल रहा है इतने सालों से, पिछले कई सालों से, लेकिन आप देखें कि पिछले 1 साल में ये सफ़र तेज़ी की तरफ बढ़ रहा है और तेज़ हुआ है, इसकी रफ्तार तेज़ हो रही है. और अब ये इवेंट विल बी ए लैंडमार्क इन द हिस्ट्री ऑफ LUMHS, in the history of scientific achievements of the LUMHS. And I hope that in future the LUMHS will be an institution that will glow around the world and will produce the world academic leaders in the medical field. I hope that you must have enjoyed not only the rich scientific sessions that we got here, but also enjoyed socializing with learning people, learning experts in the medical field, और उनके साथ डायरेक्ट गुफ्तगू करने में जो जैसे बताया ना कि सिर्फ पढ़ने से, सिर्फ सुनने से, सिर्फ कोर नॉलेज से हम वो सब कुछ हासिल नहीं कर सकते. जब तक हम उनसे इंटरेक्ट करें तो वो जो एक जिसको हम देख नहीं सकते, जिसको हम फील नहीं कर सकते, जो इनविजिबल जो ट्रांसफ़र होता है अप्रोचेस का, कॉन्सेप्ट्स का, जो इनविजिबल ट्रांसफ़र होता है, जिसको हम एम्पैथी कहते हैं, एम्पैथाइज करते हैं, जो एक लर्नड आदमी के साथ बैठ के खुद अपने अंदर जो चेंजेस फील करते हैं, वो एक बहुत इम्पॉर्टेंट कंपोनेंट होता है लर्निंग का। तो मुझे उम्मीद है कि आप लोगों ने इसको एंजॉय किया होगा। मुझे खुशी है, अल्हम्दुलिल्लाह द इवेंट वेंट सो गुड। और अब मेरे ख्याल से उसकी थोड़ी सी डिटेल्स जो दैट हाउ वी डिड आवर जर्नी फ्रॉम द कॉन्सेप्ट दैट वी स्टार्टेड दिस आइडिया ऑफ हैविंग ए कॉन्फ्रेंस हियर और आज तक का जो सफ़र है उसको मैं चाहूँगा कि probably Madam Rahil will present to you. Thank you.
The past 3 days offered many opportunities for learning and collaborations. To sum it up, I request the member core organizing committee, Professor Dr. Munawwar Alam Ansari, Dean Faculty of Basic Medical Sciences, to present a comprehensive summit report.
Honorable Vice Chancellor, Professor Dr. Ikramdeen Ujan, Dr. Simi Jamali, the most dynamic lady and ex-director, Jinnah Postgraduate Medical Center, Professor Dr. Hakim Ali Abro, the Vice Chancellor, Shahid Mohtarma Benazir Bhutto University, Larkana, and Dr. Juman Bahuto Sahab, the Director General Health Services, Hyderabad, faculty members, ladies and gentlemen. As a member of core committee of the International Academics and Research Summit, Liaquat University of Medical and Health Sciences 2022, being organized at LUMHS on 16 to 18 December 2022, and I'm very much pleased to present this summit report before you all. The theme of the summit was the integrating healthcare delivery with sustainable development goals, and it has entailed a highly enriched and diverse scientific program. The pre-summit activities started on the July 6th, 2022, and were initiated with the plantation activities at the Department of the Psychiatry and the Behavioral Sciences, Liaquat University, Jamshoro. The activities continued over 130 days, and being this third day international summit, I'm pleased to share that Liaquat University and all its collaborators together organized an excess of 106 pre-summit activities, including 9 plantation activities, 4 pre-summit short courses, 3 advocacy and awareness programs, and 82 workshops. The 3 International Academic and Research Summit 2022 hosted 11 international speakers, 67 renowned national speakers. The audience benefited from 16 plenary lectures, 29 state-of-art scientific sessions, and 157 scientific papers and digital poster presentations. It is noteworthy that the summit had a young researcher contest upon 2 undergraduate students from the Liaquat University and 36 of its constituent medical colleges. Students from the other universities, such as Aga Khan University, too participated in the undergraduate research symposium. I hope that the summit offered an enriching and fulfilling the experience for you all. Thank you so much for all being here, and your presence made all the difference. Thank you very much.
Thank you so much, sir, for your wise words. I now request our worthy guest of honor, Professor Hakim Ali Abro, a senior academician from Shahid Mohtarma Benazir Bhutto Medical University, to please come forward and say a few words about the summit.
Bismillahirrahmanirrahim. Assalamu alaikum. Respected Dr. Ikram Ujan Sahab, Vice Chancellor LUMHS, Madam, our Madam, our Madam Simi Jamali Saba, Deans, and audience, Assalamu alaikum. First of all, I congratulate the organizing committee for arranging such a wonderful program here. And I was discussing with the Ujjan Saab regarding the attendance at the concluding section, and I said that usually in concluding sessions, halls became vacant. All the attendants leave the hall in the concluding section, but here at the end, I found a lot of attendee here in the last section. So these side of academic coming to like these sessions are very, very important. So for the academics of any university, it has been counted that how many symposia have been arranged, how many workshops, how many things they have been there, and how university is progressing in the research. So I congratulate Professor Ikram Ujjan for such a wonderful this effort, and he was discussing with me before that he have arranged a lot of these symposia and workshops in his 1 year tenure, and I hope he will continue it in the future also. We were discussing also that in the future, we, Shaheed Muhtarama Benazir Bhutto Medical University and LUMHS will join hands in the academics as well as the research in the future and make these institutes of medicine at the top of the universities of Pakistan, inshallah ta'ala. Thank you very much.
Thank you so much, sir, for your very kind words. I now call forward our next respected guest of honor, Dr. Mohammad Juman Bahuto, Director General Health Services Sindh, to come forward and say a few short words.
Bismillahirrahmanirrahim. Honorable Dr. Ikramullah Sahab and all the respectable guests sitting here, and all the professors, team, students, ladies and gentlemen, Assalamu alaikum. This is a great honor to be part of this World Summit regarding the how can we achieve the Sustainable Development Goals. Actually, this is a message by organizing this summit that we have decided to achieve. However, we have consumed half of our time, 7 years in past, and now we have only 8 years to achieve these goals. We have to secure our earth, we have to respect our community, we have to make democratic institutions, and we have to provide the security overall to all institutions. So by organizing this summit, I am very optimistic that we are on the track. At least those who are working in the health department, they are on the track, because we have faced so many challenges. In the COVID pandemic, we have faced the challenge in the cholera, we have faced the challenge in the flood. In the flood, 7.3 million people were displaced, and 12.1 million people of the Sindh were affected. Despite that, health department played a very significant role that now we have no outbreak, we have no any threat, and we are behaving as in a normal. I also remember the mindset, because we have to make our mindsets. Sometimes we say that then we decide that we will not do that work. Problem असां डिसीजन करे था छॾियूं त इहो कमु असां न कंदासीं. असांखे पंहिंजो माइंड सेट चेंज करिणो आहे, ऐं माइंड सेट चेंज करण लाइ मां तव्हांखे हिकिड़ो नंढिड़ो मिसाल ॾींदुसि. उहा आहे त वी वर वेरी इन distress, we were in a very difficult situation during the COVID pandemic, and the one important thing that was we were unable to screen the all population, and at that time in the meeting there was one person who said that asan sab taanke ye testum kare dindasi, and that was Dr. Ikramullah Ujjan. And resultantly jadeh asan decision varto the 9.1 million screening tests were conducted. 9.1 million PCR tests were done, and more than 80% PCR tests were conducted by DR Lab, LUMHS, Karachi and Hyderabad. So this is mindset. तो बाबा असांखे ही करणो आहे त पोइ करणो आहे. ऐं now this summit has announced that we have decided, at least on our part, on the part of the health department, that we will achieve the goals. Although then we will also play our role. छाकाणि जो काफ़ी अहिड़ा प्रॉब्लम्स आहिनि जन जे लाइ असांखे कोशिशि करणी पवंदी, ऐं इहो असां न चऊं त असां न करे सघंदासीं. असां हितां लीडिंग रोल प्ले कंदासीं. जेके असांजा ॿिया डिपार्टमेंट्स आहिनि, असां वी विल राइट द लेटर्स, वी विल इनवाइट देम टू प्ले देयर रोल, एंड वी विल प्ले देयर रोल. थैंक यू सो मच.
Thank you so much, sir, for your words of appreciation. I now call forward our esteemed guest of honor, Dr. Simi Jamali, former Executive Director, JPMC Karachi, to come forward and share her thoughts about the summit.
Assalamu alaikum, everybody. First of all, I'm very humbled to have been called here. I am extremely grateful to the organizers of this conference, and I want to thank the Vice Chancellor, the deans sitting over here, Professor Munawar, Professor Hakim Ali Abro, the Vice Chancellor of CMC, and the other deans. I don't know a lot of names, but and also the Director General Saab. So thank you very much for inviting me here. I worked for JPMC. मैं उर्दू में बात कर लेती हूँ, वो ज़्यादा अच्छा होगा, कि मैंने जिना अस्पताल में तकरीबन 33 साल अपनी ज़िंदगी के गुजारे हैं, और उस 33 साल में मैंने दुनिया की हर चीज़ ही देख ली, और मैं समझती हूँ कि ये अल्लाह ताला की तरफ से था. इट वाज अ ब्लेसिंग कि आई वर्कड ओवर देयर एंड आई अचीव्ड व्हाट आई कुड हैव नेवर अचीव्ड इन माय लाइफ. 33 साल ज़िंदगी के जब आप गुजार देते हैं ना किसी चीज़ में, तो वो लगता है कि वही आपका घर है. अपना घर बार आदमी भूल जाता है. और उसमें मैंने क्या नहीं देखा, क्या फायरिंग के इंसिडेंट्स नहीं देखे. ये आयरन लेडी जो मुझे लिखा है ना, अब आयरन लेडी तो मुझे अब छोटी सी बात रह गई है. बम धमाके देखे, ग्रेनेड अटैक्स देखे, ग्रेनेड सामने देखे. मैंने कभी ज़िंदगी में ग्रेनेड्स नहीं देखे थे, लेकिन हमने वो ग्रेनेड्स भी देख लिए. क्लैशनकोफ से फायरिंग हुई मेरे सामने, मेरी आंखों के सामने हुआ, और मैंने वो भी देखा. It's impossible to narrate the stories that we have seen. कोविड आया, बहुत अच्छी बात की इन्होंने कि कोविड को पाकिस्तान ने जिस तरह संभाला है, मेरे ख़्याल से दुनिया के किसी मुल्क ने उतना अच्छा नहीं संभाला पाकिस्तान के अलावा जितना कोविड यहाँ पर संभला. फिर उसके बाद कोविड के हमने 2 वार्ड्स बनाए थे. एक पहले 90 बेड्स का वार्ड बनाया, और फिर 175 बेड्स का एक और वार्ड बनाया. And it was fully ventilated. The health secretary of that time, Mr. Kazim Jotoi, was extremely good. Wonderful man. He got us all what we wanted, the ventilators, the BiPAPs, and a lot of donations came in to the hospital from the common people. कराची एक ऐसा शहर है जहाँ पर हर आदमी जो है बड़ी खुशी खुशी चीज़ें अगर देखता है कि सही तरह आप इस्तेमाल करें, तो वो बहुत सारे philanthropists आगे आ जाते हैं. I'm extremely happy to hear the talk of Dr. Irfan today. I'm so sorry that I heard COVID in the last bit, and I heard Dr. Irfan. Wonderful talk. I must congratulate you because your concept, your mind, your thinking was so clear, crisp and clear. हम लोग स्टूडेंट्स को वाकई मौका ही नहीं देते कि वो कुछ सवाल जवाब करें. जैसे ही कोई सवाल जवाब करने की कोशिश करता है, उसको चुप करके बैठा देते हैं कि चुप करो, तुम ये बदतमीज़ी नहीं करो, मत ज़्यादा बात करो. और आजकल के स्टूडेंट्स वैसे भी सवाल जवाब ज़्यादा नहीं करते. मैंने तो कम से कम ये देखा, पूछते ही नहीं है. जो है रटाफिकेशन से याद कर लेते हैं. रटाफिकेशन अब नहीं चल सकता. You have to ask questions, and we have to answer those questions. If you don't do that, there is no interaction between you and the rest of the faculty or the mentors, and the mentees will have no relationship. तो ये बात तो आपको करनी चाहिए. एंड ज़िंदगी में अपने हमेशा एक गोल रखना चाहिए. हम सब जो है ना बिल्कुल एमलेसली चलते रहते हैं. अब मैं भी शुरू में एमलेसली चलती रही, लेकिन फिर मैंने अपनी ज़िंदगी का एक मकसद बना लिया, اور وہ مقصد یہ تھا to help the poor, to help the needy and to help the patients. My primary duty was to help the patients and I think I did my job well. میرا آج دل بڑا پرسکون ہے کہ میں نے جہاں پر کام کیا وہاں اتنا دل لگا کے کام کیا کہ کوئی میرا خیال سے اس کو میں نے اپنے گھر کی طرح سمجھا. It was a passion of love. It was not a نوکری. So I think آج کل کے ڈاکٹرز جو ہیں ان کا کمپیشن لیول شاید ان کو کمپیشن فٹیگ ہو گئی ہے لیکن کمپیشن فٹیگ نہیں کرنی چاہیے. آئی تھنک وی شوڈ آل بی ویری کمپیشنیٹ ٹورڈز ڈاکٹرز. ٹورڈز آئی وانٹ ٹو ٹیل یو دس لاسٹ بٹ آف اسٹوری آف مائی لائف. میں مرتے مرتے کئی دفعہ بچی ہوں ہسپتال میں بھی. جب اٹیکس ہوئے, جب بم بلاسٹ ہو گیا, میں خود اس میں آئی واز hit over. There's so many people who would be eyewitness to the fact, and there is a video in which we were all injured. But then and the last bit what happened during COVID was that I was suddenly, there was a airplane crash in Karachi. اور آپ سب نے دیکھا ہوگا شاید ٹی وی پہ, جو کراچی میں تھے ان لوگوں نے سنا بھی ہوگا, دیکھا بھی ہوگا کہ ایک جہاز ماڈل کالونی کے اندر گرا تھا جس میں کہ 2 لوگ پتہ نہیں کیسے معجزتاً وہ بچ گئے تھے. ایک بینک آف پنجاب کے پریزیڈنٹ تھے شاید, اور ایک کوئی اور کامن سویلین تھے. تو اس رات کو سارے لوگ اس جہاز میں انفارچونیٹلی, اور ہوتا بھی یہی ہے کہ انتقال کر گئے فار بیکاز دا کریش واز لائک اینڈ دین دا پلین کاٹ فائر. سو اٹ واز اے کریش اینڈ obviously وی ڈنٹ ایون ایکسپیکٹ کہ یہ دونوں لوگ بچ جائیں گے. ایک شاید کھڑکی میں سے فلائی کر کے کسی کی چھت پہ گر گئے. اینڈ کین یو امیجن, جس کی گھر کی چھت پہ گرے یہ تو بچ گئے, لیکن ان کے گھر کی 2 ماسیاں جو تھیں جو کام کر رہی تھیں وہ انتقال کر گئیں. دے ہیڈ برن انجریز اینڈ بوتھ آف دیم ڈائڈ. سو اٹ واز سو انفارچونیٹ فار ایوری بڈی کہ یہ واقعہ ہوا. اس رات کو جب یہ سارا کچھ ہو گیا, رمضان کا مہینہ تھا, 2 دن بعد عید تھی. سو آئی سڈنلی ہیڈ ایکسپیرئنس سیویئر ایبڈومینل پین. تو ہم ڈاکٹرز اپنی پرواہ تو کبھی کرتے ہی نہیں ہیں. تو I thought I should go to the CT scanner and get a scan. پتہ نہیں میرے دماغ میں it was such a severe pain that I thought I should go there. تو میں چلے گئی CT scan میں, اور وہاں پر جب ہم نے اسکین کیا تو there was blockage in my right near my right iliac fossa which was close to the cecum. And 2 days later I was operated to find out that I had CA colon, which was it struck me, but I behaved very normally. میں نے کبھی, اسی لیے شاید آئرن لیڈی ویڈی کہتے ہوں گے کہ میں نے بالکل وہ نہیں کیا کہ مجھے جیسے کوئی صدمہ لگ گیا ہو کہ جی او کینسر نہ ہو کینسر. لیکن ہمارے یہاں ایک انفارچونیٹ بات جو ہے, میں ڈاکٹرز کو اسی لیے کہتی ہوں کہ کمپیشن جو ہے بہت ضروری ہے آپ کے لیے, کیونکہ اگر کمپیشن نہیں ہوگا, جو بھی کہے اچھا اب بہت کامن سی بات ہے کہ آپ سی اے کولن کرتے رہیں, یا کینسر ہو گیا, او ہو شی از گاٹ کینسر, اوکے. I've survived 3 years now. I've been fighting the war of cancer for 3 years. 6 times I've undergone chemotherapy. I've gone through radiotherapy. I've gone through 6 times under chemotherapy. You can imagine. And also immunotherapy. تو آپ سوچ سکتے ہوں گے کہ میرا اندر سے میرے دل کا کیا حال ہوگا. لیکن میں آج آپ کے سامنے بڑی بہادری سے کھڑی ہوں. And I'm still doing the work that I need to do. Because I'm not going to let this... میں اس کو جانے نہیں دوں گی جب تک آخری دم تک ہم لڑ سکیں گے. میں نے سوچا کہ ویل فائٹ اٹ. اس سلسلے میں میں نے جو راہ میں دیکھا, بہت ساری چیزیں ہوئیں جو ہمارے ڈاکٹرز کو کیونکہ ہم ڈاکٹرز ہوتے ہیں نا, ہم پرلی طرف بیٹھے ہوئے ہوتے ہیں ٹیبل کے, تو ہمیں سمجھ نہیں آتا کہ ہم نے کیا کرنا ہے پیشنٹ کے ساتھ. دوائیاں لکھیں, کیمو تھراپی لکھیں, یہ لو جی پرچہ لو, تو جاؤ اس بلڈنگ میں جاؤ, اس بلڈنگ میں جاؤ, اور وہ آپ کو نرسز لگا دیں گے. بٹ کمپیشن ایک چیز ہوتی ہے, وہ ہمارے یہاں بڑی لیک کرتی ہے. کیمو تھراپی سے آدمی کے بال گر جاتے ہیں, کچھ اور اتنی ساری چیزیں ہوتی ہیں. جو ابھی میں ٹرپ کیا تھا, I didn't expect to trip here. I didn't expect it at all because I have been very normal. I just, the stair was like, it was the tallest stair for me, so I tripped in there. But normally I am doing everything that needs to be done. سو ڈاکٹرز کو کبھی میں نے کبھی بولا نا ڈاکٹرز کو کہ جی میرے بال گر رہے ہیں تو میں کیا کروں, تو کوئی جواب مجھے کبھی نہیں ملا. कोई कंपैशन नहीं नज़र आया कि वो तो सबके गिर जाते हैं तो क्या फ़र्क पड़ता है, मगर दिस हिट्स यू, दिस हर्ट्स यू। एंड अगर वो कंपैशनेटली जवाब दें मुझे, या मेरे जैसे और 1000 पेशेंट्स होंगे, मैं तो एक स्पेशल पेशेंट थी, लेकिन मेरे जैसे 1000 आम पेशेंट्स होते हैं जो प्यार से आके पूछते हैं कि डॉक्टर साहब अब हम क्या करें, तो जवाब मिलता है ये तो सबके ही हो जाता है। भाई आप कुछ करें तो सही, आप अगर इंग्लैंड अमेरिका में हों या किसी और वेस्टर्न कंट्री में हो तो आपके साथ लोग बहुत अच्छा सलूक करेंगे। दे विल बी कंपैशनेट, दे विल गिव यू देयर सीट, दे विल गिव यू स्पेशल डिस्काउंट्स as you're a cancer patient. This is what happens. But then it doesn't happen in Pakistan. And this is unfortunate. So if you have a cancer department over here, I think this is something, a moral story that I'm telling you from my life, कि बहुत ही आपको compassionate होने की ज़रूरत है। जो कुछ भी हो पेशेंट के साथ अच्छा सलूक करना चाहिए। दिस इज़ द की वर्ड, बिकॉज डॉक्टर्स बने तो हम सब डॉक्टर्स बन गए, लेकिन हमारे इस दिल के अंदर जो हाल है वो वैसा नहीं है जो होना चाहिए। और मेरा ख़्याल में हर एक को थोड़ा दिल में नरमी कर लेनी चाहिए उन लोगों के लिए, फ्रॉम द हैव्स एंड हैव नॉट्स। I want to thank you all, the organizers, the Vice Chancellor of this university, the Vice Chancellor sitting here, the DG Health, all the people, especially somebody who spoke about COVID, because I'm one person who never got COVID until date, alhamdulillah. So, but I have treated several hundred patients of COVID, but I never got COVID. And I'm so grateful to Allah Mian for this, despite being immune compromised, I got away from COVID. And I want to thank you all, Dr. Raheel, everybody who sits here, all my colleagues, all my juniors, all my seniors, everybody, कि आपने मुझे ये इज़्ज़त दी कि आपने मुझे इधर बुलाया, और मैं बहुत शुक्रगुजार हूँ। थैंक यू वेरी मच।
Thank you very much, ma'am, for your brave words. The International Academics and Research Summit hope to sensitize the scientific and healthcare community regarding integration of healthcare delivery with sustainable development goals. After thorough deliberations, the summit and we all propose the adoption of certain resolutions. I request our core organizing committee member, Dean Faculty of Surgery and Allied, Professor Dr. Ashok Narsani, to please come forward and present the summit resolution.
Thank you. Honorable Vice Chancellor, Professor Ikramuddin Ujan Sahab, our respectable guest of honor, Dr. Simi Jamali, Professor Hakamuddin Abdo, Dr. Juman Bahupato, my dear deans and eminent speakers from the national and international sides and delegates, good afternoon. The 3 eventful days of the International Academic and Research Summit 2022 concluded today, and I am immensely proud to be awarded the opportunity to present the resolution we adopt after much deliberations with the scientific committee and relevant experts. The many scholarly talks and thematic lectures too served as a source of much guidance and helped shape the resolution. We, the team of International Academic and Research Summit, take this resolve to do our best to meet the 2030 agenda and to formulate a plan of action for people, planet, and prosperity. We recognize that eradicating poverty in all its forms and dimensions, including extreme poverty, is the greatest global challenge and an indispensable requirement for the sustainable development. All the countries and all the stakeholders acting in collaborative partnership should work today, freeing the human race from the tyranny of the poverty. We express our resolve to take the bold and transformative steps which are urgently needed to shift the world onto sustainable and resilient path. As we embark on this collective journey, we plead that no one will be left behind. The 17 Sustainable Development Goals and 169 targets seeks to realize the human rights of all and to achieve gender equality and the empowerment of all women and girls. We must stress that the goals are integrated and indivisible and balance the three dimensions of sustainable development: economical, social, and environmental. We are determined to protect the planet from degradation, including through sustainable consumption and production. Sustainability, managing in its natural resources, and take urgent action on climate change so that it can be support the need of the present and future generations. We plan to use more sustainable sources to fulfill the energy needs of the academic campus and the hospitals. We are determined to mobilize the means required to implement this agenda through a revitalized global partnership for the sustainable development. Based on a spirit of the strengthened global solidarity, focused in the particular on the needs of the poorest and most vulnerable, and with the participation of all the countries, all the stakeholders, and all the peoples. The interlinkages and integrated nature of the Sustainable Development Goals are of crucial importance in the ensuring that purpose of the 2030 Agenda. If we realize our ambitions across the full extent of the agenda, the lives of all will be profoundly improved and our world will be transformed for the better. Thank you very much.
Thank you, sir. Ladies and gentlemen, keeping true to the academic spirit of the International Academics and Research Summit 2022, we organized an undergraduate research symposium wherein students from Aga Khan University, Bitai Dental Medical College, Bilawal Medical College, College of Pharmacy, and Liaquat University of Medical and Health Sciences competed for the Young Researcher Award. To present the meritorious winners with their prizes, I would request the worthy Vice Chancellor to kindly come forward to the center of the stage. I would request the Vice Chancellor to come to the center of the stage to award the students with their respective prizes. The second runner-up for the Young Researcher Award are Ms. Hira and Ms. Noreen Sheikh. Ms. Hira and Ms. Noreen, please come forward and receive your award. Ms. Hira and Ms. Noreen Sheikh are being awarded 25,000 rupees. The first runner-up for the Young Researcher Award and the recipient of 15,000 rupees is Mr. Momin Khan. Mr. Momin Khan, please come forward and collect your prize. And the winner for the Young Researcher Award and the recipient is Mr. Muhammad Rayan. Mr. Muhammad Rayan is the winner for the Young Researcher Award. Liaquat University has a rich tradition of honoring our guests with customary gifts and souvenirs. I request the Chairman and Secretary Organizing Committee to escort the worthy Vice Chancellor to the center of the stage to decorate our honorable guests. I now request our guest of honor, Professor Hakim Ali Abro, to please come forward and receive his souvenir. Hakim Ali Abro. I now request the Honorable Dr. Mohammad Juman Bahuto to please come forward and receive his souvenir from the worthy Vice Chancellor. I now request our guest of honor, Dr. Simi Jamali, to receive a token of our love and regard. Dr. Moin. This event would not have been possible without the wise and able leadership of our worthy Vice Chancellor, Professor Dr. Ikram Deen Ujjan. On behalf of us all, I request our guests of honor to together present Professor Dr. Ikram Deen Ujjan with a special memento. I would request all of guests of honors to come forward and present our Vice Chancellor with a special memento. Every leader needs a dedicated team to help make his vision a reality. The organizing committee together work to make this summit a success. I will now call on the members of the organizing committee to one by one come forward and receive their souvenirs. I start by inviting Professor Dr. Moin Ahmed Ansari, the Chairman Organizing Committee, to come forward and receive his souvenir. I now request Professor Dr. Ashok Kumar Narsani, Member Core Committee, to please come forward and receive his souvenir. Next, I invite Professor Dr. Feroz Ali Kalhoro to please come forward and collect his souvenir. I now request the respected Professor Dr. Munawar Alam Ansari to come forward and collect his souvenir. I now request our beloved Professor Dr. Muzaffar Ali Sheikh to please come forward and receive his souvenir. I request the Secretary Organizing Committee, Professor Dr. Rahil Sikandar, to kindly come on stage and receive her souvenir. I request the Honorable Registrar of Liaquat University, Dr. Haji Mohammad Sheikh, to come on stage and receive his souvenir. I now request the young and very energetic co-secretary of this summit, Dr. Atir Hanif Rajput, to please come forward and receive his souvenir. I now invite Professor Dr. Khalda Naz Memon to come forward and receive her souvenir. Next, I invite Professor Dr. Samreen Memon to please come on stage and receive her souvenir. Next, I invite Mr. Asif Abbasi to please come forward and receive his souvenir. I next invite Professor Dr. Khalid Sheikh to come forward and receive his souvenir. I now invite Professor Dr. Amir Bhatt to please come forward and receive his souvenir from the worthy Vice Chancellor. I now invite Mr. Azhar Akbar Sheikh to please come forward and receive his souvenir. Mr. Azhar Akbar Memon. I now invite Professor Dr. Amreen Munir to please come forward and receive her souvenir. I now invite Professor Dr. Shazia Memon to please come forward and receive her souvenir from the worthy Vice Chancellor. I call upon respected Professor Dr. Mukhtar Jafri to come forward and receive his souvenir. I request Professor Dr. Shoaib Ansari to please come on stage and receive his souvenir. Next, I invite Professor Dr. Iqbal Shah to please come forward and receive his souvenir. I now request Professor Dr. Asadullah Makhdoom to please come forward and receive his souvenir. I request Dr. Mehboob Sanjarani to come forward and receive his souvenir from the worthy Vice Chancellor. Next, I invite Dr. Mehtab Alam to come forward and receive his souvenir. I next invite Professor Dr. Binafsha Manzoor Syed to kindly come forward. Next, I invite Dr. Muhammad Jameel Laghari to come forward and collect his souvenir. I then invite Professor Dr. Shahida Hassan Memon to come forward and collect her souvenir. I invite Professor Dr. Samreen Memon to please come forward and receive her souvenir. I now invite Dr. Muhammad Kashif Sheikh to come forward and receive his souvenir. I request Professor Dr. Nand Lal to please come forward and receive his souvenir. Next, I invite Mr. Mushtaq Bhatti to please come forward and receive his souvenir. I request Mr. Abdul Rahim Sheikh to please come forward and receive his souvenir. I now request Mr. Abdul Rahim Sheikh to please come forward and receive his souvenir. I request Dr. Syed Zulfikar Shah to come forward and receive his souvenir. I request Dr. Yaqub Shahani to come forward and receive his souvenir from the worthy Vice Chancellor. I now request Professor Dr. Pushpa Goswami to please come forward and receive her souvenir. I request Professor Dr. Altaf Talpur to come and receive his souvenir. Dr. Santosh Kumar, I request him to come forward and receive his souvenir. Next, I invite Dr. Abdul Jabbar to come and receive his souvenir. I now invite Dr. Fazila Hashmi, Dr. Jameel Junejo, Dr. Mansoor Ahmed Channa, Dr. Ali Gulab Odho, Mr. Abdul Hamid, Mr. Mateen Haider, Mr. Ijaz Ali Hakro, Mr. Mohammad Misri, Mr. Shehzad Pirzada, Mr. Musawwir Channad, Mr. Muhammad Bachal, Mr. Christopher, Mr. Mansoor Ali, and Mr. Imdad Ali Khushk. I now invite Ms. Iman Tareen. I request Mr. Najib Abbasi to come forward and receive his souvenir. Mr. Najib Abbasi. Thank you, sir. You may now be seated. I now request Professor Dr. Feroz Ali Kalhoro to come forward on stage and deliver a vote of thanks on behalf of the organizing committee.
Thank you for asking me to say the vote of thanks. On behalf of Liaquat University of Medical and Health Sciences, Jamshoro, and on behalf of the entire organizing committee of this International Academic and Research Summit, I extend my hearty vote of thanks and sincere gratitude to all the international and national speakers of this summit who have contributed their research, their scientific thoughts in this summit. And I am also thankful to all the guests, the delegates who grace this, their valued presence in this summit. And as you know, this is the huge academic event, and organizing such an event is not an easy job. It takes a lot of efforts, and just preparation started a few months back. So I also congratulate and thanks to the organizing committee under the leadership of Professor Muin Ansari for organizing such a wonderful and successful event. And I am thankful to our worthy Vice Chancellor, the dynamic leadership, this support and guidance. We have successfully organized this summit. And within this short period of, we have, I think this is the 4th consecutive national international conference which we have organized in very short span and within this few couple of months. And I am also thankful to the other bodies, advisory bodies and regulating bodies, like the special thanks to Dr. Sarah Salman of WHO, Dr. Sitara Hassan of PMC, Dr. Jumman of Government, Sindh Government Health Department. And I am also thankful to all the collaborators, supporters, and sponsor, who have sponsored this, event, and special thanks to the media and our media, the FM radio, LUMS FM radio, LUMS FM TV, all, and a special thanks to the registrar of this university, Dr. Haji Muhammad Sheikh, for all the logistic support and all the, this organizing such a wonderful event. So thank you so much, ladies and gentlemen.
Thank you so much, sir. Your words mean a lot to us. This brings us to the end of the concluding ceremony for the International Academics and Research Summit 2022. Thank you and Allah Hafiz. Lunch is served in the marquee in the grounds. Thank you all.